मैं দুই নাহাতি
তোমার এই পাঁচটাই হবে তারপর হিপারনিয়ন করো সিস্টেমিয়ন করো না এমনি করো দুই দুইটা মেনু দিলে কাম চলছে জানাবো আগে মানতে পারতেছ না ঠিক আছে খাও ঠিক বল এটা তুমি কি ভাই তোমার উপর তলে মিলে যাবে যে মালটা মন্ত্রীগুলো গাড়ি যে মালটা তুমি করবেন
लाइव
अलग अलग এইটা ফাইনাল করবে ভাই দিটা হ্যাঁ চলবে
प्रोसीजर पर्सन लाइव जीवन पहले लाइव एंडो आदि बंद कर
যেটা দিয়ে এটা করতে চিন্তা নিতে এইটা তো হয়ে যাবে ভালো 3 তারিখ হয়ে যাবে বাবা নাহলে 2 তারিখ আগে করতে পারবে हाँ
সেটা তো অপশনাল রয়েছে পয়লা তো লাগবে এরকম কি হয়েছে একটা ট্যুর এটা আচ্ছা ট্যুর হ্যাঁ ট্যুর
प्रेजेंटेशन शुरू कराओ और उधर अंदर कैमरामैन हो उनको बोलो सर मोटी वन से जहाँ रेडी हो गया देखो एक पेशेंट स्टेटस ना देखो अरे मनोज सर को बुला हाँ करवा दो लाइव है उधर कैमरा मैन को बोलो और मनोज जी चल नहीं बात हो गया खुद करके बोलिए बात पसंद पसंद बोला तो सर डेमो ये कर रहा है वो ओटी नहीं ये दो में से नॉट ओटी 3 ओटी 1 एंड ओटी 2 एक ऐसे तो दीदा ही सभी मनोज सर का है बोलो सर शुरू कर रहे हैं आज बुलाओ वहाँ यहाँ जरूरत है ना उनको बोलो सर इधर आओ यहाँ शुरू कर
हाँ हाँ सर हेलो हेलो हेलो
हेलो हेलो ऐसा बात करें संबित सर हेलो संबित सर कैन यू हियर मी हेलो
हेलो
सर वेव योर हैंड
थोड़ा दिखाएंगे मुझे क्या चल रहा है मुझे समझ
सर
नहीं
वॉइस इज क्लियर
yes yes voice is clear
sir we are about to start our live transmission from here. Dr. Vivek will be presenting the first case details soon.
just wait for a couple of minutes yeah Abhay we'll just wait
शेयर
for
करना है
when are they ready I think I can see that spinal is getting ready on one side so how
नहीं,
long
for the
yeah hello Abhay
ये कौन बोला एक बार कोई
मनोज सर के खड़ा हो मनोज सर को कैमरा
स्क्रीन शेयर नहीं हुआ OT2 स्क्रीन शेयर नहीं हुआ स्क्रीन शेयर नहीं हो रहा है शायद OT2 इधर से स्टार्ट करना है कुछ OT2 एम्प्टी दिखा रहा है ना उससे नहीं आ रहा उधर स्क्रीन है ना स्क्रीन शेयर भी स्टार्टेड है उधर नहीं आ रहा एक बार आके देखेंगे अच्छा अभी नहीं हाँ मैं रेडी हूँ के पास क्या है ले लीजिए ये तो मॉस्टरलेटर है ना
हाँ तो नहीं है मॉइस्चराइजर से यूज करें
इधर देखिए
Usually, you have 1.5 centimeters distal to the waist leg. Implant plate. Because the implant is having three components. For example, this is the capsule. So there is a capsular chain. And there is a universal binding. Now this capsular chain is 13 millimeters. And the dimension of the is 8 millimeters.
Good morning, everyone. On behalf of the Functional and Female Urology Section, Urological Society of India, and Urology and Urology Academy Forum, I welcome all of you to speak on this workshop on the technical content of the Functional and Female Urology. So we have got a number of cases lined up today. We will be starting our transmission soon. As you can see on the screen, the anesthetists are giving anesthesia. The OT team is ready. The surgeons are ready. Program is start, and I'll hand over the mic to Dr. Sambit, who is going to be the MC for the program for the next 3 days to take it over and take us through the academic extravaganza. Okay, Dr. Sambit.
Good morning. Simultaneously adding
कैमरा कोई नहीं है
OTs.
कैमरा कोई नहीं
One, internal delay will be performed by Dr. Sarnit Mandi, professor for our own institute. Another OT2, we have Dr. Arup Nath with chairman, head of urology from performing to. For the first session, I would like to invite the chairpersons. Susan Das, senior consultant at IMS Hospital. DMS, senior consultant English Ramaya Memorial Hospital, Bengaluru. Shiv Charan Navaria, professor at Kanpur. Dr. Pavitra Mishra, senior consultant at Hospital Bhubaneswar. Dr. Professor at IMS Chandigarh. Hello, Vivek, can you hear me? Dr. Vivek?
There, then you have to turn it like this. This is well, kind of,
Dr. Sambit?
Yes, sir.
Yeah.
माइक लिया हुआ हूँ अभी स्टार्ट
Sir, we're ready with the session. We want the case presentation to begin, sir.
नहीं इधर
So whenever we are in the weather, we do like standard way, then you are trying to.
ये ऑन है ऑडियो ऑन है
Then you now this and then we this as we only it's not be like this or this. Hello. It is like this or this. You can change the angle of the design. Now, the moment we see the type of that
लाइट सोर्स अंदर बहुत है इसलिए
like this. On the left side is the company right side of that. This will be complete.
Dr. Sambit, we are starting. Dr. Rohit is going to start with
Okay, sir.
You will get dragon 33 millimeter. 33 millimeter. So will be by comparison we can actually still practically we can be a place to 5 centimeters. So in totality we can and by 53 millimeters.
Good morning, everyone. Am I audible?
Yes, Rohit.
Has to be 10 degree, 20 degree maximum. How much degree we want the high temperature that because 33 millimeters. Now, beyond the first state, we have both. On both the side, we have It will be within the 33 millimeters between distance that the needle travels. So the needle will hit the bone and come back. So that will be the failure of implant. So if there is a 17 or 38 degree, you can go up to 90 degree or 25 30 degree. But if the poster is say 30 to 50 grams, then we need to do hardly 5 to 10 grams of the bone. So depending on the size of the prostate, we decide how much.
Good morning, everyone. We are live from OT1.
The first thing is we release the law. That is trigger the needle.
Hello, Rohit.
Compress the as well as the blue.
Rohit, am I audible?
Because the implant, then comes each meter tension. So we have to adjust the counter tension. So that's a pipeline minimum. So what
Yeah,
we
the
have,
first case for the live operating workshop is female uterus disease for dorsal.
the moment we do the two together, you will focus over here. That is in the movie. It will show up as a white line. So the moment we see the white line occupying half of that particular thing, that is the moment where we have to press this button. This is the release button. So once we are comfortable, we are doing there, then we press this particular button. That will cut the interface and that will help the implant between the adenoma and the capsule. Now the capsule comes. The concept of urology is changing the adenoma towards the capsule. Now, since adenoma is compliant, capsule is firm, so it is not that capsule comes towards the then towards away. Because the compliance now is
Hello.
Now, how can you see the thing? For example, that we are not going to do anything from the posterior part. See, for the laser beam start from this particular angle.
Good morning, everyone. This is Anaikan OT1. Today, the first case for the workshop will be female uterus for ventral inlet buccal mucosal graft uretroplasty. Our patient is a 35-year-old lady who presented with predominantly obstructive lower urinary tract symptoms for the past 9 months. On evaluation, she was found to have obstructive uropathy, and following failed calibration, 6 French perurethral catheter was placed in May 2023. Past history, she had taken several over-the-counter medications and had no relief. And she has a regular menstrual history. On general physical examination was unremarkable. And on evaluation, ultrasound, for 3 months following the initial PUC placement, the hydroureter nephrosis has resolved, and the creatinine has normalized to 1.17. Her urine culture has shown no growth. And this is the uroflowmetry at the presentation with a maximum around 9 milliliters per second. And this is the MCU of the patient, in which we can see there is a dilation in the proximal urethra on the upper part and the bladder neck level, and there's moving at the level of the medial ligament here. And a cystoscopy was performed, which showed an urethral thickening.
Hello, is the background in the operating room.
इधर जो माइक है वो ऑफ कर रही है, सिर्फ जो ट्रांसमिट होगा वो माइक होगा।
ये नीचे
Hello.
नीचे
ସେଠି ଆମେ କେସ୍ ପେସେଣ୍ଟ କଲୁ ଜଣେ କଣ ପଚାରିଲେ ଆମେ କିଛି ଶୁଣି ପାରୁନୁ ଆସିଲେ ସେ ରୁମ୍ କୋଉ ରୁମ୍ ଏଠି ଆସିଲେ କି ନା ଏଇଠି ଆସିଲେ ସେପଟ ଆରେ ଏଇ କୋଟି ଟଙ୍କା ରୁମ୍ କୁ କାଇଁ ଯିବ ସେଠି ତ ଶୁଣା ହଉନି ଚଳିବ ଭାଇ ଏଇଠି ଖାଲି ଏଇଟା ହିଁ ଟ୍ରାନ୍ସମିଟ୍ ହଉଛି ନା ସେଠି ଏଇ ଓଡ଼ିଶା ପ୍ରେଜେଣ୍ଟ କଲେ ସେଟାରେ ଯଦି ଜଣେ କଣ ପଚାରିଲେ ସେଠି ଆସିଲାନି ଆମର ଏଠି ଅଡ଼ିଓ କଣ କରନ୍ତି वो माइक बंद है ना अभी बोलिए ना वो तो एक कॉपी करके बकल निकालेंगे फिर उसके बाद इधर करेंगे इधर में चल रहा है और कोई मिलेगा हमें बकल निकालने के लिए ठीक है सर ठीक है ठीक है सर ठीक है Yeah.
Hello. Is somebody from the OT able to coordinate what's happening? We are getting an end of vision, but we are not getting anybody telling us.
Hello. Hello.
Put on mic and interact.
Hello.
Hello. Hello. OT1, am I audible?
Yes.
Yes,
Yes,
sir.
Dr. Samrit, you are audible.
Yes, sir. Please, sir. We are waiting, sir.
Yeah. We have started the scopy. I hope you got the case details. This is a female patient.
Yes, sir.
She's 35-year-old. She had lower tract symptoms. Ultrasound showed hydronephrosis.
So we are not
tried to calibrate. Am I audible?
audible, sir, but we are not getting visuals from you.
Visuals. A camera. Cameraman.
Camera on.
Yeah. We are about to start this copy. I was just briefing you on the history. We calibrate.
Audiovisual team have not done the workshop with them. It is so obvious. Not showing, knowing what to put is
Auditorium, am I audible?
Yes, sir. But you are not visible, sir.
Samvit?
Yes, sir.
माइक ये है, मुझे दिया ना इन्होंने, ये माइक दिया ना तब, वो माइक ये कनेक्टेड नहीं है, यही माइक कनेक्टेड है।
हेलो सर।
हेलो।
हेलो।
हाँ, उनका आवाज आएगा तभी तो मैं रेसिप्रोकेट करूंगा ना।
सर यू आर ऑडिबल सर।
Yeah, we'll start this copy. We have put a guide where.
Sir, focus is not at right place, sir. We are
Which
not.
one? वो है ना ये no.
Sir, audio visual team, please focus the camera on, sir.
Yeah, we'll show to the end of view. Please, cameraman, please end of view, end of view. Take. You are getting the end of view? Yeah, you are getting it. Chalo, Rohit, shuru kar. Yeah, we are doing the scopy. This is a 9 French scope. We have put a guide where. This is the bladder neck, bladder. Now we'll come out again. Come out again. So this is the proximal urethra.
Lost the feed, sir.
We have lost.
Yes, sir.
भाई वॉल्यूम बढ़ा जोर सेठी बड़े काहू कहबी सेटा अपन कहबे ना मुई एठी केस प्रेजेंट करबी ना से जिंस कहबी
Audio visual.
this is the स्ट्रक्चर कहां गया यहाँ का ऑडियो विजुअल हटा दिया अपन को एठी पड़ी हेलो हेलो हेलो
Yes.
Audible? Hello.
Hello. Yes, sir. You are audible, sir.
Myself, Dr. Arup Kumar Nath from OT2.
Okay, sir.
Good morning, everyone there in the auditorium.
Sir, good morning, sir.
Yeah, so I wanted to show the position of the patient initially, but because the audio visual could not be established in time, so I could not show. But if somebody can focus, already patient has been draped. So if someone can focus on the position of the patient, then you can see that we are keeping the legs as much as possible and the buttocks projecting little away from the edge of the table, so that we do not get difficulty while inoculating the lateral lobe during in the apical region, and at the 2 o'clock on the left side and 9 o'clock position.
You from OT2. OT2 team, please.
Audible now?
Sir, you are audible, sir, but we are not getting any feed from the OT, sir.
Okay. So
We are getting a feed from the end of view, sir.
हेलो संवेद ସେଠି ଅରୁପ ସାର୍ କଥା ହଉଛନ୍ତି ଆଗ ସାର୍ଙ୍କର କରାଅ
Video from OT2, but audio.
Audio visual team, please connect to OT2.
audio नहीं आ रहा. Where is the audio guy? Am I audible, sir?
Yes, sir. You are audible, sir.
Okay, okay. So I was explaining about the position. Now we go for this copy. I think the case has been presented already. It's a 53-year-old gentleman with severe symptoms, around 20 AOS symptoms score, and he was on treatment for last 2 years or so. PSA normal, other comorbidities normal. Cystoscopy has been done, and it was
it was found to be a trial over enlargement. So we are going ahead with the cystoscopy.
What is the size of prostate on ultrasound? Because case was not been presented.
You can fix it. Irrigation, please.
Dr. Arup, what was the size of the prostate?
It is 37 gram, but while inquiring the person who did the cystoscopy, he said it was a little bigger than what was written on ultrasonography. Let's see by doing the cystoscopy. So this is the endorsement. So during cystoscopy, there are a few points to be noted, that if there is any associated morbidities inside the bladder, like presence or absence of any bladder tumor or stones, or at the same time evidence of or severity of the obstruction. We can see some trabeculation there. So this is the left-sided ureteric orifice. We'll localize the right side if possible. It should be possible because the median lobe is not too big.
Yes, sir. Blooded trabeculotions are there, and prostate seems to be.
Yes. This is the right-sided ureteric orifices. So once we see the amount and severity of the back pressure changes along with the associated morbidities inside the bladder, then we need to come back to assess the prostate. Here you can see the median lobe is enlarged. The two sulci at 7 o'clock, which is not well formed, and there is one sulcus formed at the 5 o'clock, and there is a midline sulcus also. The lateral lobe is not too big. Then we need to come back and see the verumontanum. The apical lobe is not projecting too much beyond the verumontanum.
It's a small prostate.
It's a small prostate rather. So we need to come back to see the sphincter area. Make sure that always you come back and see the sphincter area by blocking the water jet. You can see this is the sphincter, which contracts like the anus when you stop the irrigation flow. So these are the points you need to see before doing a laser inoculation. And urethra seems to be adaptive.
So I think, sir, that point is more useful for large prostates when the lateral lobes are at Veru, but in small prostate already the Veru is quite far from the lateral lobes, and then the sphincter will be distal to that only.
Yes, definitely. Because when there is too big enlargement of the lateral lobes, the apical lobe goes much beyond the verumontanum, and it distorts the external sphincter. And when there is possibility of injuring the external sphincter, and at that point we need to take care that either by doing early apical release or keeping a pad of apical tissue, which will eventually help in maintaining the early post-operative continence.
Yes, sir. Dr. Sambit, will he have two OT simultaneously running or only one?
We'll have three OT.
So we usually use office ureterotomy in all the cases because it was not available here. So we are going without it.
Yeah. Could you just run us through the equipment that you're going to use? Yeah. Dr. Arup,
Sir,
could you run us through the equipment that you're going to use?
yes, sir. So the continuous irrigating sheet from pulse stores and along with the pulse stores working element with a laser channel.
Arup, please ask the camera person to spot at that instruments,
Instruments. Okay, sir. Can you focus it here? Take it. Can someone focus it here outside view? Yeah.
Hello.
No, sorry. Mister, bring the trolley little closer.
Hello.
Oh, can you see the outside view, sir? So I am using 26 frames continuous irrigating castors.
Cameraman in OT2, please focus on the instrument, sir.
26 frames continuous irrigating castors pure seat, and this is the working element with one laser channel with a lock there so that we can lock the fiber while working. Then you can see this is long blade offset nephroscope with a straight working channel. We'll use it for morcellation, and we are using.
Would they remove the
So and we'll use thulium fiber laser from IPG Photonics, that is a 60-watt laser, and I am using 600 micron fiber, and we'll be using pulse mode. The energy setting will be 4 joule and 13.5 hertz, that make it to 54 watt while working.
They can remove the smaller images from the screen. I mean, it's too confusing. There are 6 images which are coming up. We just need 2 large images. The mixer team from the OT, can they remove the smaller images which are down? Dr. Arup, just to keep the discussion going,
Sir,
do you do tuflep in all your patients with prostate, or it's only because it's a workshop that we are going to demonstrate this?
sir, I started with thulium YAG laser in the year 2015, and then after 2019, I have shifted to thulium fiber laser after doing nearly 600 cases of enucleation with thulium YAG, and now I am doing all the cases with thulium fiber laser. ये थोड़ा और ऊपर हो जाए, थोड़ा हाइट पर करना। Table to throw down. Table down. So as you know that we have options of doing three lobe enucleation, two lobe enucleation, and block enucleation. So according to the wish of the audience there, we'll go ahead with the procedure. If you want, I can go ahead with a two lobe technique also, and if required with a midline incision, I can go ahead with a two lobe enucleation, or if required, I can go for envelope. So, sir, let me know which procedure I should go ahead.
So, we should go by what you're used to. That's number one. Second is you should tell the audience which are the type of cases you do a one lobe enucleation, which are the types you do a two lobe or a three lobe. It's not what we prefer. What would be the ideal way of choosing how many lobes you want to do at a time? Is it in any case you can do any of them, or is there specific instances that you will do a two lobe or a three lobe or a single lobe?
So with experience, all the process can be done with single lobe technique, which saves lots of time actually. And for a beginner, it is always better to go ahead with three lobe. Otherwise, if the lateral sulcus at 5 and 7 o'clock are well formed, then you can go ahead with a three lobe technique. And in this case, as you can see, there is a midline sulcus also. So here we can do two lobe technique, which is most common nowadays for enucleation by two lobe technique, or we can do an en bloc also. And when there is a big median lobe, it is always preferable to do either a two lobe enucleation, where the whole median lobe will be enucleated with one of the lateral lobes by either incising at the 5 or 7 o'clock position according to the sulcus which is well formed.
Yeah, so you can go ahead and choose depending on the anatomy that you find. There are sulci on either side, so you want to.
So, as it will be easier to follow, or as the prostate is not too big, so we will go ahead with a three lobe technique.
Please go ahead.
sheet डाल दें.
Have you stopped doing a conventional monopolar, bipolar TURP in your practice now after you started doing two-flip?
Sir, nowadays, because I visit to the peripheral places also in the weekends, and wherever I do cases, I do with the conventional energy source. But at my place, I have stopped doing with conventional energy. So, in the classical description, we need to incise at 5 o'clock, then 7 o'clock, and once we deepen the groove up to the surgical capsule, then coming back towards the verumentanum and limiting our incision 5 millimeter away from the verumentanum, so that the patient doesn't have like much of dysuria or painful ejaculation. So 5 millimeter away from the verumentanum. But here, what I am doing and what I feel that I mark the incision, the transverse incision in front of verumentanum first, so that while making the 5 and 7 o'clock incision, I do not overshoot. So this is the transverse incision we are making just in front of the verumentanum. So this is the pulse mode we are using, and the energy is 4 joule and the frequency is 13.5 hertz. That makes the power of the laser is at 54 watt. So I have made the incision here. After this, I can directly go for making the incision here, or I can make an early mucosal release all around, and then go for the incision there. So as the striated sphincter is an omega separated broad muscular band, so in the roof, the whole area the striated sphincter is spread like a fan, and then it comes this side, and deficient where it is like an omega. So while making the incision, while making the incision at 12 o'clock at the level of perimentonum, you can go a bit proximal, nearly 5 millimeter to 1 centimeter proximal. Then we can do the early mucosal release by making the incision. Here you can see that I am cutting through the apical lobe, that and that will keep the pad of apical tissue along with the striated sphincter, and that should help in early postoperative continence.
Sir, as you told that initially 600 cases of whole flap, now you shifted to two flaps. So what difference you are finding between these two? You are audible, sir?
Yes. So I started with thulium YAG, and then in the year 2019 I shifted to thulium fiber. And initially, actually, we had a thulium YAG laser. At the same time, as you know, that thulium is a soft tissue laser, and for stone we need another laser. So we had a holmium 35-watt laser also. And at that time, as the thulium YAG, thulium fiber was coming, and everybody was telling that it is, and what I could feel also by seeing some conferences like demonstration by Chandra sir and all, that it is a laser which is very good for stone. At the same time, the enucleation for the soft tissues will be possible. So I just wanted a standby machine being at corner of the country. When a laser machine breaks down, it takes actually lots of time to replace it, and till the time we suffer. So we wanted a standby machine. So I installed the thulium fiber laser as a standby machine to both my works, for soft tissue and for stone. And we initially started using it for stones, but gradually, once or twice, I tried in soft tissues, and after that, I could feel that it is much superior to thulium YAG laser, because at that time thulium was a continuous wave laser. So there was lots of churning of the tissue, and while going for enucleation, you get it difficult to find the plane near the capsules.
Okay. So you are doing this with classical Gilling 3-lobe technique.
Okay. Now we have made the mucosal release at the apical part. So now we are sure that we are not going beyond this point, and that will not, there is no possibility of injuring the sphincter and all. Now I will make the incision at 5 o'clock position. Horizon 15.
15 or 16. And short pulse.
Short pulse.
What is the size of fiber we are using?
It's a 600 micron fiber, sir. So by doing at high power, because initially I started with 2 joule energy, and gradually once I felt that laser is very good and with good safety margin, then I started using with more power. And when I started using 4 joule energy, you feel that it is just like the enucleation with a holmium laser. So here you need not have to touch the tissue; it splits the tissue from a distance.
Sir, any technical tips from your side to be in constant plane all time?
Yes, definitely, because sometimes you may find it difficult to identify the point, because at the mid fossa the capsule is least well formed. So if you are unable to find the capsule, you need to go to the bladder neck, because there you will get the circular fibers, and from there on you can follow it backwards towards the mid fossa, and you can go from here also. So at this place, if you are not able to find the exact plane, you can just make with the beak of the assembly, resectoscope assembly, you can just make a stretching movement, and then you can feel that this is, you can see that the lobe is getting lifted up. So so from there on you can follow it proximally. So you can see, yes. Can you see that it is getting lifted up? Yes. So we will go to the other side.
The audiovisual team, again, you have started putting so many images. If you're not relaying from the other OT, you can take off those images. There are too many images on the screen here. Just show us the one where surgery is being shown. The prostate.
So this is the reason why I just explained that I want to put the transverse incision in front of Verumantanam before putting the incision at the 5 and 7 o'clock sulcus, because at that time you do not overshoot. You just come in and you can stop here. So this is a very young patient compared to me, who is a 53-year-old. Here, you may not get the adenoma as well from as an elderly gentleman with a bigger prostate. Here, some precaution, like you need to explain to the patient about the presence of retrograde ejaculation, which will be invariably present in this patient. So as he is definitely a sexually active male at 53 or 54 years, so we need to explain to the patient about this, because up to 90% of patients in all established series that after anatomic enucleation of prostate, the patient definitely will have retrograde ejaculation. So how you identify the adenoma from the capsule? You can see that this is light yellow color irregular adenomatous tissue is the adenoma, the gland, and once you go near the prosthetic capsule, the surgical capsule will be glistening white and a smooth structure with some striated fiber visible.
You said you were using the thulium YAG laser earlier, and now you're using the pulsed laser. Other than the speed of enucleation in the thulium YAG laser, do you find any difference in the?
Sir, among all the lasers, because I sometimes do enucleation with holmium laser also. So among all the lasers, if you ask me, the enucleation speed is maximum with holmium, and then the thulium YAG, and then finally the thulium fiber. But this is a very gentle laser. Thulium fiber laser is a very gentle laser in comparison to the other two. Thulium is a very good cutting laser and very powerful also. So it will cut through the tissues. Even if you are in a not exactly in the correct plane, it will cut through the tissues. And holmium is a very strong laser again, and it is a splitting kind of laser. And if you are in the not in the correct plane, again with holmium, it will create a wrong plane, and you will follow that. But with thulium fiber laser, as it is the laser which has the absorption coefficient closest to in water, in water, its wavelength is closest to absorption coefficient of liquid water at room temperature, that is 1940. And the thulium fiber laser is having exactly the same wavelength. So the absorption of thulium fiber laser is at least 4 times more than what you see in holmium laser. That's why it is a very precise laser. And the safety margin is very, very high because the penetration depth of this thulium fiber laser is only 0.1 mm in comparison to holmium, which has a penetration depth of 0.4 mm. So see, from mid fossa, the gland, it follows a provisor. It is not like a cylinder, it is like an apple. So from here, when we started inoculating, from here the gland moved like this, and after that it is moving anteriorly. At this point, if we do not follow the curvature, there is always possibility of undermining the bladder neck. And there is an advantage of either a bilobar or en bloc enucleation, that there is no possibility of undermining the bladder neck because it will come from a different direction. You are not going to move like this from the verumontanum proximal to, distal to proximal. Rather, it will come from a lateral to medial kind of movement in en bloc enucleation. So this is the capsule. You can see the glistening white in comparison to the gland, which is, you can see, a light yellow kind of structure, irregular and fluffy. So at one stage, rather than completing the incision at 5 and 7 o'clock, completing up to the capsule, you can start inoculating from distal to proximal, and while going, you can adjust like what I am doing now. So we are almost near the bladder neck.
Sir, as in this case, median lobe is not too large. So what are the technical points when the large median lobe is there in protruding into the vessel, bladder?
Yes. So when the median lobe is very big, then the principle is same. You make the incision at 5 and 7 o'clock, and then you deepen it, you undermine it, so that gradually the stalk of the median lobe becomes narrower. Like at bladder neck, here you can undermine the median lobe gradually. You can undermine, go medially like this, like this. So gradually the stalk at the floor will be smaller, like this. You can see, and when you are lost for the exact plan, then you always come back to a more defined area, and then go again to the surgical place where you are lost to the exact plan.
So as large median lobe with undermine at the bladder neck, so how to decide proximal limit?
See, if you exactly go in the correct plan, there is not much chance of undermining the bladder neck. As I have said, that from mid fossa, your movement should be like this. Your movement should be, the fiber should project towards the umbilicus, like here, like this. If you go straight like this, then always possibility of undermining it. From here, because as I have said, that the contour of the prostate gland is like an apple, not like a cylinder. So from here, your movement from mid fossa, your movement should be upward.
So which technique is better for beginners, like as you are doing tri-lobar technique? So tri-lobar or single lobar technique, which technique is preferable?
Always a tri-lobar, sir, undoubtedly. Because in tri-lobar, once you are done with the median lobe, then you get much better vision, because the saline irrigation flow will be much better towards the gland of and at the place of your surgical enucleation. So you always get a better picture and better orientation also while enucleating the lateral lobe. You can always come back to the floor if you are lost to track, and again you can go from a more defined to a less defined area.
Because originally, initially, trial over technique was described for laser enucleation, but nowadays modifications are there like anteroposterior technique or to, especially to avoid stress urinary incontinence at apical dissection at apical region. So, what is your take on those techniques?
No, see, there will be definitely because TRP is a 100-year-old technique which was first reported in the year 1926. But laser enucleation is only a 3-decade-old technique. So gradually there will be lots of permutation, combination, energy frequency, then the technique. So many things will come up. But the principle is same. You go properly in the plan so that you can see the surgical capsule all the time. You do not undermine the bladder neck. You do not go beyond the apical. You do not go beyond the verumontanum during the apical lobe enucleation, and while morcellation also you make a good vision all the time. These are the principle actually you need to follow. So whatever large the gland is, whatever difficult the gland is, definitely you will succeed. But my advice, or rather you can say my comment for the beginner, is you should have a very high threshold for converting laser enucleation to a conventional energy source like monopolar or bipolar technique. If you have a low threshold, you will be facing lots of difficulties to learn enucleation.
Okay, sir. So, what is incidence of stress urinary incontinence in your practice, sir? With two
Initially, the stress urinary incontinence immediately after endoscopic anatomical enucleation of prostate will be nearly 20-25%, or in some series it is said that almost half of the patient or a little more than that may have stress urinary incontinence, which is transient, and most of them settles down in 2 to 3 weeks time. And that is not this transient stress urinary incontinence is not because of the sphincter injury, because in a patient of prostatic hyperplasia, the patient is not going to use the levator and muscle for holding back urination, and the prostatic lobe will be doing that. So the underuse of the levator and muscle and that weakness of the levator and muscle is the cause for transient stress urinary incontinence after enucleation. So that gradually will come up. 2 to 3 weeks time, it will definitely come up once the patient he follows the pelvic floor muscle exercise, or he will give some bladder relaxant to combat the overactivity, which definitely will be there in a case of prostate hyperplasia, because of the overuse of the bladder muscles. The muscle definitely will have some kind of overactivity. So with pelvic floor muscle exercise or bladder relaxant, definitely it will settle down.
Okay, sir. So does size of prostate matters for two flap, sir? Especially for if you are having both two flap and whole flap available?
No, size doesn't matter. Gradually, once you master the art, after that size doesn't matter. Even for bigger glands, you will face less difficulty in enucleating.
So if today's era where you have all the modalities available, would you want to put any specific role for each of these modalities, or do you think just because of your practice, you're going to change and stick only to one of these laser modalities? Or do you think there is still any current role for a conventional TURP?
Definitely, the conventional TURP is there to stay for maybe another few decades or maybe years, but definitely laser will take over once it becomes widely available. The expertise becomes available everywhere, or the cost of machine comes down gradually. As you can see that while enucleating the median lobe, the quality of vision you are getting all the time, you do not get in TURP. or like for bigger glands, there are lots of problems. When the patient is on antiplatelet, and nowadays, as you know, that lots of patients coming with lots of comorbidities, as our
That's the point I was trying to raise. If you see the
as our
evolution,
population is getting older gradually, and there are lots of other comorbidities also, and because patient used to take medical treatment before coming to you for surgery, you will get more and more bigger prostate in due course. So definitely laser will replace PRP, but as of now it will stay at least for another few decades.
yeah, if you see the evolution of lasers, it was only because people were worried about the bleeding complications and patients.
Yes, sir. Yes.
In a conventional prostate, majority of the prostates that all of us get are in the range of 20 to 40 grams. That
Yes, sir.
5 to 80% of the prostates. So do you think for glands, even this prostate, total must be about 30 to 35 grams? So in the volume of this prostate, do you think everybody should evolve and go into a laser technology rather than do a conventional monopolar or bipolar TUR?
But see, sir, the mixation parameters you are going to get after laser prostatectomy of this patient, this kind of contour of the capsule, you will never get in TURP. So definitely voiding parameters will be much superior in this patient in comparison to TUR with any form of energy, either monopolar, bipolar, whatever. So the technique you need to do is anatomical enucleation of prostate, whether with laser, monopolar, or bipolar, that depends. But the technique which will give you maximum improvement in voiding parameters and symptom score is enucleation, anatomical enucleation of prostate. That you do with any of the energy. That will that doesn't matter, but you have to do a complete anatomical enucleation. Now, as we
Sorry, if we talk about in
this is
training,
the medium lobe.
wise to go directly for this laser enucleation, or it should be like first he should learn conventional TURP, then he should jump on these techniques?
Sir, because we grew up in the generation. Because when I was a resident at BJMC Ahmedabad, we did not have the exposure to laser, and gradually I purchased the laser and got the training, and gradually I adapted to the technology, and now I'm doing laser only in my parent center in Guwahati. So it will depend. Gradually, what will happen? The people will not see much of, like, open prostatectomy. I have never seen. So the generation or the resident will come who will not see even a PRP in some centers, where, like in my center, if someone gets trained in due course, then he may not see even PRP. So for him, it will be easier to adapt to or to expertise laser prostatectomy rather than going for TURP. So that will depend even for other branches also, like in laparoscopy. After some time, people may not see even laparoscopy in high volume or bigger centers. They will grow as an urologist. Or during training, they will see lasers or robots only. So it will depend.
Okay, so a person who's directly learning this laser enucleation, so it is not required to know the standard conventional TURP techniques.
But it is always, I think till now it is mandatory. So if you have the feel of TURP, then it will help you in doing this enucleation.
I feel, sir, because the standard conventional TRP still has role. Suppose in some cases some complication or the plane lost, then the standard TRP is the technique that will save.
Because maximum urology is still doing monopolar or bipolar TUR only, because of maybe because of the lack of availability, the cost associated with the laser and the morcellation, and at the same time the lack of exposure or expertise, whatever. But gradually, once the laser machines become economic or easily available, the people will be more experienced in laser technology. And now, as you feel that more and more people are adapting to laser technology.
Yes, sir. That's true.
Now you see, as I have enucleated the medial lobe while enucleating the lateral lobe in the most medialmost part of the lateral lobe on the left side. It is for me, it is easier to, because this is the capsule and I have to come up to this much distance only, because I already know the extent of enucleation. So now,
Are you using a combination of cutting with the laser and a little of mechanical energy to push that lobe?
so it is always because with the beak, I will handle the enucleated part of the lobe adenoma with the beak. So what I am doing, I am lifting up the enucleated adenoma with the beak of the assembly and getting the cobweb-like attachment between the adenoma and the capsule stressed, so that you know where you need to divide with the laser. This is the area. If you do not stress it, then you may go in a wrong plane. So what I am doing with the beak of the assembly is to stress out the tissue, stress out the attachment, and then separating it with the laser. And it's such a beautiful laser. It is so gentle. It will not make a wrong plane so easily. Or even if it makes, you can come back, because it will be not much of a very deep kind of capsular perforation, because of its lowest penetration depth among the contemporary lasers.
Not only the machine, the man behind the machine also matters. So you're doing a great job. And
These are the challenge. Actually, smaller gland, young people will, and those having chronic prostatitis or prostate cancer or earlier prostate abscess. These are the people. These are the cases actually a little more challenging. You do not get a very well-defined enucleation plan, and at that point, you need to apply your experience.
do we have the other OR running? If you can. Oh, okay. Fine. If anybody from the floor needs to ask any questions, feel free. There must be some mics circulating there. Now tell me, you've done so many cases. Does your incidence of post enucleation strictures in the urethra differ from your earlier days of TUR strictures? Either bladder or urethral?
It is the same, nearly the same with TURP and with laser. It is not with the I think the energy which you are using, rather than the anatomical stress you are putting on the urethra, because it is otherwise a S-shaped structure, and we are making it straight. So as long as we are going to keep it in that non-anatomical stress position, chances of stricture will be there. Because what I could feel that initially when I started with thulium iode, I started with first with vaporization, then with vaporesection, then ablation, and finally with enucleation. So what I felt when I started doing enucleation, the chances of stricture has come down, because after doing enucleation and morcellation, the surgical time has decreased drastically.
No, probably with enucleation, the bladder neck contractures would be less, but the incidence of urethral strictures would be the same, because the instrument size you're using is 26 French, both in a TUR and in a laser enucleation. And
Yes,
probably laser enucleation, your total operating time will be more because of the enucleation process and the morcellation. For gram to gram, I think the time for laser would be more than a transurethral resection.
Yes, sir, definitely. So less and less time when we can do a laser enucleation and subsequent morcellation. If we use less time and keep the urethra stays for less amount of time, this picture should come down. Now you can see that I have almost completely enucleated one lobe. Now what I'll do, I'll make the incision at 12 o'clock. So if I do a en bloc enucleation from here itself, I can again go reverse to the other lobe. Even I did some modification of en bloc enucleation like unidirectional en bloc, which we adapted in our center, that I enter to the adenoma here at 5 o'clock and then go like this, and end at 7 o'clock. That is unidirectional en bloc. So it is there in my YouTube channel also, unidirectional en bloc technique. So you can sometimes, if you want, you can see there, and it takes very less time.
Yes, sir, please.
So I can understand that doing an enucleation on smaller glands perhaps is required for the people who are training, because when they do it on smaller glands, then they progress to doing it in a larger gland. But if you look at the data doesn't seem to support doing enucleation in smaller glands. So if the contention is that doing an enucleation is the better procedure in a smaller gland, I don't think there's any data to support that. For the large glands above 80, 100 grams, I can understand. But small glands, if you tell me that a 40-gram gland is better enucleated, I think I would take exception to that.
Yeah, I agree with you. So that's why I posed that question. If you have everything available, why would you want to only stick to laser, where conventional TURP for a gland of this size is definitely quicker and it's as safe and is effective. So I think even the data which has come out says that it's preferred to do enucleation when the volume of the prostate is large, when the patient is high risk, like he's got antiplatelets running in him. So you don't want bleeding complications. The evolution of lasers has occurred only because of bleeding complications. And you don't want to do an open prostatectomy for a very large prostate. You could safely do an enucleation. But in an average prostate, which is 70 to 75% of the times, between 20 to 40 grams, I think it is still safer and quicker to do a good TURP, either monopolar or bipolar, than offer a laser prostatectomy to all patients. That is as far as theory goes. But I think since we're in the workshop, it's all right to go ahead with this. But I think it'll be difficult to say that I got a TFL machine, all my prostates in my patients, I will just use TFL. I think that will be something, a wrong message going out to the younger generation. So
no, I beg to disagree, sir, because for smaller prostate, TURP or any kind of conventional allergy will give you the equally good voiding parameters or the symptoms for improvement after the procedure, even with laser. But if you can do a laser much safely or even with the same safety but better efficacy, or while doing the procedure you are more comfortable, then gradually, definitely, it is. You cannot say it is a wrong basis, but definitely time will tell.
Sir, Gopal Krishnan from Calcutta.
yes, Dr. Kumar.
Yes.
Sir,
In my personal
we
observation,
are almost through, sir.
that in those patients who have chronic
So
retention,
we have enucleated the median lobe. Then the left lateral lobe enucleation is nearly completed. We'll just
whose urodynamic parameters do
take
not
down the attachment here.
pressure more than 30 or 35 centimeter, and you are wary of doing a TURP because they may still be in retention. In those patients, I found that doing an enucleative surgery gives them better voiding parameters than a TURP. Any observation from your side regarding the same? That an enucleative procedure gives better parameters in patients with dodgy bladders whose voiding pressures are not more than, say, 25 or 30 centimeter water.
It doesn't fit into logic. Because when you do a TUR, you do the same thing. In a small prostate, like you say,
Yes.
all of us do capsular resection. We go till the capsule, what you do with the enucleation. So if you're doing a good TUR or you're doing an enucleation in a small prostate with this underactive detrusor that you're referring to, or a low pressure,
Yes.
I don't see why the outcome should be better in a laser prostate enucleation than with a well done TUR. It doesn't sound logical to me.
I mean,
Actually, what I want to say that the result in small prostate with not much of comorbidities will be the same with laser or with any kind of conventional energy source. But if you do it much comfortably, then gradually you will see it. Like it is just like driving a car with a automatic transmission, then manual transmission. Gradually, once you are adapted to this technology, it is so comfortable, then you will not like to do it with TUR.
The voiding pressure.
I said that the cost should come down. To offer it to all the patients, the cost should come down and then expertise should come up.
The voiding depends on not only the size of the prostate or the process method we adopt. It is both disease, whether it is associated with detrusor paralysis or detrusor defect, and the voiding pressure, how much pressure it can give it. So only enucleation by whatever method will not give the whole voiding pressure or voiding pleasure.
No, that is differently, totally a different sector. That definitely we need to determine whether there is underactivity or other neurological element. We need to determine even before the surgery. That is true for any of the technology.
What is in the chronic retention of the urine? Whatever the method we adopt or whatever the size of the prostate, the voiding pressure is not always satisfactory.
Yes, sir. So it depends on the adequacy of the procedure. It's either it's conventional TURP or laser. It will not.
It will not depend on the technology actually in chronic retention.
Mostly the voiding depends on acute retention or chronic retention or occult disease associated with the voiding. So in one thing, we cannot predict that this process or this enucleation or this will give a better result.
Yes, sir. Agreed. So that outcome is multifactorial. A compromised detrusor that will have impact on the outcomes. So either laser or conventional TURP for small prostate or in cases of chronic retention, the adequately done TURP is equal to laser enucleation for small prostates or in chronic retention.
The
So
purpose
it was 37 they said, but it looks a little bigger. So 2 lobes we have already. This is the median, then 1 lateral lobe. Sir, with the same setting. With the same setting, we can do coagulation. So I do not use the other setting because yes, because that is too slow.
Other OT also running simultaneously.
We're just waiting them to start.
Okay.
Yes, sir.
while well, this comes on just a comment. While you look at the survey across the country in training centers, most of the MCH program runs in government hospitals or in a few private medical colleges, where laser has still not got inculcated into the routine. most of the laser prostatectomies are occurring in DNP programs running out of corporate hospitals. So you have two subsets of graduating. Not seen prostatectomy. The other group there's no laser machine. How they as of today, it is still going to be very imperative that all residents go through a phase where they learn basic TURP, because even while doing a laser prostatectomy, they can get lost and they need to convert at some point into a TUR. So this we find is lacking in some of the ultra modern high-tech DNB programs run out of corporate hospitals, where the consultants prefer doing a laser prostatectomy rather than a conventional TUR. So those DNB students who pass out of these high-tech centers have not even seen a TUR. I'm telling this out of personal experience. When we did the Euromed program for USI in Delhi, we were surprised that a lot of residents had not handled a conventional resectoscope. So this is the pattern of training. It's not uniform across the country. And the current day, most of the so-called laser experts have learned the laser themselves, not during the training program. They've evolved into good clinicians and good surgeons, and have slowly evolved into the technology of laser prostatectomy. So my take would be still most of the training centers should have a good TURP program, either monopolar or bipolar. I hope my next power out to say that we should at some point stop doing monopolar TURs when we have a good bipolar machine, because the technique of doing the TUR is the same, but it's much more safer procedure doing a bipolar TURP than a monopolar TURP. And that's the way it should.
Definitely, sir.
In the meanwhile, I would like to thank our chairpersons for such an enlightening discussion. And I would like to call the next set of chairpersons. Dr. Prasanna Kumar Misra, Senior Consultant Urologist, Amri Hospital. Dr. Jagat Vallabh Jagdev, Senior Consultant Urologist, KIMS Hospital, Bhubaneswar. Dr. Dilip Kumar Mishra, Senior Consultant Urologist, Jamshedpur.
এটা বড় অন আছে
Rajesh Ranjan, Senior Consultant.
ক্যামেরা দেখাও অন কর দিও
Dr. Amrit Nayak, Consultant Urologist from JP Hospital. And Dr. Nasrin Gite, Consultant Urologist at Apollo Spectra, Mumbai. I would like to request all the chairpersons to please come over the dais and please be seated.
ladder full पड़ा है प्रश्न कैथेटर दिले नॉर्मल कैथेटर করে দিন
So after we enucleate up to the 9 o'clock position here, the lateral lobe, then we'll again go to the 12 o'clock position, then we'll take down from there at the bladder neck. We'll go to the bladder neck here. Then we will try to take it down from here. And finally, we will meet both the enucleation plane at near 9 o'clock position.
Good morning, chairpersons. I don't know, the new set of chairpersons have come. So I'm Dr. Uttam Mehte from PJ Chandigarh. So can I ask some questions, Dr. Arup?
Yes, sir. Please go.
Hi. Dr. Arup, I'm Uttam here from PJ Chandigarh. I heard discussions. I believe you started with TURP, isn't it? In your career. Now, what I want to ask that what is the long-term outcome differences? Everybody talks about short-term. I think hardly any data is there with a head-to-head comparison for a long-term data. Say after 10 years, you do 100 patients of your TURP patients and you compare your laser enucleation. So is there any difference at the end of 10 years, the long-term data you have? How long you have laser for how many years?
Sir, there is not much of published data, long-term complication of laser with TURP for that matter or bipolar. But what the series coming up gradually, and they are saying that the voiding parameters along with the retreatment rate for laser is very less as compared to TURP.
No, I'm asking your personal experience because you must be doing laser for you started in 2015, if I heard correctly. You started with holmium and then I think 2019 you switched over to thulium fiber, isn't it? So 2005 means around 8 years. So in these 8 years of your laser practice, do you find that the outcomes are different at the end of 8 years compared to your TURP patients? Your personal experience, because there's no long-term data, much data is there, but what is your personal experience?
So totally agreed, sir, because for laser, the all surgeons are getting mature gradually and nobody having experience of like, except few like Maheshwari sir or Anil sir in India, they do not have experience of maybe 2000 cases, even less than that. So even in my case, when I started in the year 2015 and I have done nearly 1300 cases now, what I feel that the initial cases while I did was definitely under resection. So it will take time for expert laser surgeon to come up with their data of anatomic endoscopic enucleation, which apparently looks much superior to any of the TURP technique.
Because
it is just like simulating open prostatectomy.
Whatever literature is there, most of the time, if somebody has compared the laser with the TURP, they have done it as a non-inferiority procedure. So it is not standard TURP. In most of the training centers, it is TURP.
No, definitely, because of the non-availability of the technique, at the same time, non-availability of the required experience or expertise. Because anatomical endoscopic enucleation with any of the laser technology, or if you do it even with bipolar or even monopolar, there is a comparative study by Dimitri Enikis. He said that anatomic endoscopic enucleation of prostate with thulium fiber or holmium gives much superior result with less complication as compared to monopolar enucleation or mechanical enucleation of prostate.
And
so definitely, with time, once you master the anatomical enucleation of prostate, and gradually that should be the order of the day, that complete enucleation, complete anatomic enucleation leaving behind the capsule intact. That with any of the energy, it may be monopolar, bipolar, laser, with any of the available laser in the market.
Dr. Arup, this is Dr. Prashant. So we will be watching on this while we shift to OT1, where Dr. Swarnendu Mandal is ready with
Yes,
his.
sir, definitely. Thank you, sir.
Watching you here. Thank you. So, persons. So Dr. Swarnendu Mandal is ready in OT1. He is going to demonstrate a ventral inlay urethroplasty for a female urethral stricture disease. Swarnendu, are you audible from here?
Yeah, we can hear you, sir. Are you audible?
Yeah, you are audible. Loud and clear.
Yeah, thank you. I would like to welcome you all. The history has been presented. Patient had obstructive gluteus, calibration with a 16 pin catheter failed, ultrasound showed bilateral hydrotonephrosis. So we had put a 6 French Foley. Now I am doing a scopy with a 11 French diatic cryptoscope. A guide wire has gone in. You can see this is the bladder neck. My endo view is there. Endo view, what's up?
We are endo view.
You see the endo view?
We are getting only the outside view.
Endo view to diya. Endo view, please, camera person.
Yes, sir. Now we are getting.
Yes, we can see that. So the bladder neck looks okay. As we come out, you can see the urethra has a flap here, and there's a There's a stricture narrowing here, and the urethra there is pale. As I come out, the remaining urethra looks more or less normal. And also the distal part was unhealthy. So basically this part was also unhealthy. So basically this is a mixed picture. You can see it here. This is the distal part. The distal part is again unhealthy. So the distal is unhealthy, the proximal is unhealthy, and the mid is okay. So basically what we would do is we'll do a ventral inlay. So this is something that we do endourethral. Either दिखाओ. Lights, top lights on please. Camera इधर surface view दो. Percept of Caesar छोड़ दो. Right, ये हटा दो. So we have surface view please. You can see the surface view. I'll zoom करो.
Yes, sir.
इधर आ जाओ.
Getting it, yeah.
ये पकू नहीं. So you can see my guide wire. So what we do is, this is a thin vascular forceps. We'll just put this in. This takes me into the bladder. We'll drain the bladder. तो थोड़ी कम nasal speculum थोड़ा सा नहीं है ये ना ये थी भाई यही थी. You have to show it here. कौन देखो जी किसी देखो नहीं. ଏଠି ଗୋଟେ ଏ ବାଲ୍ଟି କରିଲା. ସେପଟୁ ନିଅ.
ମଝିରେ ହେଲେ ସେ ୟୁରେଥ୍ରା ଭିତରେ ଏଇଟା ଦେଖା.
ଏଠି ଗୋଟେ ଲୁଗା ପକା. ଏଠି ଗୋଟେ ଲୁଗା ପକା. I think we'll start. I think you have a decent vision. So basically what we have done is we have put in a guide wire. Top light tall. नहीं यार. Light नीचे से आता है ना. तुम लोग भूल गए हो सब कुछ. नीचे ला. Section, Rohit. Section. So basically what we'll do is under vision, just like as you do in OIU, we'll make an incision at 6 o'clock position. Gently with a 15 number blade, so that my picture just opens up.
Please zoom in.
We understand, yeah, this is a little difficult, but the camera person has to be very careful, very diligent in that. Yeah, now it is better.
Sir, cannot you use nasal speculum here?
We will put that, sir, but that would only after a bit picturotomy has been done. So this part we are only using our form. We'll finally use it. We'll use a Killian's nasal speculum.
You mean to say now it is too tight to allow that?
Yeah, now it is too tight for me to give a Killian's. So I'll just, the incision has to be only to the pictured mucosa. And then it just opens up. I think my forceps has opened up. Now I am in a situation where I can put in my Killian's forceps.
Dr. Mandal.
Sir.
Dr. Jagdev, in that way, in that case, do you mean to say that the stricture is limited to only the mucosa?
Mucosa and the submucosa.
So you need to deepen the incision till that, till the
yes. And you know that you have reached the right plane because you just make gentle incision and that opens up.
Then it gives way, sort of thing.
Yeah, it just gives way. बहुत बढ़िया. ଖୋଲୁନାହାନ୍ତି ଯୋଉଗୁଡା ଏଗୁଡା କାହିଁ ଦଉଛନ୍ତି ମୁଁ ମାଗିଥିଲି କି?
Dr. Mandal,
Sir,
I am Dr. Mishra. Just I am curious to ask,
କଣ answer କରିବି?
the stricture is deeper, involving more than mucosa. Then what, more mucosa and some mucosa. Then
You
how?
You will have to cut it, sir. In female, there's no spongiosa. So it's mucosa, submucosa, and straight away you go to the muscularis.
Okay.
So till you are not able to open up the urethra gently, then you have to keep cutting it. I am not able to put my killians. That means enough stricture has not yet been cut properly. The blade, please. Pani maro. So I was not able to put my speculum. So I have again gone in with my forceps to do bit more of
Mandal.
hysterectomy.
Dr. Mandal.
Sir,
Is there any fear of injuring the vaginal mucosa here? How do you prevent that?
Which mucosa, sir?
Hide down, hide down.
Fear of injuring the vagina.
Vagina, I am working endourethally, sir. So I am in the urethra only. I still have my muscularis and the serosa outside. I can show you. I will show you.
How do you really take care of not injuring the vagina?
Sir, as you can see, this is my vagina. The vaginal mucosa is intact, and over it you have all the layers, other layers of the urethra. So it's suction.
Right.
Blade, please. So now you can see endourethally. I hope the camera person is showing you inside. Andar dikhao, please. I can clearly see the strictured urethra, and I'll make bit more of cuts. Light.
Sorry, we are not able to get a clear picture inside.
Are you seeing? Camera person, please show inside.
Dr. Rajesh here. Whole length you are cutting?
Sir, when you put, it's almost the entire length because the stricture was there in the proximal urethra as well as it is in the distal urethra. And since your killian goes in and it stretches the urethra, the effective length of the female urethra after the killian goes in stays to around 2.5 centimeter or a 2 centimeter. You can see, I can see almost into the bladder. I do not know how good is your vision. I am seeing it very nicely. I'll request the audiovisual person to please focus and show it inside. Zoom inside, please.
Some endoscopic light source can,
Yes,
if
sir.
it can be put there, then it.
The focus is very good, sir, but there is.
Light source, yeah, we'll try. Give the light source. प्रश्न को देखो ना कौन देखो तुम देखी पड़तो कि भितर माने मजा बनै रखछ गोटे जिंस हमको एठी देखा जाउची ना हमको जोटा देखा जाउची सेटा तांको देखाय जीवो केमिति आपन को एटा देखा जाउची
It's getting little better, but we'll appreciate if it is.
आपन देखि जाउ ता परसेंट सेटा से देखि परिया कथा ना या तो पचरती बस आपन मते पाठ पढाइले सिस्टर मनोज सर को डाकन तो एंगो ट्रांसमिशन बंद कर दो तो मते पाठ पढिया स्टार्ट कर बाइपोलर दियली
Lighted speculums are able.
Visual people are idiots.
That is a great help.
इंटरव्यू आएगा इंटरव्यू आएगा मैं कैमरा से दिखाऊंगा
बाइपोलर ऑन करो
Sir, Mandal sir.
He's not understanding. Yes, sir. No, no, बुझून येथी देखा जाऊ जो इंटर स्पेशल दिखे
First of choice in all cases, or there's some special.
how will we show the stitching? Interview you can see. What is it? It is all dark, no?
Women should be there to cut inside. So
Light
that
off. Light off.
operative strictures, you can't do this procedure, I think. So there are some special cases in whom you will prepare this procedure, or you will do in all cases this.
So this is what you see when you see with the endo view. No, actually the problem we are facing is with the audio visual. I think people who are in the OT can very
So
nicely see it.
much better. Now we are able to see inside. Yeah, it's little suction only is required, I think.
एक बार पानी ऑन करो, वाटर ऑन करो. चलो सब करो, पकड़ो. Bipolar, bipolar. So I am done with my stricturotomy. I'll just use bipolar sparsely to control the small amount of bleeding. Aggressive cauterization is not advisable because this is the bed from which my buccal will take the. Yes. So I am now done. I can fix my Killian here. I hope you are seeing everything.
Sir, I just want to have a chat with the people at the auditorium, then I'll start the modulation.
Swarnendu, we are just getting the view of the endoscope.
Yeah. Nice.
Hello? Hello?
Yeah.
Sir, this is Dr. Arup from OT2.
No, this is only the endoscope is fitted. Yeah, now it's better. Yeah, now we have got the.
Sir, I have completed initiating then this is one lateral, this is one lateral. Complete enucleation has been done, and you can see.
Swarnendu, Dr. Arup just wants to come in and show that when he has to pass on a message. Dr. Arup.
Sir, so this is the final end of view after we completely enucleated both the lateral lobe and the medial lobe, and then we need to spend few minutes extra to completely pinpoint hemostasis so that we can do the modulation crisply.
Use a different.
This is the final fossa.
You are using same energy
and these are the lobes.
and settings for coagulation.
So this is the final picture.
Dr. Arup,
sir,
final coagulation, have you changed the energy setting or you are using the same setting in a defocused mode?
Sir, I can't hear you. There is too much of noise, sir. Just
have you changed the energy setting for coagulation, or you are continuing with the same energy setting?
Audio visual.
Dr. Arup, the question from chairperson is, have you changed to coagulation mode, or you are using the same energy settings on laser while doing coagulation? Hello.
I think the audio visual people have to connect to Dr. Arup Nath's OT.
Yeah. Dr. Arup, are you with us? No.
Hello, Dr. Swarnendu sir, can you hear us, sir?
Hello.
Swarnendu sir, can you hear us?
Audio output is not going from here to auditorium. Just check.
Sir, we can hear you, sir.
Hello.
Yes, sir, we can hear you, sir.
Where's the mic? Oh, मैंने ये निकाल दिया था mask. Hello.
Yes, sir.
Now audible, sir.
Yes, sir, you are audible, sir.
I am using the same energy setting even for coagulation also because it is much faster. But if we use the lower energy setting, it becomes very slow. Because otherwise also we were doing only at 60 watts, which is not inferior to the other available laser technology.
ये बकल डरेगा भाई
Arup sir, will be getting back to you. Dr. Swarnindu is waiting for us in OT1. Swarnindu sir, can you please tell us what you are doing?
Yeah, I have taken those two proximal stitches. I really wanted to show it, but the audio visual were not able to show you inside. So I went ahead. Lalita ma'am is here. She might have seen it. Right. I've taken the two proximal stitches, and now I am taking the stitches on my buccal, and finally I'll parachute my buccal endourethral into that. This is my buccal. I've already harvested a buccal, which is around 1 centimeter wide and around 3 centimeter long. The two stitches have been taken endourethally. I understand the main task of this surgery is seeing those stitches, but actually you are not seeing it inside because visual find it difficult to focus inside. It's all dark inside. I have taken the stitches and I just take the buckle. Yeah. One second. Right. Are you seeing anything? Endo view, auditorium? Yeah. So this is the endo view. I have taken these stitches. Camera key. One is around. Say this is 7 o'clock.
White balance was it?
The other one is around 5 o'clock. This is the part. The most interesting thing would have been to see how this is being taken. But we could not show it to you because it was not, view was not going inside. Yeah. So these are two space that have been taken endourethally. I'll show you once more. See if you can see. Basically, what we do is
Hear us?
Yeah, at around 5. This is the 7 o'clock.
There is some,
So this, there are
Your-
only two
other-
stitches. One at around 5 o'clock.
yeah, that we saw.
And with a forceps, you will be able to end your knot inside. The knot goes in.
Swarnendu sir, can you hear us?
Yes, we can hear you.
There was a question from the chairpersons. What suture you are using, sir?
I'm using 40 PDS. And the needle was a semicircular needle. I just turned the proximal part and converted it into a so-called a Turner Warwick needle. I'm extremely sorry for the poor quality of the video, but then you can see this. We have uploaded it in our YouTube. And as you know, we have a lot of publications on this technique. We have our initial publications in Indian Journal of Urology 2020 as a feasibility study where we have done it on 11 cases with a success rate of around 90%. And then we have published our long-term results on around 25 patients, which is published in Urology Gold. We have till now completed around 70 cases of female urethral stricture over the last 7 years here at AIIMS Bhubaneswar. And our RCT is currently going on. The recruitment is done. We are waiting for our follow-up to get over. The follow-up period is 1 year, where we have done around 35 patients with ventral inlay and 35 patients on dorsal only. And the other things that we have come up and we have presented in the EUA this year on the sexual functions scores on people, ladies who have undergone the quality of life and sexual function scores of people who have undergone this technique. We find the results good at our hands, but now the challenge is to make sure others pick it up, and the internal validity is good. Now we are looking for an external validity where you all see it and pick it up. In Cuttack, in Calcutta, this is the third, and I hope I can go to many more places and show it so that you all are comfortable. We have uploaded it in our YouTube. I'll forward you all the link. People in the OT, my residents are doing it regularly. So these are the last few knots that you give. So there are 2 proximal stitches and 2 distal stitches. That is all. And as you can see, when I put in the Foley will fix it to the bed. So the 2 proximal stitches have been done. Section 3.
Hello, Swarnendu, I am Amresh here. Can I ask you?
Yes, please tell me. I hope you can now see. Cameraman, can you zoom inside, please? Zoom. See, this is the proximal 2 stitches that you can see. These are the stitches are bigger.
Very nice.
The buckle has been fixed at 5 o'clock and 7 o'clock. Camera person, please zoom inside so that they can see. My buckle is now fixed to the bed. This is a buckle which has gone in and it is sitting very nicely. Can you see? Yeah, I can try to give you an endo view again. Can you see? Yeah. So these are my two PDS stitches that you see. The proximal part is the red bladder part, and the distal part is your buccal, which has sit very nicely.
Swarnendu,
Yes, sir. Can you see the end view? I'm trying to show the end view. Camera person, please convert to end view. Yeah, this is the end view. You can see these are the two stitches, the proximal stitches. These are the two PDS stitches. And this is my buckle, which is sitting very easily over the picturotomy part. Now I'll just put the catheter surface. Now I'll put the catheter through silicone. Or you can fix it. No, the catheter. Surface view.
Mandal sir.
Yes, sir.
Sir, we would like to know, is there any specific indication for endourethroplasty, or we can do it in any case?
You can do it in any case, ma'am. We are doing it for all cases, for proximal, for mid, for distal, every part, and for, as in this case where we had a proximal as well as a distal stricture.
Is there any contraindication, sir?
No contraindications, ma'am.
Urethra is completely steno, or still we can do it?
We have not encountered such a case here, but in case that is there, we can do this. But again, in a female, we have not yet encountered a complete picture as we see in a male. I take out my speculum and then I'll fix the pucha. The externally, you will now fix the buckle at 2 points.
Put a guide wire, then we can do this procedure.
Yes, I could not hear you. Please tell.
Swarnendu, the question was that if guidewire can go through the urethra, then this procedure can be done. That is your message.
For any female urethral stricture, you can do this procedure.
You have put the patient in a standard lithotomy position, or you have changed it somehow?
Standard lithotomy, the normal lithotomy. I'll request the chairperson to zoom it back and show the position of the patient. Standard lithotomy, the one which you do TURP, TURBT.
Dr. Mandal,
patient ka position.
are you with you, Dr. Mandal?
Yes, sir.
The audience, there's a question from the audience. What is the position of the patient? Is it standard lithotomy or
Standard lithotomy? Standard lithotomy, sir.
And another thing is that I believe you would agree the most difficult part of this operation is taking the stitch in the depth, apical stitch.
Sir, that appears to be most difficult, but actually it is not so. We all urologists do the PFUDD surgery where you take the apical stitch. So this is just like a progressive perineal urethroplasty in a PFUDD case where you take the apical stitch. You make your needle J-shaped and then you take the stitch. This is just like that. It appears difficult, but actually it's not so. I wanted to show the stitching, but the problem was our camera was not giving you that endo view.
That's true. That's true.
Swarnendu,
Yes, sir. Please tell.
if it is a mucosal and submucosal stricture, why not to do an optical urethrotomy?
So the results of optical urethrostomy are bad. You know, in male, it's 10 to 30% success, and female, results are not that good as well. That is probably the reason why this flap urethroplasty is developed, because earlier these ladies were kept on urethral dilatations and OIUs, but that only gave temporary relief. So we were looking for some permanent way out. And if you can see, many there are multiple publications on various free flap and free graft, sorry, and this medical flap vagina from the vestibule that have come up.
Thank you.
Starting to OT2, where
We are done. Thank you.
Yeah, where
Sir.
Yeah, sorry. Dr. Saranandu, before you run away, I have a question. So, you have any sort of experience with anal mucosa? I mean, as a graft, vaginal graft?
Sir, we for postmenopausal ladies, is buccal, vaginal. But generally, we have a preference for buccal unless and until the patients in this part use a lot of tobacco. In those cases, we use, but for postmenopausal women, the vaginal mucosa doesn't give good results. 600.
हमने 2 watts 20 hertz में स्लो होता है, लेकिन थोड़ा अच्छा लग रहा था। कल मैंने किया और
forward for joule energy.
Dr. Sir,
very fast.
Sir, one photograph.
मेरे को भी भेजते हैं।
हाँ sir.
hello. Yeah, Dr. Sir and Dr. Pushkal.
Need my technician, my
मैं भी लेके आ रहा हूँ।
sir.
Can you in the auditorium?
Yes, sir, I can hear you. One guess.
थोड़ा फास्ट कर दो।
Sir, I have
OT2 to Dr. Arup. He has just completed the case.
Sir. So as the OT going on other side, and I did not want to, our Sandras are waiting for me so that I completed the case, and after that the morcellation was done with rotating type of morcellator, and in less than 5 to 6 minutes time we complete the morcellation, and you can see the urine color. It is just like normal saline. You can see the color in the tubing. So we are not applying any.
बहुत देर बाद अरे इन्होंने आज सुबह से खून चूस रखा है।
Okay, Dr. Arup, so
नहीं बुला रहे हैं, आने का मतलब नहीं है। कल हमने 2 बजे ओटी बंद कर दिया कि ये आएंगे, नहीं आए। ऑडियो वो बंद करो, OT 1 से ऑडियो बंद करो प्लीज।
hello, Dr. Swarnendu.
Swarnendu sir, two more questions to you, sir.
Yeah.
Yes, sir, please.
I am Dr. Pushkal Bakchi.
Sir.
We do
Other OT, I think.
the mucosa, buccal mucosa in 3 layers for better inosculation as well as imbibition. So you have fixed the proximal and distal with 2 stitches only. What about the buccal mucosa? How it will be fixed to the deeper layers?
Sir, there are 2 proximal fixation stitches and 2 distal fixation stitches. The rest, the catheter stays over it, and then we will curve this catheter to the abdomen. So if you, I'll request the camera person to show again. So as you keep the catheter up here, can you see, sir? Yeah. So the pressure of the catheter keeps the buccal fixed to the bed.
How long do you keep the catheter?
Catheter, ideally, initially we were keeping it for 21 days. We were discharging the patient on POD 3 with a catheter. But then the results started coming out in a male urethroplasties where you can remove the catheter as early as 7 days. So we have started a study at our center. Currently it's going on. We have completed around 7 patients where we are removing this catheter on day 7. And till date, we have not encountered any problem with an early catheter removal. So in this patient also, I'll remove the catheter at day 7. The patient goes home at day 3, comes back to me in the OPD at day 7 to get the catheter removed.
That has been the practice for how many cases now?
So this is the last 8th case. 7 we have done with 7th day catheter removal.
Duration? Means
Sir,
over how-
over the last 5 to 6 months, sir.
6 months, okay.
Yeah.
What size of the catheter do you prefer?
16 French, sir.
16 French, obviously silicone.
Yeah, it's a silicone one. It's a silicone one, or these days we have a lot of those siliconized catheters which are available. We have it in our hospital supply, so we use them as often because we are finally removing it on day 7. So we do not keep it for a long period.
What advantage do you have? Like, why do you remove the catheter in a hurry?
In early period, the early catheter removal does not compromise the surgical outcome, and the catheter induced UTI and the catheter induced pain scores go down significantly.
Sir, can I ask one question?
Yeah, please go.
Dr. Swarnindu sir, your choice is ventral inlay for all the patients, or you are opting for dorsal onlay also some patients?
Ma'am, generally it is ventral inlay for all patients, but we were carrying out a CTRI registered RCT where we had to do, since dorsal onlay was the most commonly performed procedure worldwide, so we took that as a standard of care and compared it with our ventral inlay. So for those subsets which were randomized, we opened up the envelope, and as it came out, we proceeded. But otherwise, the preferred technique at our place, at our hands, is a ventral inlay for all strictures.
Okay, thank you, sir.
Do you do endoscopic assessment post-operatively?
If the patient has a trouble, sir, so if the patient doesn't have a trouble, we do nothing, except that the initial cases where we were removing the catheter early, we went ahead and to see what's happening. But then we realized nothing actually is causing a trouble. So then there's the other concept. Buccal only provides a scaffold over which the urothelium grows. And this is what we feel is happening. So there was an earlier hypothesis where the buccal stays and then you are able to see the buccal. But we have realized that buccal doesn't stay. Buccal just provides a scaffold over which the urothelium grows. If you do a scopy in a male or a female after maybe a month, you find nothing. It's all normal.
May I ask one question?
Yeah, please.
Sir, there is another question. Sir, Swarnindu sir.
Yes, sir.
Dr. Swarnindu, this is Udita from Nepal. And
yes, ma'am.
What is the recurrence rate you while doing ventral inlay?
Yes, ma'am.
The recurrence rate, like.
Ma'am, I'm not able to hear you. Please repeat.
What is the recurrence rate you have faced till now, sir?
Recurrence rate at 1 year is 10%, and at 5 years is 15%.
So how do you deal with it? Like, do you go for optical internal ureterotomy, or do you?
No, people who have failed a ventral inlay, we go for a dorsal onlay. People who have failed a dorsal onlay, we go for ventral inlay.
Thank you.
What are the complications like you anticipate in these type of ventral inlay cases? And what do you advise, like who tries such cases? Like what caution they should practice?
Few cases we have encountered hematuria in the post-op period. So to prevent that, we put a vaginal pack, and we make sure that the catheter is inflated by around 10 cc and it comes at the bladder neck, and it causes tamponade over my bed so that the buccal is fixed to it. But generally this is a self-limiting one. It generally is limited within the 6 to 12 hours and it resolves by the next day.
One thing which really worries me, like when you were giving this, when we were doing the ureterotomy, And sir had asked you previously, like, is there a chance that you may injure the vagina, which
No,
may?
there's no chance. There's a very thick layer. You have 4 layers of urethra: the mucosa, the submucosa, the muscles, and the serosa. And then you have the vagina. The vagina has the vaginal epithelium and the subepithelial tissues. So we have never encountered this problem here. And all of us, we have 5 faculty here, all are doing it. All my residents do it. And there are more than 6 residents who have passed from my centers and all have done it. And never we have come across this problem.
Okay, can we practice some technique where like we ensure that no injury to the vagina happen? Like
You
either
are cutting endourethally, you are cutting the mucosa and the submucosa. So you have still the muscle and the other layers intact. So it is very unlikely to go till the.
Is there any
vagina.
evidence of uretrovaginal fistula or something like?
None till date.
Okay, thank you.
Okay, if there are no questions, thank you from the audience. Thank you for
sir.
big applause from the end. Good demonstration of a procedure.
Thank you, sir. Thank you, sir. Is it big? छोटा कर लो. इससे भी छोटा है.
Is it? What is
It's very tight.
the other OT?
हाँ,
You want?
मेरा ये आ गया. चलो ठीक है, उतना ही रखो. शेयर है ना. हाँ हाँ, ये रखो. उसको स्ट्रैप कर दो. कैथेटर स्ट्रैप करो. बेनोप्लास्ट लो. साबिक बेनोप्लास्ट लो. ठीक है.
We are going to have Dr. Rohit Joshi. In the morning, he has done a Urolift case in OT itself, but Urolift is a very short procedure. So what he wanted was, and what the company also wanted, that Dr. Rohit has got a recording of the Urolift that he did in the morning today. He is on the way to auditorium. He will do a presentation of the Urolift, that video, and he will take the questions here. So Dr. Rohit Joshi from Ahmedabad, he is on the way to auditorium. So as soon as he comes, we'll start that. OT3, the thulium fiber enucleation, that is getting ready. And so, yeah, so we're just getting OT3 ready. Are we ready with the OT3, Manoj? I think OT3, Dr. Prem is going to do a bipolar TR. That's it.
How do you manage your female urethral strictures? Can you elaborate in 5 minutes?
I believe, honestly speaking, people in my practice don't readily agree too much for urethroplasty. Many of them are managed by Otis urethrotomy and urethral dilatations. But yes, urethroplasty is the standard of care today, and we must offer it. And if they take it, I prefer a dorsal only, ventral only I have not done, but this looks quite good. And probably this procedure does not interfere with the clitoral nerve supply, and we expect that the outcome of, if they're sexually active, the outcome will be better.
What about incontinence?
Incontinence does not
Stress.
Stress incontinence, I have never, I don't have that much of experience.
Because
to
the
comment on it.
urethral pressure zone is gone by this.
That's true, that we can, it looks that it may be having more incidents of stress incontinence. But people who have got large number of cases, they can only comment on it. I believe Dr.
Hello. Hello.
Mr. from Tata, he does a lot of these urethroplasties. He can say stress in.
Not, sir. We have not seen that. In fact, as far as incontinence is there, I have got where I have attended a conference. There, Dr. Kulkarni and others were stalwarts were there, and he told us that cut as long as you can. There will be no incontinence. He has told us, and that has been a great boost for us, and we have been now more bolder and cutting more proximally and doing the urethroplasty. And till now, in my, might have done maybe 150 or so. No incontinence has taken place still. As far as incontinence are concerned, usually the patient who has recurrence after dilation or urethrotomy, only they come for operation. And in few cases where there is already uremia or bilateral hydrourethral nephrosis, then we strictly tell them to go for operations. They are the indications as far as that.
Hello. Am I audible? Hello.
Yes, Dr. Dheeraj, just wait for a couple of minutes. You are audible. Am I audible to you?
Sir, how?
Yes, sir. Yes, sir.
Just wait for a minute.
Dr. Prasanth, there is a question from the audience?
Sir, I want to ask, sir, how many recurrence rate for 150 female patients, sir?
I believe Dr. Mondal answered during his, he said.
No, I want sir's experience.
They are recurrences, definitely. I have not less than recurrences out of 150 cases.
Sir, all patients are operated on dorsal only?
Dorsal only. I have not seen that this ventral only I have seen for the first time. I will try next time.
Sir,
but I do only dorsal only.
We found that the patients who are on repeated dilatation before procedure, before surgery, they recurs more commonly. Is it so, sir, for your practice also?
I don't say that repeated dilation will be causing more recurrences. In my view, recurrence is if you don't cut the whole stricture and go to the normal urethra, the chances of recurrence are much higher.
Okay, thank you, sir.
Okay.
Most of the times we found that when the apical stitches are there, that area got stenosis or recurrence rate of stricture.
I didn't get you, please.
The apical stitches, what we are taking on the proximal urethra,
Huh.
there most of the times the recurrence are common.
That's quite expected because as you rightly pointed out, unless you have done a proper sclerotomy and have not gone to a supple and normal part of the urethra, the apical stitch has to ensure. You cannot ensure that it is natural to fail. And if at all it fails, it has to fail that area. Because that area is the most difficult
Most
area.
difficult area. Yes.
I just want to add one thing. Definitely, it is not like a male stricture where if you don't go into the normal urethra, you are bound to get a stricture. Here, if distal portion is very narrow, sometimes it is very, very narrow, and you cut it and you are very not able to go to very proximal in some cases, even in those cases, stricture may not recur. It may sometimes, may not sometimes, but if it is distal urethra is very narrow, and if you cut proximally, and if you go up to the stricture, now I become, because after Dr. Kulkarni's comment, I have become much bolder. I go very, very proximal now, but really I have fear of incontinence. I might not have been cutting very proximally.
Hello, Ariana.
Didn't take place that much.
Sir, I want to ask you a question, sir.
Hello.
Just to you
Hello.
question. It's like when you get female urethral stricture, straight away you go for urethroplasty, give a trial of dilatation or urethrotomy first.
Sir, this I always offer. The dilation is there and urethrotomy.
On.
Always tell them what are the good and bad things about the stricture, the two options, and the patient chooses whatever is correct for him.
I believe there is already a case presentation.
Sir, can I ask two questions, sir?
The case presentation is ready.
Sir, I would like to thank the chairpersons for this engaging and
Sir,
enlightening
please,
session.
sir, please.
Yeah.
I want to ask one
Okay.
question to expert. Sir, I have got two questions. First of all, what are the standard investigation to diagnose the urethral stricture in female patient? To the experts, what are the standard investigation? Second thing, what are the standard line of management in case of failure of the stricture?
Answering the last question first, I believe that Dr. Mandal answered it. Urethroplasty today is the standard of care. If the ventral only has failed, they go for dorsal only. If the dorsal only fail, that is the ventral only. If both fails, he has not answered. I believe both fail, you have to fall back upon your age-old management of dilatation and urethra. First question. What was your first question?
What are the investigations?
Investigations, I believe the same ultrasound, uroflowmetry, MCUs, and cystoscopy with a narrow cystoscope, maybe a ureteroscope or a thin pediatric cystoscope. So these are the standard investigations. I believe if
Another question is whether UDS is mandatory in your stricture cases, whether you will perform UDS, because many of the strictures may not be there stricture.
I believe it's not mandatory, but then definitely it's desirable if you're suspecting a hypotonic bladder or if there's a chronic retention kind of things, then probably it's desirable. But if you have an anatomical narrowing at the level of the urethra demonstrated by, say, cystoscope or by MCUs, then I believe there's some optional investigation to my mind. Anybody else to? I believe there's some optional.
Out of 150 cases that I have done, I have found that in patients who have got uremia, we should be very careful, because in those cases, chances of atonic bladder might be there. Say, I have got 2 successful urethroplasty where he is unable to void. Later on, we found that it is case of atonic bladder.
I would like to thank the chairpersons for this engaging and enlightening session. For the next session, I would like to invite Dr. Tulasi Mohapatra, sir, Professor Emeritus, SC Medical College, Cuttack, Dr. Joseph Philip, Professor, Mahatma Gandhi Medical College and Research Institute, Puducherry, Rajkumar Sharma, Stone Urology Center, Ranchi, Dr. Sukant Padi, Senior Consultant, Kalinga Hospital, Bhubaneswar, Dr. Deepak Kishwal, Assistant Professor, Raipur, and Dr. Pankaj Kumar, Dr. Dheeraj, if you can hear me, please start with the presentation.
Good morning. This is a 49-year-old gentleman with a and widening lutes for 2 years. There is no significant improvement on medical management, and there is history of AURs 1 year back. IPSS is 27. There no comorbidity. 3 form prostate. Anal tone was normal and BCR positive. Serum PSA is 3.8 and serum creatinine is 0.9. HUN 82 cc prostate with large median lobe. This is the uroflowmetry with maximum flow is 6.9. Now, you can start.
Dr. Dheeraj. Prem sir, can you hear me, sir? Tea, coffee, and snacks are being served in the trade area right now. If anybody wants to have it, they can move to that area. And no food and beverages are allowed inside the auditorium. Please keep that in mind. Prem sir, can you hear me, sir?
Hello, good morning, Dr. Prem. Can you hear us? Dr. Prem may be connected now. Dr. Prem connected now.
Sir, ready. 7 number class. Sir.
Dr. Prem, good morning.
Hello. Hello.
Sir.
Can you hear? Hello.
Sir,
Hello.
good. Hello.
Dr. Prem here. Hello.
Sir, can you hear us from the auditorium? Hello.
Hello.
Can you hear us from the auditorium?
Yes.
Yes. Sir, good morning, sir. I'll hand you over to the chairperson.
Good morning.
So the chairpersons want to talk to you. We just Dr. Dheeraj who presented the case to us. Now, the chairperson, Dr. Tulsi Mahapatra, Dr. Rajkumar, Dr. Sukant, and Dr. Pankaj is there. So I'm handing over the mic to the chairperson, sir.
Thank you. No. दिखा नहीं देख लेते हैं. दिखा ना मीटर्स कैसा है. नहीं मीटर्स कैसा है. एक मीटर्स डायलेट करने के लिए कुछ है. कैप देखो ना.
Please focus on Dr. Prem Kumar. Zoom out.
You have window. Yeah. Camera. So as the history has been presented, so it is around 82 grams prostate, and as you see in the ultrasound, there's a large median lobe. So I think it's an ideal patient for bipolar TURP. So usually we do all TURPs by bipolar only in our place. So we'll be using the Olympus generator, and the working instruments are from Storage. Light cable. क्या कितना बिल है अपना? नहीं इसमें है बाइपोलर. तो कितना का सेटिंग रहेगा?
3 to 5 के बीच में
रखो.
5 मैक्सिमम है और 3.
ओके. वो वीडियो हम यूज करेंगे. चलो जाएगा कि नहीं. एक मिनट. ये तो टाइट है ना. वही हम बोल रहे थे टाइट है. आउटलेट इसी में रहेगा. वाइट बैलेंस गॉच पीस. मीटर्स डायलेट करने के लिए कुछ है. मीटर्स डायलेट करने नहीं है ना. अभी तो मांगा नहीं है. वाइट बैलेंस. चलो हो गया. चलो ठीक है. मीटर्स टाइट है मैं बोल रहा हूँ ना. अरे ये दोनों में डायरेक्शन एक ही दिखा रहा है यार बाहर जाते हुए.
नहीं सर ये बाहर है.
ये भी तो बाहर है. तो कैसे हो गया? छोड़ो ये होगा. पानी खोलिए पानी. ओके ना. इसका मीटर्स कुछ दोगे राहुल? बस अंदर मत बोलो. इट्स टाइट. चलो. So we'll be doing the scopy. Already scopy has been done once. So we are directly going inside with visual obturator. So it is a 26 French sheath, and using the visual obturator, meatus is slightly snug, and patient is having phimosis, but allowing the scope. So this is the urethra. First we'll go inside. As we see in bladder, there is trabeculation, grade 2. Orifices are just seen. It was mentioned not seen, but here we can see the right orifice. Left is not clearly. So we have a, sorry. So we have a large medial lobe. The bladder neck is congested. And coming back, so lateral lobes, and this is the Veru. And just we should have a inspection of the Veru and a rough idea of the sphincter. So now we'll take the working element. हाँ ठीक है. Stool though, huh? So now they have given us a Covidion electrosurgical unit. So I have not used earlier, but let's see.
Dr. Prem sir.
Yes, sir.
I'm Dr. Rajkumar Sharma. I'm going to ask you that as you are doing both laser or TURP. So what is your criteria in your hospital that you are selecting the case for laser, which case to laser or which case to TURP, sir? What is your...
Routinely, I prefer doing bipolar TURP in all my patients. If the prostate is really large and if the patient is willing, then only I give the option for laser. So then I do thulium laser. I have thulium laser, but usually I will prefer doing bipolar TURP.
Okay.
But I am not very rigid about laser, but if the patient wants or he can afford, suppose, and then I'll give an option that too when the prostate is preferably more than 50 grams. But less than 50 grams, I'll not like to give the option of laser.
Okay, sir.
So as the Veru, we'll do an initial marking. So here there is a large median lobe. So either we can just remove the median lobe in this part, which is intravesical, just at the level of bladder neck, and then do the second part, or we can bring our sheath out and take cuts up to the Veru. So we will try and first remove the median lobe. So here the length of the median lobe is like more than the length of the lobe, that is more than 2.5 centimeter. So we need to bring the sheath little out and then hold the sheath at the Veru and then complete the cutting part.
And Dr. Prem sir, which bipolar system you are using now?
Here it is Covidion right now, but in my place I use Torch and I have a Indian LN, that Combimax and Shalia. So they work very well and they are really cost effective.
Here you are using Storz resectoscope.
Yeah, resectoscope is Torch, but the generator is from Covidion. Population badhao na?
I think they are compatible right now.
Huh? Yeah, we're just changing the cable. There is some problem with the cable. So we are not getting coagulation also.
What are your bipolar settings?
Here they have a setting of 3 and 5, but in our institute we use around, that's 170 is cutting and 120 is coagulation. But here it is from 5 is coagulation and 3 is cutting.
Okay.
We are changing the cable. The bipolar, the thing is you have only one cable. In the all other units or the Indian machines, you will have two separate cables. Male and female will be separate. But you can use a, no, sorry. Now we have shifted to Olympus. है ना? The 120 है कितना?
120, 80
हाँ ठीक है, कुछ भी करो जो नॉर्मल करते हैं. 170 and 120 करता हूँ. ठीक है 120. ओके. कटिंग 80 है.
कोगुलेशन बढ़ाना है.
अच्छा उल्टा रखते हो हम लोग ज्यादा. कोगुलेशन कम रहता है. कोगुलेशन कम है. हाँ ठीक है, उसको 100 करो ना. ओके. कहाँ कोगुलेट कर रहा है? Not coagulating. Okay. Oh, sorry. वो change करो ना उसका. Put pedal. और पीछे जाना. कहाँ कर रहा है यार? हाँ ठीक है. Okay, fine. So now we have shifted to Olympus. So the setting is now cutting is 100 and coagulation is 80. Increase the cutting, na? Cutting, हाँ. Increase the cutting, but they will not cut. नहीं बढ़ेगा. बढ़ागा. नहीं बढ़ेगा.
There is Olympus compatible with storage receptors.
They have given the cable which is compatible, but I am having some issues. Okay. उसका working element लेकिन बहुत अच्छा नहीं है.
Sir, he is using Olympus electrosurgical unit.
अभी अब क्या कर रहा? क्या और नहीं बढ़ेगा? तो फिर उसी का दो. फिर वो ये नहीं कर रहा. इसी पे दो ना. इसी को दो ना. है वो है, but I am not that familiar with that. इसीलिए इसमें क्या प्रॉब्लम हो रहा है?
This bipolar unit is compatible with stores the hardware. The Thunderbird, they have to use only Olympus system.
Yeah. So that is problem we are having. इसमें
Olympus
काम कर रहा है. ये तो ठीक ही कर रहा था.
Or if you're using a stores resectoscope, use the autocon machine if it is there.
So they could not get the autocon, so that's why there is a problem. Pedal the दूसरा pedal.
If there's the Olympus diathermy unit, use the Olympus diathermy unit with the Olympus resectoscope.
Yes, sir, we'll change to that. कितना है? लगाया है? ओलंपस का सामान भी रेडी रखो ना. ओलंपस का सामान भी रेडी रखो. ओके ओके. ओके.
अब ठीक है, फाइन है। हाँ, फुट पहले चेंज हो गया ना, कोविड नहीं, ठीक है। नहीं, ये काट रहा है कि नहीं यार?
Dr. Prem,
यस सर,
actually, Olympus is not compatible with this.
we are going to Covidian again, otherwise I will go to change everything. अभी ठीक है, हैं? Yeah, चलो। So we have shifted back to Covidian.
Your settings are still 3 and 5.
It's 5 and 5. Only problem is we are having some the cable na, there is spark from the cable, that's why. और दूसरा केबल नहीं है कोई ऐसा? कोई दूसरा केबल है?
That is the most common with this
Yeah, that is a spark is quite significant. No. We'll change. ठीक है? वो दे दो, Olympus को सारा सेट दो ना? Give Olympus set ना? No, in cutting there is a lot of spark, so we have to stop. Then Olympus के सारा सेट दो ना? निकाल लो ना? Okay? चलो, दो, कोई बात नहीं, जो होना तो ठीक ही है। इनलेट किधर है? इधर होगा ना?
वो बोलने के लिए खड़ा है, बोल दो।
जेली प्लीज, वॉच पीस दो ना, जेली डाल।
Hello. Audio.
Prem sir will be coming back to you. Meanwhile,
Okay.
While in OT2, Dr. Vivek is waiting for a case presentation for Thuflef, which will be operated by Dr. Chandramohan Vaddi sir. Dr. Vivek, over.
Hello, am I audible, sir?
Yes, you are audible.
Yeah. Good morning. This is a 69-year-old gentleman who had presented with storage and warding LUTS for the last 6 months. At that time, his IPSS score was pretty high, around 34. 2 months back, he had an episode of AUR, during which he had recurrent episodes of AUR and trial without catheter was unsuccessful. He doesn't have any comorbidities, and on examination, there was a grade 3 firm prostate, and the serum PSA is 3.3, his creatinine is 0.8. Ultrasound showed a 62 cc prostate with upper tract normal, and urine culture showed no growth. So over to Dr. Chandramohan Vaddi sir for Thuflef. Thank you. Uber.
होना एटा दिले चार्ज बस दिल्ली से चार्ज बस ना फुल ऑफ कर दो
We can go back to OT3 with Dr. Prem until Dr. Chandra Mohan is all mic'd up. Dr. Prem, we are with you.
Yeah, so we have to change everything. Now is the Olympus system and cutting is 200 and coagulation 122.
Yeah.
So, let's see. So
Earlier, the coagulation was not very effective, right? Dr. Prem?
no, it is not compatible with storage also. And there was spark from the storage cable, so we have changed to the.
Okay.
So we'll just try to rectify.
So now you're comfortable with the thing?
Yeah, fine, fine. Thank you.
Thank you.
So this is a medial lobe. Yes. Just trying to be little cautious that don't go subtrigonal in the beginning. Otherwise, everything is like normal TRP only.
Prem sir,
Yeah.
do you find any difference between this monopolar or bipolar TURP while you cut or coagulate?
Usually, it's like bipolar is a little slower, but you can go fast also. Only thing is the coagulation effect will be little less. So if you are using a thicker loop, new loop and starting, then you can be slow, but gradually you can increase your speed. Usually bipolar is slightly slower, but it's not like that always. You can do fast resection also, but you will see some small bleeders. But then bleeding is less in bipolar and easy manageable.
Right.
But if you are like some people, they operate very fast in monopolar, the speed will be slightly less. So I think now we have made a trench. So now we will go for the lateral lobes. Here usually what we do, so before going for the mid fossa resection, what we do is as we use in laser, here we'll make a groove. There's a marking also and this will help to do mid fossa resection better. So this is not for apical tissue right now. It is only for the mid fossa resection, so that we'll take long cuts from bladder neck up to Veru. So you know the adenoma is here, so we'll just make a marking here. Good. Yeah. So as most of the right hand surgeons, we start from the left lobe. So here we can take long cuts. And not all bleeders need to be coagulated. Once we start reaching the capsule, probably then it is important to coagulate the bleeders. That's okay. Bladder neck high only. ये रिकॉर्ड करो ऐसा रिकॉर्ड ले बायलेटर bladder neck high. So we will go try to do one low
and then again come back. Try to finish the left lobe as much as possible. Hello. Then go to the right lobe. In bipolar, even if you
Video.
Prem sir, we will get
Dr.
back to
Prem's,
you. Right now, we are with Dr. Chandramohan Vaddi sir.
okay.
Over to you, sir.
Hello.
Yes, sir. You are audible, sir.
Good morning, sir. Outset, I thank the Urology Society of India Female Urology and Bhubaneswar Urology Society for giving me this opportunity. Frankly speaking, my experience is I have done 50 cases with 2 flap because I don't have 100 watts ohmium. I'm both for the stone and this thing. First thing I do is OTs, whether it is catheterized or not catheterized, lot of jelly and jelly, and I will observe the both ureteric orifice like here, so that I will have an idea what I am doing. And bladder neck is very high here, and it is so-called median lobe. You can incise. These adequate size around 60 to 70 grams. Ideally, you should come out and see what is the on the floor. You come out like this. Come out. When you come out, the sphincter will be open. This is a catheter. This is a sphincter. This is a sphincter. You should not damage this area. This area. That you keep in mind. Now, whenever you go for the fingers, you can turn up like this and go, so that damage will not come. If you go like that, you can damage like this. You can go up and press. See, even with full press, it is not going easily. So, withdraw the laser fiber. These are the essential steps. This is coral starch equipment. What on, please? So, you go like this inside carefully, like this, and one is the bladder neck. All this problem will not be there. While you doubly ensure that you don't go near. Regarding the laser settings, there are various laser settings. One laser setting, which there are 3 types of laser settings. One is 4 watts and 13 hertz, which is very high, and it cuts very fast. That I am using now. What's the blood pressure? See, it cuts very fast like this. What's the blood pressure? And you concentrate on one area. 160. Just bladder neck. It is on the large. It's like bladder neck incision, so that the flow will improve. This is the first thing I am doing. Can be done with loop. Can be done with. फिर उसको काटे. नहीं. This is.
Could they play other TURP bipolar? Both the screens.
You complete up to initially I am doing here because by chance if you
Can they show the end?
if you want to reinsert, it will be easy. Once it is done, patient will void. Even if you don't do anything, patient will void. Do not that is advantage. But
voice is not very much clear, sir. Your voice is not very much clear. Also, we want both the PIP in both the screen. Yeah, right.
We want the endo view from
Yeah,
OT.
endo view from the both the OT. Yeah.
दिख रहा है.
Chandramohan sir, good morning,
Yes,
sir.
I am incising the bladder neck on the right side of the. This will take time. We should spend time here. We should not be in a hurry, and we should not try to do this lateral one now only. See the charring. If you do on the capsule, the charring will be less. So completely till the last level, you do it. Have patience here. That will define the level of entire surgery. It will almost go parallel. See, it almost touches here. This is the hypertrophied bladder neck. People used to cut up to the ureteric orifice, bladder neck incision. but that we will not do. Now it is flattened. After flattening, you can take a turn like this slowly. Slowly, same area you be there. If you change the area, this is a coral star which has a beak on either side. Area. Can you see, sir? And you can do this area also. Same like the standard bladder neck incision. So if you do this, major part of the surgery will be, the water outflow will be very good, entire surgery. But this appears time taking. Even if you do with TURP, it will take time. It will go up to the capsule. So in TURP, to go to up to capsule, it will take 15 minutes time. Time you have to spend here. So ultimately, these two should be united here. Here they are united. For example, here a marking reverse. You are going here, and then here also marking here in this groove like this, and then these two will be united and lifted up like this. This is the first step.
Sir, are you planning to enucleate the prostate en bloc, or you will?
No, sir, no en bloc, because this is too big. Medium lobe. Medium is very big. Better finish it off nicely. If it is small, we can do. See the amount of the high bladder. If high bladder neck is there, water outflow will not be there. Necessarily procedure, because see, this is the fiber. This is the fiber. See, almost operating here. Here. There is later part of the surgery, it becomes millimeter by millimeter. Millimeter by millimeter. Here the prostate gland will be just in front. You meet these two, almost they are related. That much patience you should have in the beginning. Otherwise, entire procedure, see, it will be yellow like this. If it is white like this, it is a capsule. That is the identification. Whereas in thulium, everything looks, see, while dividing this, you may open this elevated part. You may tear see, I am tearing here. This is the outer layer of the prostate capsule. Here you have to turn like this, turn. Initially it appears charring, turn like this, so that side of the gland will go away, like this. Same thing will continue while the lobe is done. Now I am going laterally, like this. It's making a toe, so that water flow will be better. Initially, all this looks easy. As you proceed, enucleation becomes difficult. If you lose the plane, it will be difficult. See, I am meeting here. I am meeting here. This is a pure capsule. But there is no bleeding, absolutely no bleeding, because it is highly. Now, horizontally, I have cut already here. Now, I will finish this also and remove this, the medial lobe out. See, here is the cut. I am coming here. Once you do this, the base will be defined.
Chandramohan sir.
Yes, sir.
For a beginner, how to fix that laser fiber? How much distance it should be from your
For example, your question, if you do like this, for example, your precision will go. See, it is not cutting.
Yes,
it is not cutting very nicely.
Yes.
So if you go close like this, it is dangerous to the scope.
Yes.
So you have to keep 1 centimeter like this, so that it works like a pen. And you are not using the working element here. Slowly, first it is an end firing, not side firing. So you should keep, see, I am opening the capsule here. I am opening the capsule, that is dangerous. This is a common mistake. In the last, you see, that will be a very big, opening. Because constantly, it causes a stretch and then causes unnecessarily capsular perforation, with which water absorption can occur. Even in this. Now, this is the last part. If you have any trouble, you do like this. If you have any trouble, you will do like this so that you will get a bigger opening and water flow will be very good. See, like this. Like this. See, they are getting separated. It's a very high voltage. Nearly 4 watts. 4 watts is too much. 4 joules. 4 joules and now. Now I'm getting the last part. Enjoy the service.
वापस भी जा रहे हैं करंट के साथ.
But if you see in a less than 60 grams prostate, the time taken for enucleation is very high. It will take minimum 1 hour, 1.5 hours, whereas most of the prostates can be finished in 45 minutes. So less than 60 grams, I slightly feel. See, like this you separate. See the capsule. There is charring. This much charring will happen with QRP also. So they don't worry. At the end, this charring will not be seen. See, nice. This, now you unite this. You have to unite this. It will lift up easily.
Sir, are you moving the whole system, your receptoscope, or only your working
Can you
element?
see, sir, capsule here?
Yes, sir.
I'm not lifting anything. I'm rotating. You can somebody keep on the. See, this charring is a negative of the thulium fiber laser, but 0 bleeding, and I am on the capsule. So what will happen if some yellow is seen? Nothing will happen. Just because white is there, you cannot say it is very good. And one more thing, now this is a 30 degree. All of us will use the 30 degree here. So that's why you should turn up like this and then lift, then you will not cause any damage to the capsule. It will touch the prostate. This is the point, very important point. It took time for me to learn this. See, you cannot touch the capsule, you can touch only the gland because it's 30 degree, like in laparoscopy. Like this, I am uniting. It will finish fast because 2 lines you have defined. You should know where you are coming here. You should know where you are coming here. Here. It will be depth here. Like this. So I am pushing the gland into the lumen. A lot of people say that you don't see the capsule in the thulium fiber laser. That is not correct. You can see it, but only thing is that if you stay, for example, if you stay here like this, it will char. You should keep on moving a little away from distance. Nicely, it will lift up. Now, here, where I back and see where I am uniting. So this part is their bridge. I will cut this bridge. Otherwise, you will be going deeper. Where you go, you don't know. So here it is released. This is definitely capsule. This is definitely capsule. Now come like this and reverse the camera. And now you start again lifting. Nice white plane will be there. This much time you have to spend. If you don't spend, you will be missing the planes. Learning curve is more. See, here it is bleeding. So just apply, same from distance, it will go. See, I am turning like this. Entire gland is lifting up. Entire gland is lifting up. This is high energy. As 60 watts full you are utilizing. Can you observe that I have cut the laser obliquely, like a beak, and laser fiber is not at all burning. So much heat is released. But laser fiber, it is last 5 minutes, hardly 1 millimeter of laser fiber is also not burnt. Like a pencil, we are diverting. Only thing you should know where you are coming out.
Could we go to the audio to the bipolar? It's a bit too loud.
Pardon, sir?
Hello.
Sir, for a few minutes, we are going to change to OT2 with Dr. Prem.
Sir, OT, we'll be going to OT3, sir. Prem, sir.
Can you see the all the medium lobe going, sir?
Vadi, sir, we'll be going to another OT.
Yeah,
Prem.
yeah. Please.
We'll be back to you, sir, soon.
Okay.
Prem, sir, can you hear us, sir?
Hello.
Ah, yes.
Yeah,
Yes,
yeah.
sir.
So I have nearly, so this is the Viru and this is the left lobe. We can see the capsule so well. And this is up to the bladder neck. So we have nearly completed the left lobe. So it's not, you can resect the whole adenoma with bipolar very well. Even if you injure the capsule, nothing is going to happen. It's not, it doesn't split like in monopolar. And you can just coagulate the bleeder. So the resection in bipolar is good, and the speed is also good. Like you would have seen, the speed is fast. So that way bipolar is good, and we all are trained with monopolar. And the cost of electrosurgical unit is also not that high, and it makes life like easy.
Dr. Prem, whether
Yes,
this
sir.
this monopolar type resection is comfortable or enucleation bipolar is comfortable to you?
No, sir, I prefer doing TRP only. I don't do enucleation with bipolar. Except in bladder tumors, I do en bloc. But in TRP, I do TRP rather than enucleation.
Acha, they always there is a presentation that by enucleation, the bipolar bleeding will be less and the results are good. What is your opinion?
Yeah, here also the bleeding is less. You are seeing the bleeder, but if you see the return will not be that dark. So
Yes.
definitely bleeding is less in bipolar. But again, if you are doing enucleation, then you have to go for mosylation. Mosylation has its own benefits and drawbacks.
Sir.
So I think so till 80, 100 grams, 120 grams, bipolar really works well, and there is no need of laser. I think you will be seeing the prostate, the fossa after fiber laser there, and here also you see it won't be much different. So the idea is to do enucleation. It's not en bloc. We are cutting and going up to the level of capsule. So still it is, we are removing the whole thing, not removing in toto.
The achievement is same.
Yes, sir. And here usually I take continuous cutting. I antegrade, retrograde simultaneously. Wherever the gland is bigger size, so I keep on cutting. The loop get damaged early, but that will increase your speed.
And time is also less by doing
Yes,
this
sir.
type of section.
Yeah. So this is like we are doing continuous cutting, antegrade, retrograde, but the loop gets damaged. There is a part of intravesical part, this the groove between the medial lobe and lateral lobe.
Sir, if you would have given 12 o'clock incision from the beginning, that is Silver's technique. So would it have been more comfortable or fast median lobe enucleation is more comfortable?
Nesbit technique is there, but with bipolar you can do anyway. I don't think bleeding is ever a problem. So usually it's better to remove the median lobe or make a groove if the median lobe is not big, and then go side by side. Because anteriorly the prostate is thin. So there are chances ki you will go to capsule easily, and but Nesbit technique is there. But here I think it is your comfort level and one rhythm we have to follow. Either we come from above below or go from below above. But with median lobe, it's very difficult. You will have good water flow. So it's better we make a tunnel and then proceed whichever way we want.
By cutting the median lobe fast, all the bulk of the tissue will go up.
Yes, sir.
Then that will be more difficult for resection than below
sir.
6 o'clock.
Actually, if you saw it was very easy to cut the tissue from here, like enucleation, but I did not do, because if I do, it will be very difficult removing it later on. So
Sir,
it's better to be patient and remove it gradually.
Sir, it is immaterial for you, like your experience, but for a beginner, what to do?
So we should remove bit by bit the tissue, and like if we remove this tissue completely like that, so then it becomes very difficult. At the end, we will be cutting inside the bladder, or again holding big chips and removing with the sheath. So it becomes difficult. So we should not be greedy, and it's better to cut slowly like this rather than going from the base. Because we are not doing laser where we are lifting the whole median lobe. We are doing TRP and we will be using ELIC. So that thing should be there in the planning.
Sir.
Even when we do N block, say TRBT, later it becomes very difficult to remove the tissue, and finally we have to cut the tissue.
Yes,
Though
sir.
it must be having muscle in it, but tissue is fragmented, then only you can remove it.
Yes, sir.
Like this is the intravesical part or part of medial lobe. So we are just removing from top to bottom rather than cutting in total. See, the cutting is so smooth. So here again, we can make retrograde cuts. Now we have come to the left lobe partly, and then apical tissue also, right lobe, sorry. So we can make the markings using this retrograde cuts. Or even if you want, in apex, it is better to use retrograde cuts. It gives you better control. And in antegrade cuts, at times, the sheath comes out of the outside veru for the beginners. So if we command this retrograde cut, I think it's very easy.
Sir, you are using an active working element or passive?
Passive. Actually, Olympus working element, it is smaller, so I thought I won't be able to do it. That's why I was using stot, but after using, I feel it is good.
Closed. Okay, no fear of going.
See, like this, we can just, whatever you are seeing, you can use cut by retrograde cut also. The tissue is seen, so you can take a retrograde cut.
Dr. Prem, can we switch to other OT as Chandramohan sir is giving incision in the 12 o'clock and separating the Chandramohan sir, we are with you.
You see, this is the veru. This is the veru. Just turn it off.
Chandramohan sir, OT1. Audio visual team, can you connect to OT1 with Chandramohan sir?
Camera clean karo. Quick. Hello.
Yes, sir.
Done.
Sir,
I
your
have
voice.
come to the para veru region. This is the veru. This. I crossed this and.
So your voice is not properly audible, sir.
Wait 1 second, sir.
Hello. Hello.
बहुत बड़ा मीडियम लोब था, है ना? तो वही ज्यादा था एक्चुअली, उसी के लिए उसका साइज बड़ा लग रहा था, है ना? उतना बड़ा प्रोस्टेट इधर उतना बड़ा नहीं था, बट मीडियम लोब देख रहे हो, उसके कारण उसका लेंथ बढ़ गया तो वो ज्यादा दिखा रहा था.
We are not getting any audio from the OT1.
Adi sir, can you hear us, sir?
Hello.
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 Yes, sir, we can hear you, sir.
Now what I will tell you important steps I have done. This is the median lobe, you can see. Little bit of tissue is here. This is a bit of perforation here. This is the 2 mm depth. If you try to be over enthusiastic, you will perforate here during leak evacuation or during Mars later, it will increase. Have this bed, nothing will happen. After that, this is a quite red lateral lobe. Now I came by the paraveru. See, this is the paraveru. I will show here. I came like this. I came like this. Say I am rotating. I came on to the floor, same level. Till that level is reached, don't make incision into the gland. Otherwise, it will become yellow. See here, like this, you make. Usually, it will be white. By the time you reach the capsule, see, you are reaching the capsule. Here, it is getting separated. Something is pressed. Now, I am coming the same plane like this. Don't see the veru, see the curvature of the gland. Automatically, you will be crossing the veru. See, just follow this. This I have done the other side. Like this. Half of the gland between 6 o'clock to 9 o'clock is lifting nicely here. 6 o'clock to 9 o'clock. 9 o'clock. Lift as much as you can possible. No problem. Like this. I hope you are appreciating the capsules. White capsule. Somebody from that side to encourage me. Like this.
Yes, sir, we can see it, sir.
You can see. See, when you come back, you have these 2 lobes lifted like this. Now, this is the mucosa. I have gone up and inside a little bit here. Just proximal to the veru. See, this is the meeting point. This is the meeting point. On either side, this already I have broken. Can you see? I have broken here. See this area. Can you see the capsule here? Is it, sir? This is the most important step. See the capsule. Nicely on the anterior surface, retropubic region. This is. I have disconnected. This lobe part is over. This part I was doing. Then you came to the mic. So if you go beyond this, not necessary. This much mucosa, you leave it. And rest of the gland you undermine. This much mucosa, you leave it. See now, the capsule is nicely seen here. It is lifting. Same plane you maintain all around. Whether you do en bloc. Now, if you want to come up, here see, little bit of mesh is there. This is the capsule. You can divide this. You can divide this. From the center, I have already come. I am dividing. Once you divide, they will separate like fibers. See. Once you completely divide, it will touch the previously cut area. See, it is slipping. Slipping means you are, see this last piece. This you should be careful, you should not go beyond. That's all. Now this area, on the left lobe, I came like this, I came like this, I came like this, I came like this, and I am finishing here. Here. Same thing will continue to the opposite side, like this. Here I have not done much. First I will concentrate on this lobe. At the same time, while you are not in this thing, I have incised also this. Incised up to what area. Here. This is the end point. Finish. All around capsule is seen. Then you spend time irritating all of them. That's all. If this is done perfectly for 15 minutes, then entire surgery becomes easy. Everywhere it should be go up to the depth of the capsule. If you don't go up to the capsule, see, this is all anterior People say anteriorly prostate will not be there, but for the laser fiber, it is there. See, laser fiber is very small. If you don't cut all this, you will not reach the anterior plane. See, like this. This is the cumbersome part of the. See, now you turn like this. See, everything will come into this. See, that's all. Now sphincter is safe. So if you want to come back and go inside again with Janek and jelly, what happened? Now only you can see. Now I am coming out of the urethra. Now you go inside. Then you always remove. First of all, urethra should be intact like this, like this. Now this is a sphincter area. This water plus, please. This is a sphincter area. So totally, I have not done any damage. Now I am going inside. Now all incisions are beyond this. That's all. Only problem is if you come out repeatedly, it will bleed. So now my safety area is over. Now all around, see, this is the area where I do like this. Like this. Then again, I will do here also for some time. So you do little bit, it will keep on separating. It will keep on separating like this. See, go up, go up, go up, go up, go up, come back a little bit, come back. That's all. That's all. Here you finish. You need these 2 points. These 2 points. A little bit of tissue. If you don't meet like that, entire surgery looks clumsy. Now see, this is a capsule. Now you need this capsule. This one. See, this is a capsule. Automatically it is separating. Automatically it is separating. Now, retropubic region, you come. Retropubic region is already incised here. Like that. Now, combining. Do for 2 minutes like this. Retropubic region. Water on, please. Do like this. See how it is separating. Some amount of yellow is the part, the nature of, see how it is separating. This is at 12 o'clock to, you do for 1 centimeter like that. Don't do continuously like that. Now you come back to this side. This also you do for 1.5 centimeters. See, is a capsule here. It is deep. So come this side. Be on the gland side. Now you unite to the top area which you have done. It is united. Now again you do for only one movement, rotational movement. No forward pushing, no backward pushing. Definitely it is capsule. No doubt about it. People say it is not capsule, it is not seen, then we cannot do anything. It is capsule clearly. See, here you have made, here you see I am turning, and ultimately I will reach to the retropubic region. Here also retropubic region. Do little areas. Don't turn all around. Because wherever you cut, it will go into the tissue. Even pubic bone, I doubt it may char and cut. See, like this. See, this is the area where I have given incision in the center. Here. 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 Like that. So all around capsule reaching is important. Now see below. Now I will do sometime below. Sometimes side, sometime below, sometime like that. See now. As you near the bladder neck, this should not be 30 degrees, should not be down. Otherwise, capsule will cut. You have to go up. See nicely it is rotating. Already done this area. See now you do this side part. This is difficult part. Mixing both of them. You move like this. See, somebody focus on my hand. You will really appreciate. My left hand is fixed. My right hand is rotating. Nicely gland is going inside. You can see the capsule here. Absolutely zero bleeding. Zero bleeding. Like this you go. I am not at all. See, all turning around. See, turning around. Turning to the where I have given initial incision. So first time when I have made good incision on the good incision while doing the median lobe is helping a lot to me. That is a landmark.
Chandramohan sir, Sir,
Yes,
Prem sir is waiting for us in OT3. He's just wrapping up the case. We'll be back to you soon, sir.
Pardon?
Sir, Prem Kumar sir is waiting for us in OT3. He is about to wrap up the case, sir.
Okay. Please, please.
We'll be back to you, sir. Prem sir, can you hear us, sir?
Yeah. So we have nearly finished the right lobe also, some tissues at the apex and here anteriorly also. So we have done. So some little tissues there. What I suggest, suppose whenever you are at the apical tissue, it's always use this retrograde cuts. You have better control. And in bipolar, risk of incontinence is relatively very less. So usually I resect in such cases distal to Veru, and even if the lobe is falling, probably will resect further also. The idea is to stay in lumen, don't go too laterally when you are coming out of Veru. But here we can see prostatic tissue. We can just cut. So this is the apical tissue.
I would like to thank our chairpersons for this engaging session. And I would like to call the next chairpersons for the next session.
Thank you.
Dr. K.K. Panigre, sir, Senior Consultant Urologist, Berhampur. Sir, please come on the dais, sir. Dr. Manikandan R, sir, Senior Consultant Urologist, Miyot International. Dr. Sunilmal Chaudhary, Senior Consultant Urologist, Kolkata. Dr. Udita Mishra, from Consultant NAUS from Nepal. Dr. Arshad Jamal, sir, Consultant Urologist from Ranchi. We'll be now proceeding to OT1, where Dr. Arvind Panda sir is ready with a dorsal onlay repair. Dr. Rohit will begin with the presentation. Dr. Rohit, over to you. Please begin with the presentation.
I hope I'm
Zoom on the
audible,
slide.
sir.
Please zoom on the
I-
slide. Yes, you are audible.
Slides. The second case for today is dorsal only BMG in the OT1. It's a case of 30-year-old lady who presented with predominantly obstructive lower urinary tract symptoms for the past 8 years, on and off. She has been taking multiple over-the-counter medication with which she had no relief. And surgical history, she underwent LSCS 11 years back. Apart from that, her menstrual periods are regular. General examination was normal, and the calibration with around 14 French police was unsuccessful and at 1 centimeter from external uterine meatus. Uroflowmetry, cumulative Qmax is around 10. And coming to ultrasound KUB, the upper tracts are normal with an elevated post-void residual volume. The culture is normal. Patient underwent a cystoscopy in which the proximal and the distal aspect of the urethra were found to be unhealthy. Yes. Now we'll be proceeding with dorsal only buccal mucosal graft urethroplasty by Dr. Arvind Panda, sir. Thank you, sir.
This is an interesting case in which the video which they have shown, will of course do a scopy again, but initially it was showing both a stricture distally and then a stricture proximally just distal to the bladder neck. So if we have to patch and there is a structure there, we have to patch both these areas. And we don't have an MCU. So we'll do a scopy right now on table. We'll see where it is. If there's a distal structure and a proximal structure, then I would probably go for a hybrid technique, inlay and onlay. Because near the bladder neck, inlay itself may be a little difficult to, not difficult, but it sort of stretches the neck and sort of distorts the neck a little bit. So there we're going to do an inlay, after doing an onlay in the more distal aspect.
Arvind?
Yeah.
Yeah. So are you going to harvest the graft now? Or do you want to do that after?
If the OTs are busy, we can harvest the graft.
I think you can harvest the graft. We will have a short presentation on this Eurolift in the meanwhile.
Yeah,
Here in-
perfect. So that's exactly what I was saying. We'll harvest the graft and keep the graft ready, and we'll start after the thing is free.
Great, great. Okay, Doctor.
Thank you.
I would now like to invite Dr. Rohit Joshi, sir, Senior Consultant Urologist from Ahmedabad. Sir has operated a case on Eurolift in the morning in the first session itself. But for demonstration purpose, sir will be showing the semi-live video with his expert opinion and talk. So over to you, sir.
Capsule.
Good afternoon, one and all. At the outset, let me express my gratitude towards the USI leadership, FFUS leadership. Chandra, it is really difficult to get into the scheme of the thing. So can I request to, shut up the OT voice? And I'll tell you a small story. My anesthetist used to give us a local block, and he asked my patient, "दर्द होता है?" तो वो पेशेंट बोलता है, "नहीं सर, थोड़ा सा दर्द तो होता है." अरे इसको दर्द नहीं बोलते हैं, इतना दर्द नहीं होता है. So that's what Chandramon does. Whenever he says capsule, 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 you have to believe it's a capsule. So that is the difference. So that happens when Chandra is operating. Can we have the video on the one screen? Yeah. Only one screen, yeah. So this gentleman was a 59-year-old male patient who had a refractory acute urinary retention, and we came with renal failure. And his create was high. There was bilateral hydronephrosis, and then he was catheterized. His hydronephrosis resolved. His parameters became normal, and then he was subjected for this Eurolift. Yeah, everything is ready. Yeah, this case we operated morning 9:20. This case in totality took us hardly 12 minutes, and that is precisely why we thought we should be doing this semi-live, because all the main steps, it might get away. So this is the case. Can you get the audio with? Anyway, let me give you the live thing. There are a lot of technical glitches over here. So this is what the patient's position is. We all know this is a standard lithotomy position, which we all give for our TURPs or HOLEPs and all that. But the main difference when we are considering Eurolift is we need to have high lithotomy. That is what this distance between that flat and the knee joint has to be little high. So that distance, which is usually half a foot, now we need to increase it to say about 75%. Second thing is we need the patient right at the edge, and little part of the buttocks need to be off. See, that's what I'm doing with my elbow edge of the table, because this is off a little further than the edge of the operating table. So this is all about the position. Now we come to the instrumentation part. So here there is a complete set of instrumentation. This is the conventional cystoscope, which is a 4 mm cystoscope with which do any cystoscopy. This is a bridge, and there goes our sheath. This is for the routine cystoscopy. Now, what difference we have between the conventional cystoscopy and the set which we have for Eurolift is the scope is extra long. So the scope is at least 4 or 5 centimeters longer than the conventional scope, and the scope diameter is 2.9 mm. So it's less than that 4 millimeter conventional scope. And the scope is very, very slender. So it can bend easily. You see, it can be bent. So we need to be very careful while inserting this into the implant. And so two things, length and the diameter. These things makes a difference. So now, because of that extra length, we need to devise a specific obturator. So here is the specific obturator, which has got that particular balance length to counter for the length of the cystoscope. Why do we need this extra length? Because that is to accommodate the stapling device or the implant device. And this is the conventional sheath. Now, we all know why there are markings. Now, we are doing a study, Sanjay, on the urethral length measurement for the females. There, we know the importance of these markings. But in Eurolift, This has got little more relevance than that because we need to understand how much is the length of the prosthetic urethra. And depending on that particular length, we can decide how many implants this patient might need. So this marking has a stronger relevance whenever we are contemplating doing a urolift in a patient. So this is the complete set, 20 French sheath. Then there is an extra long obturator, and then there is an extra long slender 2.9 mm cystoscope. So this is the total assembly which we need, and this assembly is all that we need in pursuing the urolift. Now what we need is an implant. So that is all we need. So whenever do a cystoscopy, once we mark the bladder neck level, then we come back and then we reach to the veru, and that's how we mark the prosthetic urethral length. Because the preoperative ultrasonography, maybe transabdominal truss, might not give you the exact. Here I'm doing, a little bit of a kind of a drawing over there. This is a conventional bilobar prosthetic enlargement. And we all know that, conventional indication for the urolift is absence of a sizable median lobe. So there is a veru. This is the veru. These are two lateral lobes, and there is the bladder. So first of all, what we need to do is doing a cystoscopy using the urolift cystoscope set. Then we go in the bladder, and then we take it at the level of bladder, like we assess the bladder for all these mucosal abnormalities, and then we come back from the bladder neck, and then we measure the prosthetic urethral length. Now, besides the prosthetic urethral length, one more thing which is important is the girth of the prostate, and this is the implant. This is the implant, which is the disposable one. We have to use it and then throw. There are several important components of this particular device. So this device has locks on both the side, and this is the length. This is the extra length of that cystoscope, wherein this implant device's width has been taken into factor. Now this is the needle lock. So this is available on both the side of the device. This needle lock is right now locked towards the patient side. It is locked towards us. It is unlocked. So until unless we release this needle lock, we will never be able to fire the needle. So this needle lock is a very important aspect, because if one misfire is there, it will cost a lot to the patient. So once we are sure about our positioning, that is when we turn this lock into the unlock position, and that is when we can fire using this blue thing. Now, before proceeding further, let us see how much is the angle and all that matters. So this blue and gray, there are two pedals. Now blue is to trigger the needle. Once we fire the blue, the needle will transverse across the prostatic gland up to the capsule. So once the needle is triggered, then we need to compress both the blue and gray. Through that needle, the implant will be deposited. Now this implant has three components. So it will deliver the subcapsular component, which will go beyond the capsule of the prostate. So now we do this cystoscopy with the implant, and it can be either anteroposterior or mediolateral orientation. But whenever we are in bladder, that is only when we can rotate anteroposterior and mediolateral, because the edge of this particular thing is quite rough. So if we do that maneuver within the prostatic fossa, it can lead to certain capillary abrasions in the prostate. It may lead to serious bleedings. And we don't need any sort of bleeding, because in the future thing, while cutting the sutures, we need absolutely clear vision. So we do this cystoscopy, keeping this anteroposterior orientation, and then we turn it 90-degree anterolateral. This is we are doing to cater the left lobe of the patient. So once we are coming there, we need to come at least 1.5 centimeter away from the bladder. And second thing is angle. We need to be parallel to the operative table. Neither we want to do up, neither down. It has to be parallel to the operative table and parallel to the floor. So that is, if you do it a little bit angulation, the implant will go haywire. So this needs to be taken into consideration. Your position of your implant device has to be parallel to the floor. Second thing is how much angle. Now you see, we are compressing. Now the moment we hit the needle trigger, there is a 33 millimeter distance traveled by the needle. So once you fire from the prostatic end, the needle will start delivered. It will deliver across the parenchyma, and it will reach up to 33 millimeter. Now just lateral to the prostate, we come across the bone. So depending on the prostatic girth and the volume of the prostate, we decide how much compression we need to give. So if you are having a 0 degree, and then we can go on, we shift this particular this particular handle on right side of the patient. So we go from 5 degree, 10 degree, 15 degree, 20 degree. So every time we increase the compression, we are compressing the prostate. So that 33 millimeter length needs to be kept in mind. If there is a very small prostate and we are giving too much compression, it is likely the needle will straight away go and hit the bone and the entire implant will go. If the prostate is significantly enlarged, then we need to give a little bit more compression, say about 15 to 25 degree. And even by that, we can have 30 millimeter safe distance. So this is regarding the angle which we need to adjust depending on the patient's prostatic anatomy. Now, there are three components of this particular thing. One is the capsular tab, which I've drawn here. Then there is a suture, and on this side, there is a urethral endpiece. Now, why 1.5 centimeter from the bladder neck? Because this subcapsular tab, that is 13 millimeter length, and the urethral endpiece is 8 millimeters. So whenever we are deploying this, it will traverse 13 millimeter from before backwards. So if you're starting at the bladder neck, the whole implant will go in the bladder lumen. There will be incrustations and the implant failure. That's why we should never start deploying this device unless we are 1.5 centimeter distal to the bladder neck. If that happens, the bladder neck will remain open and retrograde ejaculation and all those things will happen and the whole fun of urolith will die. So this is about the three component and the compression. Now this compression, we need to give it two steps. The first compression is little compression and then we trigger the needle. And subsequently, we give little more compression that will drive the subcapsular component and the suture. Once we do that, we need to move forward towards the bladder that we will show in the actual operative video. And then lastly, we need to cut the suture. So this is how the entire procedure has been explained. The same thing we need to repeat on the opposite side. Now, if the length of the urethra is 3 centimeter, like this case had 2.5 centimeter length, so we had to do only one set of implant on right and left. But if the length would have been 4 centimeter, 5 centimeter, then we might have to have little more implant, a set of implants more. This is the urethral suture cutting tab. Once we are sure, we fix the tab, it will cut the suture and it will leave the implant in place. So the outer way, there will be subcapsular component, there will be urethral endpiece, and in between there will be a suture. Now, why? One can ask why the capsule is not drawing towards midline, why the adenoma is shifted laterally, because the capsule is firm and the adenoma is compliant. So whenever we do this kind of tenting, what we are doing is we are shifting the adenoma towards lateral aspect, towards the capsule. So we are actually converting the prostate into a kidney. We are doing a bean shape. So we are doing at 3 o'clock and 9 o'clock, and we are converting this prostate into kidneys. And so ultimate aim is to create a mechanical channel in the midline. See, because the problem in BPH, LUTs are mechanical. So why do we need cavitary things? Why do we need ablative things when we can get away in selected cases doing only the mechanical solution for a mechanical problem? Now, after this 2 dimension, we also need to take into consideration the third component, that is third dynamics. See, the prostate is like, if you visualize this, in entero-posterior dimension, which matters to us is only the anterior compartment. If you take on the prostatic fossa as a wall clock, what we are concerned is only the anterior compartment from 3 o'clock, 12 to 9 o'clock. We are not concerned about the posterior compartment, because at the posterior compartment at 5 and 7 o'clock, we come across splanchnic nerves. So if we fire our implant, it can hit those neurovascular bundles and it can lead all these complications. So what we are concerned is we have to deploy the implants at the 3 o'clock or 2 o'clock on the left lobe, and 9 o'clock and 10 o'clock on the right lobe of the prostate. So our ultimate aim is flush from the bladder neck right to the veru. We are concerned in making an anterior channel. We are not doing anything for the posterior thing. So even if there is a significant apical tissue, we are not attending them. And ultimately, the same thing delivers what our catheter does is the same thing. Our catheter crosses like the same direction, and it gives us a very good channel. So this is the ultimate aim of urolift, that creating an anterior channel. This is regarding this. And now we proceed for the actual cystoscopy. Now this was the urethrocystoscopy. Now we can see both the bilateral lobes are encroaching, and once we close off the flow, they are actually occluding. So we have to start at the veru and we have to see, and then we have to reach to this bladder neck. Now there was a little bit of median lobe. It was not a significant lobe. If there has been a sizable median lobe, we can still deal with them using 2 more implants. This patient had a chronic catheterization, so there are secondary stones. and it was significantly trabeculated bladder. So we had to wash all these stones and take care of them, and then we started planning our implant. Now this is the implant delivery. Now here, what I want you to focus is, I'm posing it right now. This is the window. This is the window where everything happens. You know, the moment you fire a needle, you see here, the moment you fire the delivery of implant, you have to focus there. And at the last, when we want to cut the suture by adjusting tension, that also we need to focus on this. So kindly focus on this particular window. Here what we are doing is we are taking down this 3 o'clock and 2 o'clock position. We are dealing with the left lobe of the patient. We are compressing it. I am just compressing it to make a furrow and understand how much opening which I'll be able to get. So I'm doing it couple of times and then understanding where exactly how to place. So I'm coming 1.5 centimeter away from the bladder neck, and then where I am seeing Veru. So I understand that with the 2.5 centimeter length, I don't need more than one set of implants on each side. So after configuration of my thoughts about the implant, I'm doing is I'm compressing little bit between 3 and 2 o'clock and creating a furrow. We need to be very, very gentle, because if we exert too much of pressure, we might hit the needle to the bone, or secondly, we can lead to capillary abrasions, and it can lead to significant amount bleeding, because any bleeding which can obscure this particular window, you are in a problem. So we need to have excellent vision unless until we need to be sure about cutting the sutures. So now I'm setting up my thing. I've set up my position. I have set up my angle 15 degree, and here I am firing. See, this is the needle fired. So we have released the lock, then we have fired and now we are moving forward, and see, yeah, stop, just stop here. So this is the white line. So what we have done, we have fired implant over here, and then we have taken down scope, sliding the prostatic gland until we see this white line. That is the time when the suture tension is adequate enough for this particular thing. So when we see that, that is the time when we insert the urethral release button, and that is when the suture will get cut and urethral end piece will be deployed. So the moment I do it, I switch myself to the median, and then I go inside the bladder, and then I exchange this implant device with my Urolift cystoscopy set to see where my implant is. So we exchange that for our Urolift cystoscopy set. Here we go. And we try to see where our implant is. So I'm going with that, and I'm turning on the right side, and this particular side, this is the urethral metallic piece. So this is particularly been taken care of, that 3 o'clock position on the left side. So this is what we need to make sure. This implant should not be in the posterior compartment. It has to be in the anterior compartment. Now, same thing which we are going to repeat on the left side. So on the left side again, I'm going little bit on 10 o'clock part, because there is a bit of median lobe. So I need to create little more entry channel. So on the left side of patient, I went at 3 o'clock, and here I'm trying to go at 10 o'clock. But we should never go beyond 11 or 12 o'clock, because there are dorsal venous plexuses. So we stay ourselves at the 10 o'clock, and then again we are firing this device. So that's the fire. That's a needle which has been given. Now we are compressing. Now the needle, the implant has been delivered, and now we are moving forward. And here again you see this white line. So once the white line is come, you cut that, releasing that urethral cutting stitch, and then you separate it and you take it away. And that is the moment when the urethral end piece will be deployed there. So once it is deployed there, you can see there is a tenting of this particular angle which has happened there. Now we have cut that. Now you can see there is a very good channel. So this is a left side implant, this is the right side, and then this is the anterior channel. So then again we go inside, and you see there is hardly any bleeding. If slightest amount of bleeding is there, we might not see that window, we might not see that white line, which can lead to significant problem. So once we do that, what we do is we take this picture. Now this is the sitting at the Veru. We are not focusing here, we're focusing at the anterior channel. The small bladder neck is not going to give us trouble. Otherwise, we would have still taken down it, having 2 more implants. But with this particular appearance, I am happy. If you could compare it with the previous, it was practically closed, and now it's all open. And now what we do is we do an intraoperative kind of, a calibration or an, assessment of the urinary stream. So we just make little bit of bladder full. This is with the flow closed. You can see some bladder things. Now we are withdrawing this cystoscope assembly out, and keeping the bladder partially full. This patient was having a renal failure and retention, and this was done in spinal, so we had to put a catheter. But what we are doing is we are checking the intraoperative urinary flow by a gentle compression on the suprapubic part, and we see what is the uroflow on table. Mind well, the ultimate result will come at 3 weeks, but this is the intraoperatively at 0 moment. What is the flow which we are getting? This nice and fine flow which we get. So yes, let's not compare Urolift, or let's not compare this, or I'm not trying to project this Urolift as a substitute to whole lap or TURP. No, it is a complementary to existed modality. I am a whole lap guy. I have 1,500 whole laps, 200 tooth laps on my name. I am doing it since 2011. But there are subset of patients who are real candidates for this non-cavitating, non-oblative, only mechanical procedures. These patients may be high-risk patients who are ejection fractions are 15 to 20%. Very relatively young patients who are very sexually active and concerned about preservation of their ejaculatory function, erectile function. These are the subset of patients wherein Urolift has a place. But having said that, we all need to orient ourselves that, we look at BPH only as a mono component, only the LUTs. No. Now, new study is there. Uttam, there is a new study which is BPH 6. Now, they have taken into consideration 6 components: LUTS, quality of recovery, erectile function, ejaculatory function, complications, de novo incontinence. So if we take out the entire 6 component, I am sure if you train your mind, if you train your patients, there will be more subset of patients who will be fine voiding nice and fine, but they will have several other problems. So Urolift gives a compromise thing. It doesn't give as large kind of a prosthetic fossa at the end, but it serves the purpose for which it's been done, and it saves all this erectile function, it preserves all this ejaculatory function, and overall quality of patient's recovery and quality of patient life. That is what matters in all disease. So that is what, for a benign disease, I think Urolift will have a place in future. But we need to be having caution. The cost is a big hindrance to all of us in our subset of patients. Second thing, the long-term data. We have 7 to 8 years of data, and there are retreatment rates of 13 to 14%. So we have to accept that, and with a pinch of salt, we need to take and accept this procedure. Thank you so much for patient listening, gentlemen. Thank you. I'll be happy to answer any questions in person or here. Thank you so much. Okay. Yes, sir.
Excuse me.
Yeah.
Suppose there is a median lobe, large median, then this procedure is not indicated then?
Sir, if there is a small median lobe like which we had in this case, that can be pinned down to the lateral lobe. But if there is a sizable intraprostatic median lobe, which seems to be 2 centimeters or more, there we can pin it down at 4 o'clock and 8 o'clock. So initially till 2018, until Rixtalis published his series, it was contraindication. But now even a sizable median lobe, we can do away. Lateral lobe, same technique. For median lobe, we are pin them down at 4 o'clock and 8 o'clock. But for that, we need to have a sizable median lobe, because 33 millimeter, it's a mathematics and physics. If we do it for a smaller median lobe, the needle will go directly to the cavernosal vein and it will injure this thing.
Can you then predict perioperatively which cases are fit for this?
Sir, the only problem in this Urolift is, even this case, we had to have a preliminary cystoscopy done prior hand, or else we have to counsel the patient that we might, because the cost is so much that we need to address that issue and how many implants we need. So we usually do a preliminary cystoscopy, assess the prostate, and plan how many implants we might end up using.
Sir, I have 2 questions.
Yes, sir.
First, what you will do if there is a dislodgement of this stapler device, and second, what if a patient fails after this procedure? What is the next approach?
Yeah, see, whenever the deployment fails, usually it happens when there is a bone contact. It can be easily retrievable. So that's question number 1. The question number 2 is failure. Now we need to address the definition of failure of Urolift. The Urolift is just not mechanical. It has got a histopathological implication as well. So there has been studies done in canine models and there that ultimately it remodels the whole prostate. So whatever result we are getting at the 0R is only the mechanical component. Gradually from 3 weeks onwards to 3 months till 12 months, there will be remodeling of the prostatic tissue. So any patient who doesn't do well with Urolift, we need to give him some time, 3 months down the line, and assess. And the times we can add on few alpha blockers for them. But at 1 year, if somebody fails, then we have to contemplate either doing a second cystoscopy and consider according to the anatomy of the prostate, reinsertion of few more implants, or we can do TURP, we can do HOLEP, we can do TUFLEP, anything. These implants can be cut easily with the laser. So by doing Urolift, we are not negating any future cavitating procedures.
Have you ever come across delayed this dislodgement of the stapling device?
Not delayed, but I have removed 2 devices now. The couple of patients from US, they had done this Urolift a year or 2 years back. They failed to improve. So at that time, I didn't have this Urolift. So I had done HOLEP for them, cut them, and then I could retrieve them. The subcapsular component remains there outside the capsule, but the suture and the urethral end piece, you can take it out. Though they get epithelialized, but you feel when you are cutting with the laser, you are cutting some thread.
Okay.
Yeah. What are the selection criterias for this procedure in comparison to other known modalities?
Yeah, the first thing is anybody who deserves a surgical indication. Second thing is ideal patients are between 30 to 80 grams of prostate. People are doing even in US 80 or 100 grams, but I think I would resort myself between 30 to 80 grams because number one, larger the prostate, more number of implants, cost will be high. So 30 to 80 grams of prostate, no urethral pathology, which can lead to difficulty in introducing our assembly, no active urinary tract infection, and we need to make sure we are not having any suspicion of prostatic adenocarcinoma because we are not removing any tissue. So we need to be very sure. Slightest of suspicion with either in the form of DRE or TRUS or PSA, we need to rule out CA prostate by doing a biopsy. So these 3 to me is an absolute contraindication. Somebody is having more than 80 grams of prostate, somebody is having CA prostate, like not now, but has a doubtful suspicious CA prostate, active urinary tract infection, and any urethral pathology. As far as the blood thinners and all concerned, we usually keep aspirin on. Clopidogrel, we preferably stop, but we start it the next day because we are not going to keep catheter for long. So those patients can be taken very well.
Now, is there any indication where you would like to do this procedure in preference to other non-conventional procedures?
Two kind of subset of patients. Now, one is 50 to 60 who are quite relatively young, who are sexually concerned, who are sexually active, and who are actually willing to preserve their ejaculatory and dysfunction and accepting the cost and the procedure. Second subset is a very high risk patients. We did this in spinal, but at our setup, we do it in pseudoanalgesia. So even with 15 to 20% of ejection fraction, we have done a couple of cases. These patients, because there is hardly any hemodynamic, we did this case in 12 minutes using less than 3 liters of saline. So there is hardly any hemodynamic alterations. So these poor risk patients and the sexually active males. These are the 2 subset of patients wherein this in future will have a definite role.
I have one question. How do you follow up the patient? For how long and how often?
See, how often is we first thing is we remove, if at all we put a catheter, we remove the next day. Tomorrow morning, I'll take this catheter out. And then we see how he is doing. Then we'll ask him to pay us a visit at 7 to 10 days. We'll do an IPSS and uroflowmetry. Then I'll assess him at 1 month and then at 3 months. So 3 months and 3 weeks is the time when the histopathological component starts acting. And it takes at least 3 months. So I'll follow them at 3 months and then at 1 year. In form of IPSS, his quality of life, his BPH6 score, his BPH6 component score, which includes the IMSH score for his sexual function. And I don't do cystoscopy in this patient unless until the patient's condition is not improved. So these are my criteria for follow-up.
You see.
Yeah, Uttam, anytime.
So I think most of your patients would have been on alpha blocker before this procedure.
Couple of them, yes.
Couple. So do you continue alpha blocker for some time before you stop them?
No, now there are 2 subset of patients. Now those patients who are on alpha blocker, we usually allow them to be on alpha blocker for 7 days or 10 days after the procedure. But I wish I should stop it within 1 week, because if I continue alpha blocker, it takes away the whole fun of Urolift, because with alpha blocker anyway, he is going to experience that retrograde ejaculation. So I will never start de novo, but those subset of patients who are on alpha blocker, I'll ask them to stay for 7 to 10 days and then I'll withdraw, because I don't want them to be on alpha blocker. Otherwise, the whole the concept of Urolift dies.
That is fine. That's what I'm telling. So immediate post-op period.
Yeah.
And there may be some sort of wording issue. So you
Definitely.
want to continue for a week or
If
so.
he is on alpha blocker, I continue for 7 to 10 days. If he is not on alpha blocker, for example, this patient was in AUR, he is not on alpha blocker, he is on catheter for last 3 months. I will take the catheter out next day morning. I'll give him antibiotic, anti-inflammatory for 5 days, and that's all, nothing more.
Have you done any semen analysis in the post-op period to prove that yes, there is no retrograde ejaculation?
I did not do sim, but that's a good comment. I'll take that, and I'll do when I go back home. And
Because that is the only objective way to prove that the patient doesn't have any retrograde
we live in
ejaculation.
era of evidence-based medicine. We need to document. But I'll share some small example. I had a patient who was from a typical caste. He was 65 years, so I take him for granted that usko sexual function se kya farak padta hai. So I did his whole app, and he was also convinced about retrograde ejaculation. He always used to come with elderly lady, husband, wife, 65, 70. Then third visit, after a month, he was fine. Then he went off. At 3 months, he came with a younger looking lady.
Oh.
And I said, what happened to you? You're fine, sir. I am fine, but she has a problem. And who is she? She is my wife. Well, then what was that lady? That was first wife. She's the third wife. That's it.
Good.
Thank you. Is there any questions?
Thank you, sir. Very
Thank
nice
you so much.
presentation.
I think Eurolift is exciting and Dr. Rohit Bhai is even more exciting. So yeah, kudos to Dr. Rohit Bhai. And I think we will, आज रात में भी आपका एक स्टॉल लगा देंगे, अलग से अब यूरोप पे बात करते रहेंगे. So we'll go back to Dr. Prem Kumar for his concluding remarks. He's wrapping up. So Dr. Prem, we are with you. Can we connect to Dr. Prem Kumar, please?
Hello.
Yeah. Sir, we are with you, sir, Dr. Prem.
Hello, Prashant.
Yes, sir, we are with you, sir.
So see, like this, there was a large intravesical portion. So that's over. These are the bladder fibers. And this is Veru. What I like to show, we can see capsule everywhere. We can see capsular perforation also, no problem. It is very similar to laser. So nothing to worry. We can see fat also. Okay, but nothing to worry. So it is not that it is not enucleating. So we can have a good enucleation with bipolar also. So that's the left lobe and this is the right lobe. So if there is a capsular perforation, nothing will happen. And there won't be any bleeding. The return here is clear. So we are done. All around we can see the capsule. See on the top also we can see the capsule. And coming outside Veru, slightly you can see a good fossa. Slightly it is hemorrhagic, but outside the return is clear. So this is a good fossa. Okay, so I am finishing and putting a 20 French catheter. Total resection time was 50 minutes. It was 82 grams prostate.
Prem sir, I have a question. I'm Dr.
Yeah.
Sunil Kolkata. So you are not using mushroom. You are using only the.
I'm not using mushroom. I use only lube.
Okay.
Okay, fine. Chalo. Thank you. Thank you. Okay.
Thanks a lot,
Thank you,
Prem
sir.
sir, for this excellent and very fast demonstration, sir.
And the flow anyway. When the flow is good, we can. Chalo. Thank you.
Now go back to OT.
डाल दे. इसको कर देगा क्या? डॉर्सल स्लिट करना डाल. डॉर्सल स्लिट
OT2,
करेगा.
where Chandramohan Vaddi sir is also wrap up with the enucleation part. Vaddi sir, we are with you, sir.
इसको खोलना दीपक, एक बार खोल देना. ये भीग जाए. अरे बाप रे, ये टिश्यू कितना है?
Vaddi sir, can you hear us, sir? AV team, please unmute OT2.
Shifting to OT2. Yeah. Audio, OT2.
Mike?
Yes, yes.
Sir, can you hear me, sir?
Yeah, I'm able to hear. Can you hear me, sir?
Yes, sir.
So I'm at the 5 to 9 o'clock position at the base. See, if you see, there's a high bladder neck was there from beginning. Can you see here, sir? Can you see here this gland, this side?
Yes, sir.
This side?
We have lost your audio, sir. AV team in OT2, we have lost the audio.
Hello. Hello.
Hello.
Chairperson, sir, is anything other than this surgery is going on? I think Dr. Panda was waiting for.
Sir,
kilogram
right
last.
now they are doing the graft harvesting in OT1, sir. Buccal graft harvesting, sir.
Are we connected to Dr. Arvind's OT?
Hello, Arvind, sir.
Dr. Arvind?
AV team, please unmute OT1.
That's why answer the area you do all this. Can you hear me?
Yes, sir.
Yeah, can you hear me? I just want to show this to you very quickly. Can you hear me, sir?
Yeah, we are
Please
hearing
zoom
you.
in. Please zoom in.
So I just removed the graph. I want to show 2-3 things here. Firstly, I want to show you that it is possible to, take this. I have not defatted this graph. I do in situ defatting, so I take out the thinnest possible graph which will do the job. I don't want to take out any sort of buccinator here. And I was just also wondering that if you can show the inside, that is the key point. Get the water, please. Yeah. Yeah. Now, if you can see the graph, sir, there's absolutely no.
Can you zoom in, please, cameraman?
You need to come in here. Please get that thing here. You need to come in here. Get that whole machine here. Get that camera here. You cannot show anything from there. You get it here. No. Come this side. Come this side. Detach the camera and bring it here.
Dr. Arvind?
I want to show inside the mouth. How do I show inside the mouth? I have to show inside the mouth.
Dr. Arvind?
Sir, so I just show you this graph is not an issue. Just want to show inside the mouth. Graph is fine. Take as thin as possible.
What is the graph size you have chosen?
Because I have not measured this picture, just give us see. We have a this one here. I'll just put it on his hand. So this is roughly unstretched.
Okay.
Unstretched is about,
Cameraman, the
about
focus is
4
not good.
centimeters, sir. 4 centimeters after the primary, 4 centimeters into around. If you stretch it, it will be much more, but.
Okay, that's nice.
So basically, sir, I leave this stencils 4 centimeter into maybe 2 centimeters.
Yeah.
What I want to show you is inside the mouth, actually. I don't know if you are able to see this. Can we have the lights, please? So.
Okay.
So,
Now we are getting the image of the oral cavity. A little bit zooming.
From inside the mouth, show it here.
Please switch on the top light, sir.
So basically, sir, when I take 3 stays and I try to take as big a graft as possible without causing harm to the patient. I don't know if this is visible here.
Yeah, we are getting a good view now.
Yeah, without causing any harm to the patient. So this is the stencils. So
Okay.
with the marking pen, yeah, this is the stencils duct. So instead of going below the stencils duct, I tend to go around it. This is the stencil, sir. You can see this mark here.
Okay.
See, this is the Stenson's duct. I have gone around the Stenson's duct. So that way I can assure that I get the widest possible graft.
Yeah, we are able to see that. Well,
Wide. If we go around the Stensons, then in the middle you will may get a little bit where the graft.
Dr. Arvind,
Here
in
you
which
can
cases
get
you,
a bit of an arc here, but otherwise the graft is quite broad and wide, and there is no bleeding. If we take it, if we take a superficial enough graft, you can see I haven't even used cautery till now. There is absolutely no bleeding inside. So that's it. Thank you. We'll go down and then we can restart.
Dr. Arvind, in all your cases, do you use buccal mucosal graft or do you use vaginal graft as well?
So vaginal,
How do
I
you
don't use so much because so vaginal I don't do. I sort of prefer to use buccal mucosal. Sort of gives so because vaginal I'm not always sure how much take will be there. That's all. Otherwise, we can use anything we like actually. But I do believe that the buccal mucosa has a little better better take than the vaginal.
Okay.
Later we will come back and see. Okay, that's it. So thank you. Sister, please take 5 ampules of gentamicin. For my wash, I would like to take 5 ampules of gentamicin in 1 liter water. You've got genta?
Dr. Arvind, have you done the cystoscopy? Not yet.
I just go and do it now, sir. I will rescrub because I've taken the graft out.
Okay, sir.
It's an unsterile area. Now I want 5 ampules of gentamicin. That's what I'm going to. I want to put this graft in there. Sister, stay here. When she puts the gentamicin in that liter, you take little bit of genta saline in this and put the graft in that. Now, can you hold this, please? Bada kidney nahi chahiye, size bhi chalta hai. But she will take in a big kidney tray. Yeah, 1 liter. Hold this, please.
Arvind sir, till you prepare for cystoscopy, we will go back to Dr.
Yes, please.
In OT2. Vadi sir, can you hear us, sir? AV team from OT2, please unmute.
I wanted to show I have finished. I will
sir.
come out and show, sir.
Chandra, hold on.
Am I audible, sir?
Yes, Chandra.
Yes, sir. Now I have finished. Maybe took around 1 hour 10 minutes. Sir. See, I will withdraw the laser fiber. This is the trauma of the rotation. This is the sphincter. Can you see, sir?
Yeah. Yes, sir.
This is most important. Rest of the surgery, thoda coagulation idhar-udhar, there is no problem. This should not be. See, this grip should be there. This grip. And once you go inside, see, everything is mucosa hanging. This mucosa hanging. And this is a long veru. This is a long veru. On either side, I have taken all around here. Can you see, sir? This
Yes,
is
sir.
not at the bladder neck. This is at the level of the veru. See, here, if I grams in, that is better. This will not cause obstruction. For example, if I come like this, you will go close to sphincter. So benefit of that, this 5 mm I have left. But the opening, can you see, sir, opening? Hello?
Yes, sir.
Opening, can you see? It's a huge opening. When I was not able to go, see, this is the capsule. The entire thing you can, this is the coagulation mode. Can you see the coagulation mode, sir?
Yes, sir, we can see.
Like a surface coagulation mode. The depth of penetration is very, very less. Only one area bleeding is there. This is the length of the prostate. No bleeding. Some irregular surface is there. That is microscopic. You should not worry too much. Everything is fine. See, here I have gone deep. If you go like this, no charring will be there. If you come like this, little charring will be there. So that is the balance. Here I have kept a little bit here. This is 1 chip equal to 1 chip. If you go little deep here, Foley's catheter will go into that. You can coagulate, not necessary in fact. The only area where bleeding is happening is, see here, sir. This is a true the bleeding area. Sinus, can you see sinus, sir? There is no way you can manage this except coagulating the walls and opposing it. Once we put the Foley's catheter, it will stop. This is the only area of bleeding. This. When you go close, it will not bleed. See, use capsule. Directly it will go into IVC. If you go like that. So leave it. Foley's catheter will take care of it.
Chandra,
And
let us
meantime,
let's
take
spare.
this is the 3 lobes. Now vision is good. Next important point is how far you are from the orifice. Kilometer away from the orifice, this mucosa. And here also, you are very much away. This. That's all. Now I will remove and use coral starch nephroscope for the coral starch nephroscope as well as the Mars later. For that, you have to remove the outer tube like this. It appears little change in time. Now I have inserted the long length 26 French so that you need not buy the marcelloscope.
Chandra, Chandra,
I am changing with the
Chandra, hi.
yeah, hello.
Yeah, Dr. Rohit Joshi, hi.
Yes, yes.
Yeah, see, one small thing is before you introduce this nephroscope, what I suggest is what we do is we ask our assistant to get this camera light source away from the cystoscope and put it on the nephroscope, get the white balance things and all that.
Now
So
one
that,
one more water should be on. Can you
Yeah.
give the one more water? There are 2 water inlets for this, for the safety. Can you see the bladder neck and the ureteric orifice here? The above one is the floating one. Can you put the one bottle? So 2 inputs are there so that the bladder will not, and you need not buy extra equipment for this. Now both water is going, automatically bladder is getting distended. Now this is 6 French. This will go through the 22 French also. This is coral starch. You can observe the jaws here. Can you observe the jaw? It is up. If you put down, it will suck the bladder. If you put up, it will suck. Nazdik now. Foot pedal Nazdik. See, now it is floating. There are 3 lobes. And irregular surface will help in, see it is, now I am keeping up. If you have doubt, stop it. There is a clot also. Now my assistant is checking whether the bladder is full or not. If the bladder is not full, anterior wall has to come and touch. The backside phala surface should be seen. If the black background is there, that means you have inadequate amount of water. Now you don't change any position. Pray the God that it will not go away. Once it goes away, again it has to come in. Hardly this will be seen now like this. Again you stop, suck it, see. Below one is also sucking. Can you see? Now lift up into this thing and then stop. These are the precautions. Most of the times enucleation, marcellation they will not see. They will show, see now it is very important. Marcellation sometimes takes more than half an hour. It should not. If the suction, see this is one, the jaws is facing up, suck it first, like this, suck, it is not coming, suck, now lift it up. Now let the water fill, you are only sucking, you are not using the blade. Now I am using the blade. So in a collapsed bladder also you can suck. Now I don't know, I will wait. Now I will suck. See, it is sucking. What is, I don't know. Well, it may be posted also. So go inside and then see. If entire part is moving, it is definitely free floating one. If the entire part is not moving, you may catch the wall of the fossa. That is dangerous. That also bleeds. See, it is sucking out. Now his blades are working. That's all. Now, wait and see. To my knowledge, one more small piece may be there. See, this is a small piece. Suck. See, it is sucked. This. Completely. Like that, small pieces should be. Now, this is also there. Suck. Just only suck. Get it. Now it has slipped. These slippages will come. These all will take time. Sometimes you have to collapse and see. Only keep up. Don't activate the blade. Keep up only. See, it is sucking the floor also. Let the water fill. Come back. Usually, if you come back, this is the edge. There is some huge. I have to control one large. See, this is the piece. Not so good vision. I agree. So some people say that absolutely zero bleeding will be there. Don't believe them. Sometimes this type of vision also will be there. So chup chop take the loop and then finish the coagulation. It will take less time. I will do that.
But
In
Chandra,
this case, I will do at the end. Ultimate point is patient should not come back to the
are we
theater.
audible to Chandra? Sambit? Are we audible to Chandra? I think, yeah. I don't think so. Nah, he's in the flow. Yeah, he's natural.
Vadi sir, hello. Hello. We'll be now moving to OT1 where Arvind Panda sir is ready with the cystoscopy. Arvind sir.
Yeah, can you see this scopy? Cystoscopy,
Yes, sir.
please?
Sir,
We are not
we are
getting
seeing
the
the surface view. We are not getting the endo view. Please switch to endo view.
Can you hear that? Yeah.
Yes, sir.
So this is the endo view. Can we?
We're not getting the endo view.
Yeah. So in the endo view, you can see this is trabeculated
No,
bladder.
we are not getting the endo view.
No?
Yes.
Yes, sir. We can see it, sir.
Okay, if you can see this also, it's fine.
Yeah.
Okay, so you can see that. See, normally I would do a MCU for all these cases before I do erythroplasty. The main reason is we know there's an obstruction, but anatomically it is always functionally. You can know the level of obstruction from MCU. From a scopy, you can only the anatomical level of obstruction, not the functional one. So here, if you go, you can see that the bladder neck, the bladder neck is looking slightly pale, but there is no discernible structure there. I have put a wire through. This part of the urethra looks okay, more or less. I will just open the water now. This part of the urethra looks, and then here you can see a little bit of unhealthiness distally. So distally it is little unhealthy. You can see that is distally unhealthy. When I go inside, this part looks more or less okay. And then I come to the bladder neck. I really don't know if the bladder neck is really, because there is the urethra right after the neck looks okay. So I would ask two questions here. One, I would like to say an MCU to see if there is functional obstruction at the bladder neck, or the obstruction is only at the distal part. One. Secondly, I would give these patients generally a degree of urethral rest, because when you have done a dilatation or when the patient has a recent scopy, it is not always possible to know the where the obstruction is and how bad the obstruction is, because it has been dilated. So if you give the patient, so when you are planning to female urethroplasty, it is always better to give the patient about 2 months of urethral rest, tell her to stop doing self-calibration, stop doing dilatation, and 2 months or 2.5 months later, when she has again recurrence of symptoms, then you go ahead and do urethroplasty. If you have dilated the patient before once, it is worth repeating a uroflowmetry to see if the flow is good. If the flow is not good, it is mandatory actually to do aerodynamics to see that she doesn't have underactive detrusor. Sometimes this picture can be because of iatrogenic injury after underactive detrusor, in which case after urethroplasty, her flow may not improve. So here if you look at it, this is the neck. You can see the neck. The neck is slightly scarred and pale, but this is not a part where I can put the graph. Quite frankly, I cannot put the graph at this neck. I can put it from here. So this
Dr. Arvind, Dr. Manikandan.
So,
so what is their strategy now? Do you think that only the distal half centimeter of the urethra is strictured, or do you think the bladder neck is also
definitely around 1 centimeter is definitely unhealthy. What I'm not sure is how healthy this part is. This is the bladder neck. Can you see, sir? This is the bladder neck.
Yeah, we are
And
seeing.
this is just after the neck.
Yes,
Now,
this
I'm
this
not
mucosa
sure
looks healthy.
how bad or how good this part is. This part is definitely bad. Now, that part which you get at the neck, you can also get when the patient has been subjected to multiple episodes of urethral dilatation.
Okay, so what is your strategy?
So my strategy would be to do a hybrid dorsal onlay and inlay procedure where I would put it proximally, but I really can't patch the bladder neck. That would make her incontinent. So just distal to the bladder neck, I'll patch. I'll start from here and proceed till here. That is what I'm going to do, because again, if the patient has not been dilated, you have had urethral rest, you can exactly, you an MCO, you can exactly make out from multiple sources where the possible stricture is.
Oh, we
Because-
understand that.
So,
So now you are going to substitute the distal one point vicinity.
mid and distal, sir. Mid and distal, extending a little bit to the proximal, sorry, but not completely to the proximal, not to the neck. I leave the neck and basically patch the rest. Hybrid, I will do both a dorsal onlay and an inlay, because I feel inlay procedure near the neck is little tricky. You have to yes, yes, but doing the inlay from here to there, it will be a little more trickier. So can we have the light on, please? Top lights. So we can have a mop, sister. Please give me a mop. So we'll put this below because I'm going to dissect that below.
So we're about to wrap up this session here. I would like to
So-
thank the persons for this engaging session.
Give me a
And
forceps.
on our next set of chairpersons for the next session.
So jelly.
Dr.
Jelly is
Chengavayan
also-
Ji,
this is actually-
Professor Madras Medical College, Chennai.
Inlay would be very easy actually here. If
Dr.
I do
Samir
only
Swai,
classical inlay, it will be easy to do.
HOD, Urology Department, SC Medical
It's
College.
easy to do, but because this is quite wide.
Dr. Benu Panigrahi,
But I do believe that this
Professor,
patient
MPC
deserves an
Medical College,
onlay
Berhampur.
also. Give me the knife.
Dr. Amitabh Mukherjee, Senior
You have,
Consultant.
can you give me that xylocaine aniline again if you have,
Kolkata.
5 ml, 10 ml, not too much now.
Dr. Shyam Babu Prasad, Senior
Give me Alice
Consultant.
forceps.
Pani?
Give an Alice forceps please to me.
चलो एक
Dr.
बार
Sudhir
mic दे दो।
Saikia, Senior
Hello,
Consultant,
what's
Urologist,
future?
Guwahati.
Hello? Hello?
Dr. Sumit Kumar, Consultant Urologist, Bihar. I would request the chairpersons to please come and occupy the chairs.
Zero baggy.
Okay, please give me the.
Where is that tissue?
Can we have head and down, please?
Head and down.
Sumit Kumar.
So I make this
उधर ही है।
linear incision here.
चलो ठीक कोई बात
There is no separate lunch break. We'll have a working lunch session. So anybody who can please proceed for the lunch.
Hello? We are shifting to
Yeah,
Lunch is outside on the
Hello?
floor.
Yes,
Yes, fine,
hello,
fine.
Hello?
Dr. Chandramohan.
Yes, sir. I'm audible,
Yeah,
sir.
Dr. Samir from Cuttack.
Sir, am I audible?
That injection.
Hello.
You are audible, sir.
And can I have a sharp scissors?
Hello, sir. I'm audible.
Sharp
Hello,
scissors?
Hello?
Dr. Chandramohan, we are audible?
Am I audible, sir?
Yes, we are audible to you. Is it?
No,
audible?
you are audible to me, sir.
Yes, yes, please tell what you want to tell.
Sir, actually, this was around 65-70 grams prostate with medium lobe. I have incised one side. I have incised the other side. In front of the veru, I have corrected. I have lifted that. That went well. There is no problem. When the right lobe, I went from the capsule towards the paraveru region, towards the paraveru region, towards the paraveru region from 6 o'clock to 3 o'clock, 6 o'clock to 3 o'clock. Almost 3 to 4 centimeter I lifted. Then I connected the mucosa to the top, a little in front of the veru, deep to the capsule. Then I have given an incision on the anterior part up to that level. Anterior part means 12 o'clock. That means my left part of the lobe of the patient is done. That left part I have done below, side, up and completely pushed inside. After that, the right lobe of the patient, I have given same continuation half of it. Above I connected and then I started pushing. Last 15 minutes part of the right side of the lobe, I am in the learning curve because it will become opposite hand to me. So I used the reverse, that means camera up, then started cutting on the floor and completely pushed and it is over. Now at the end, 3 pieces are sucked out. It will be around 40 grams. Now this is the color of the without any traction. This is also important because large venous sinusoid was there. That sinusoid, if you keep on working, blood will be coming. It's like washing the blood from the vein. You just put a Foley's catheter, it will oppose and bladder will collapse and it will clot within 5 to 10 minutes. We all know it in TRP. Some amount of capsular perforation will be there. That was the only mishappen in this case. So thank you once again for giving me the opportunity.
I think it is just, hello. Yeah, I think it is same principle as per TORP. The sinusoid should not be explored more, rather it should be kept as such so that it will collapse at its own.
Yes, sir.
Yeah.
Yes, sir.
Now the urine is very clear and we have enjoyed your procedure. Just to have a point of discussion, how to prevent just to avoid a mechanical dissection, because some sort of mechanical force is needed during enucleation. That is a clear-cut fundamental.
No, sir. As the experience increases, I am decreasing. Initially, I used to feel that it is easy. No question of mechanical when you are doing laser. We have seen Anil Varsha sir, Pankaj Maheshwari, all the seniors now, Tanush Pal Bhatte. No question of doing any mechanical. In this case, rotation. Only rotation, rotation. Very few millimeter, if you have doubt, you can push, but no mechanically rotating and pushing. That will definitely cause trauma to the sphincter. That's why bipolar enucleation of the prostate is receding. Whereas more of the people are learning enucleation by laser. Laser is a complete incision, no question of pushing.
Sir, Dr. Sumit here, sir. Sir, your tips for prevention of bladder neck contracture in case of thulium fiber laser or holmium?
Loud, please. Bladder neck.
The question
contracture. Sir, tips to prevent bladder neck
I have
contracture.
done only 50 cases. I did not, but I have seen 1-2 cases of hematuria. After the 7th day or 10th day, little from that bladder neck stricture, because my number is less, around 60 cases. I haven't seen now 2 years I am doing. In 2 years, nothing has come because I feel it is a big bladder neck will form, very big bladder neck will form because it will come from the root level up to the capsule. Unlikely it will cause stricture and the depth of penetration of these 0.15 mm. Unlike in TRP, it will coagulate these deeper tissues.
Dr. Benu from the floor, Dr. Benu from Barampur.
Yes.
So, what is the incidence of bladder neck contractures that you have encountered?
Incidence of bladder
You
neck
have done around 60 cases, what you have told. What is the number of bladder neck contracture you have encountered in your patients?
Now, in my bladder neck contracture, I have seen maximum in bipolar. Unfortunately, bipolar we use more, so naturally incidence will be more. Bipolar, small gland, when I try to do overdo, completely reset all around. When tight bladder neck is there, bladder neck contractures have happened. If tight bladder neck is there, if you incise the floor also, it is sufficient. So leave the mucosa anteriorly is a very, very good point. Seniors say, I also follow. When there is prostate gland less, chances of complications are very high. When a large prostate is there obstructing, chances of patient satisfaction is very high. Complications are also less.
Okay, thank you.
Thanks a
Thank you
lot.
very much, sir.
So can you move to
Thanks a
other
lot,
OT?
sir, for this engaging discussion and very nice demonstration, sir. We'll be now moving to OT1, where Arvind Pandit has already started developing dorsal plane.
Yes,
Arvind, sir, over to you, sir.
Hello, Arvind. Dr. Arvind.
Yeah.
Samir here.
Yes, sir. Please tell me, sir.
Samir here. Yeah. What
So
have
I
you
have
done till
dissected
now?
this, sir. Little bit of urethra I have dissected. Now I'm going to divide it here and then do the inlay procedure. This is the urethra, and here I'm going to divide it. You can see that
Yes, as per during the discussion you have told, you will not go more towards bladder neck because this is little bit proximal. So what exactly your extent of proximal
So I'll
incision?
show you, sir. I'll show you. Now I have divided the urethra. Can I get the speculum, please? Give me the
Cameraman,
speculum.
please make it parallel. It's a little bit angular view.
Long
So
one, please. Give me the long one.
surface camera, please change the view little bit.
No, it's not going
Dr.
to
Arvind
work. This is
and Dr. Beno
this
on the floor.
hold this, please.
Dr. Arvind,
Yes, sir.
while
Yes, show you,
dissecting
sir.
urethra, while dissecting the urethra, it is a common happening that you encounter
Can you
bleeding.
give me sutures, please? Can you give me 40 vicryl, 50 vicryl or 40 vicryl, please?
Dr.
No,
Arvind,
PDS is for the thing, but vicryl I want for the stay.
Dr. Arvind, can you hear me?
Yes, sir. Please tell me, sir.
While
I told
dissecting the
you, sir, I'm getting
urethra,
a Lone Star. I'm getting a Lone Star. That will make things easier. As of now, without a Lone Star, you can't really see too much.
what are the measures you take to reduce the bleeding while
Sir,
dissecting
I'm
the
going to take sutures, sir, and exposure. And I'll just show you, sir. And one more thing we can inject is we can put xylocaine adrenaline.
urethra?
We can.
Have you given in
this
this
is the
case?
urethra. You can see.
Have you given adrenaline in this case?
So a little bit I have put. I'll put more now. Now this is the edge of the urethra. You can see this.
Exactly.
The bleeding occurs from two parts. One from the edge of the urethra, which no need. One from the edge of the urethra. Second is from the paraurethral tissues. So I'm just going to put that retractor. Can you give me this one, please? Give it to me. Hooks. So 1 minute. Here then, give back to me. So I'm going to retract this. You can see it very clearly now. So this makes things very easy if you have this. I really thank Dr. Nikhil for giving me his ring retractor. So now you can see it's I have taken the suture also. Can the table come down slightly, please?
Table down.
Table height.
Table height down.
Give me
Dr. Arvind,
Yes,
in
sir.
this case, you will put in the half, distal half, na? If you find whole of the urethra till bladder neck is pictured, what we should do?
Sir?
If the whole of the urethra is pathologic, then
No,
what
we
should
can
be
go
the
up
plan?
to the bladder neck, sir, not any beyond that. Till the bladder neck, we can go. Can you put a clip here?
Up to bladder neck only.
Yes, we can go, sir. Beyond the bladder neck, I'm sorry, we can't
Then
do
the
that.
chance
I
of
don't
incontinence?
think it's a good idea to pass. She'll be incontinent.
How to justify up to bladder neck the incontinence part? Arvind?
Yeah, tell me, please.
Yes, regarding the proximal extent of incision and placement of graft, if bladder neck is totally incised, is it justified that incontinence may not happen?
No, bladder neck is incised, the incontinence may happen. I am aware of that.
Yes.
So I try not to incise the bladder neck.
Okay. So what exactly your proximal extent?
So the bladder neck in this case was looking quite okay. It was not looking that bad.
No, the question is not in this case. If it is almost extending towards the bladder neck, what option should be?
In that case, there are two things. If the stricture is so bad,
Yes.
if the stricture is so bad that that the extent is till the bladder neck, one option is, can the table go down a little bit, please?
Table down. Table down.
One option is, of course, yeah. So now can you see, sir? Can you see this in a better way now?
Yes, the exposure is quite good. Yes,
Okay, now I'll just take a suture here. This bleeding from here. I'll take one more suture. Give me that 50. Yeah, height is looking okay.
Sir, when do you make a choice of dorsal only plus ventral inlay as you were speaking at the start? Hello,
Mosquitoes.
Arvind sir.
Yeah, please tell me.
Sir, when do you make a choice of combination of dorsal onlay with ventral inlay?
Yeah, these cases like this where it is very proximal also, where you really don't know the extent. And secondly, the urethra is friable. That is for me a 100% indication. If urethra is friable and I'm going to put my speculum inside, then the urethra keeps tearing. So if the urethra is friable, it's better to do a procedure which is like hybrid rather than, go only for inlay. Because the urethra is going to tear in that case and not a great idea.
Regarding female optical internal ureterotomy, what is the stand now in this case?
Yeah, can we take the needle off, please?
Arvind? Hello?
Yeah, please tell me.
Regarding optical internal ureterotomy in this type of case, what is the current?
No, I didn't get your point, sir. Give me one more 50. Is the question addressed to me? What is the question?
Regarding internal ureterotomy in this type of situation.
No, in urethrotomy will recur. I feel urethrotomy, whenever we do, whatever we do, it tends to recur. Give it, sister, please. Thank you. So here, can we have more light? Light. It really helps if you have a headlight here. So if you have a headlight, please use that because, or you use a cold light source. Can we cold light source? So you can use that, put that light here. They will be able to show me. Yeah, they can leave this one. On. The full thread. I tend to take this hemostatic suture. It helps me very much. As sir was asking, Dr. Uttam was asking, method to reduce bleeding. I think one of the method is obviously to take hemostatic sutures. One more mosquito here, please.
Not clear. Please tell it again.
What
your? Hello. Your voice was not clear.
Arvind sir, can you hear us, sir?
Yeah, tell me, please. Show me. So I think I will dissect this one more suture and then I will dissect it. Hold this, please. Now I'm going to, I think from here on we can use the inlay technique. So for the inlay technique, I'll put this one inside. Give me scissors, please. Give it to me. Give me hold this. Give me the knife. Yeah, so this is it. So here I cut this urethra. Do you have a scope ready now? Give us a speculum. Give me a speculum, please. Yeah, I'll just see how much where it is. The dangerous part is, putting it into the neck. No, still I can't really. No, this is not enough. I'm not going freely. Hold this, please. Yeah. Can we have it?
Is there any question from the floor? Yes. Please give the mic. Anybody?
Arvind sir, your plan is to do dorsal onlay and ventral inlay. So why have you dissected the ventral urethra also? You're putting a ventral inlay graft.
Your question is that he has planned it for ventral and dorsal only.
No, he have planned for dorsal and ventral inlay. So if you have planned for ventral inlay, there is no need to dissect the all around the.
Audio.
Okay.
Hello.
Okay. Arvind, Dr. Arvind. Hello. Arvind. I think we are not connected.
But Sambit, most probably is not audible.
Audiovisual team, kindly take some steps.
So meanwhile, we can move to OT3.
Okay.
Where Dr. Dheeraj is ready with a case presentation. This is a third case from this OT. Patient with BP planned for HOLEP. It will be done by Dr. Tanuj Paul Bhatia, sir.
Okay.
Dheeraj, over to you. Can you hear me?
Yes, sir. Yes.
Please present the case.
Our next case is BP for HOLEP. This is a 78-year-old gentleman presented with predominantly obstructed lutes for since last 3 years, having recurrent EUR. IPSS score is 25. He is suffering from CKD. DRE shows grade 3 prostate. Serum PSA is 2.7. Creatinine is 1.9. Ultrasound shows bilateral kidney with increased echoes. There is no HUN and the prostate size is 132 cc. Urine culture shows no growth. And so we are proceeding with the HOLEP, which will be done by the Dr. Tanuj Paul Bhatia, sir.
Hello.
7 number. Give me the speculum now. Speculum should go in now.
Tanuj,
Hello.
sir, can you hear us, sir?
Any OT is connected here?
As we
Arvind,
said,
Dr.
as we
Tanuj?
said this, the urethra opens up. You can see the urethra has opened up.
Yes, Arvind.
Yeah. Can you see the
Yes.
urethra opening up?
Yes, there is where nicely seen. There was one question from the floor.
Yeah, tell me, please.
Yes, the question was, if you want to have a dorsal only, is it needed to dissect the urethra all around, or limited dissection will be
I didn't
okay?
understand your question, sir. Could you please?
If you plan to go for dorsal only, is it required to dissect the urethra all around, or?
No. It is not required. This is a hybrid. This is not pure dorsal only. Because
Okay.
it's very proximal, I'm doing a hybrid procedure.
Okay.
Can you put the cold light? I normally don't do this. This is a hybrid procedure. I told from the beginning I'm doing a hybrid.
So why do you plan to do hybrid technique for this when you say that it's only a
It is quite proximal and urethra is very friable.
okay,
See
sir.
what happens when I do an inlay and open the speculum like this, the friable urethra keeps steering.
Okay.
So if I do a hybrid, then the trauma is less. I don't have to spread so much.
Okay. So as you have told before, it is always better to have a rest period if some intervention has been done.
Yes, you want the urethra to have rest. See, now you
Yes.
can see I've opened up.
Okay.
You can see the bladder neck actually, if we can focus there. So this is the part which has to open up further. It will bleed, of course. We can't help it. It will bleed, of course. Give me the scissor, please. I mean the knife. Okay, let's take it off. We can't help that bleeding. That bleeding will happen. Can you see that now? The part is white. So this is where I'm going to put the graft. Can you see this?
Yes.
My speculum is inside the bladder. It is, see, this is the urine coming from the bladder. This is around 18 French at least. So, can you put this back, sister? Give me the scissor, the knife again. Yeah, now you can see it. Can we have cold light here? Get the cold light here.
Can you shift to other OT?
Yes.
Dr. Arvind, we are just watching
Yeah,
you.
no problem, no problem. I'm just emptying the bladder now.
Dr. Tanuj,
Can you hear
please
me?
connect to OT3.
OT3 AV team, please switch,
इसको पीछे कर दो.
turn on the mic, please.
Tool, please.
Acha, it was muted. Okay.
Okay, give me the knife. आएगा इधर. Give me the scissors. नहीं तो कोई बात नहीं. वो दोनों हटा दीजिए. अगर नहीं आ रहा तो हटा दीजिए. Can you sign it?
Hello.
Do like this. Yes, sir. You cannot. Hello. Light
Yes, Tanuj. Dr. Tanuj.
Good afternoon, everyone. Good afternoon, sir.
Yes, Dr. Samir here.
Good afternoon, Dr. Samir. How are you?
What is your plan in this case?
Yeah, this is a large prostate, as we can see,
Yes.
largest of the day. It is a 132 cc prostate. Give me this. There's a large median lobe, very large lateral lobes. And when we go in, we try to look for the ureteric orifices. And this is a very highly trabeculated bladder. I want two large forceps.
Yes.
So it's always better if you can see the orifices earlier itself. If you cannot see, then after the laser, I think here it is.
Yes, that's it.
Yes.
So here I think one large median lobe and second issue was distal extent of the lobes, lateral lobes.
Yes. Yes.
Yes.
They are
So what is your take on
it is
this case?
expected in a very large prostate as well. But at the same time, the veru is also a very long one.
Okay.
So I will be coming little beyond. I will show you when I'm doing that step.
Okay.
But we'll try to take out as much as prostate as we can. And there is a passable stricture here, somewhere here. It's a narrow, it's a ring actually, not even a stricture. But we'll
Yes.
do a otis urethrotomy, which is my routine for every case.
So you are doing it in all cases.
Cases because we use a 26 French the sampler, sorry, resectoscope sheath. And our Indian urethras are not that wide, so it's better to use. And earlier, when we started doing HOLEPs, we had some incidence of urethral strictures, which has really come down since we started. So I'm doing the otis urethrotomy.
What is the calibration in this case?
Calibration of?
Urethral calibration, it was done before or?
No. He was on catheter. But
No,
calibration-
I mean, what is the baseline urethral diameter in this case?
I could go in easily with a 20 French cystoscope sheath.
Or you are planning to have otis urethrotomy in all cases, or you just have to have a calibration beforehand, then plan?
Sir, no. I do it in all cases.
All cases,
In
okay.
cases, either otis or the usual urethral dilatation. The metal dilators. I prefer otis.
No, it's not about dilatation. Actually, I was thinking whether the urethra is capacious enough or not.
No,
Before
sir.
going for
So that
otis.
there
That
was a
was
ring
the question.
in the bulbar urethra, and I know that is the site where a stricture can form later.
Yes, that is a potential site, of course.
Yes. So that is why I like to dilate. The otis could, yeah. So I've dilated, but I think mainly the meatus and anterior urethra only is cut. So I'm just passing the resectoscope now. This is a Karl Stoss 26 French continuous flow. Part is, yeah, we can enter easily, not a big issue.
Why to do otis?
So generally, I like to keep my, I don't know if you can see the external view. Generally, I like to keep the monitor right opposite so that I don't have to strain for a long time looking on right opposite in the line of eye. The stress and the strain is much less.
Okay.
So we're using a Karl Stoss working element, laser working element, which is. I hope the endoscopic view there is decent, sir. Are you getting a good endoscopic view?
Screen करो. Dr. Samir.
Getting any endoscopy view, sir?
ये इसको भी क्लीन करो. ये ओटी का डोर्स क्लोज कर दीजिए. कूलिंग अच्छा नहीं होगा तो फॉगिंग होगा. डोर क्लोज कर दीजिए. Okay. A little bit table up, please. Table up. Stool आगे. Sorry, are you getting my?
Yes, sir.
Yes,
Now
sir.
getting
As well as endoscopic view?
Yes, we are having the endoscopy view.
Yeah.
Uh,
Can someone show the external view? External. So I am passing the laser fiber through the laser carrier.
which instrument you are using? Please tell and it.
Carl stores.
Okay.
And that is what I want to show, that it has a locking mechanism for the fiber. इधर दिखा दीजिए, side से side, nothing side.
Gallstones is having some locking mechanism. They have to rotation it and make it fix the fiber. That's
Yes.
it.
Can you see it? I don't. Or so I'll just
Which
rotate. Beam on during my enucleation. We are
Yes.
using a quanta laser today, 100-watt laser, and in
Okay.
that we are using a setting of 1.5 joules and 45 hertz with medium pulse for enucleation, and 0.6 and 35 hertz for coagulation. So as this is a large prostate with a large median lobe, I would be demonstrating a 3-lobe technique. I'll just define my incisions. So this is where the Vero is. So we'll start from 5 o'clock here. There is a natural groove. We have to start making the incision from here, and in the natural groove we have to come till the verumontanum, till here. Then again on right side at 7 o'clock across the median lobe. On this side the groove is not very prominent, so we'll have to make an artificial groove on this side and come again till the verumontanum. Another option in such cases is that we can take out as 2 lobes, wherein one lobe is the entire left lobe and the right on the other part comes out as the median lobe and the entire right lobe. But for demonstration, I will try to demonstrate a 3-lobe technique. Now I'll just mark a marking here before I start. Then once I've taken the 5 and 7 o'clock incisions, I'll be turning the scope like this. I will be making a distal marking here. Because anteriorly there is no landmark. So we'll be making a marking here to mark the distal limit. Then we give our 12 o'clock incision and bladder neck till this part. Then we will be giving the apical release incision, which will be separating the sphincter, which is here, from the adenoma, which is here. And then we go about enucleating the later lobe. Okay. So I'll be starting with the enucleation now. Laser ready, please. Okay, so this is the.
So your plan is to make a artificial sulcus for the right side, but the median lobe sulcus and the left is almost good, but in the right side it is not that much clear.
Yes, it's not that good. So I
Yes.
have 2 options. One, I can do a 2-lobe technique wherein I take out left lobe as one piece and this entire median lobe and this right lobe as one piece. The other option is I make a sulcus.
Yes,
which
there is,
will be-
the sulcus is quite clear, but it's not that much clear as comparison to the opposite.
I don't think it is not there. See, this
Yeah,
is the
yeah.
median. When I try to cross here.
Yes, that part is not clear. Okay.
So I'll be making an artificial sulcus here for demonstration.
Yeah.
Okay, I'll be starting with the enucleation now.
Uh,
So just
so,
making a.
we are connected to both OT or one?
Yes, sir.
So I'm making an inverted V-shape incision here, just proximal to the Veru. Can these lines go away?
Tanu sir will be watching you, but now we are going to OT1. We'll be connecting to Arvind Panda sir. Arvind sir, can you hear us, sir? OT1 AV team, turn on the audio, please.
फ्रीक्वेंसी बढ़ सकती है? एनर्जी कम तो नहीं करी ना?
Dr. Arvind?
It's not connected, I think, na? Dr. Tanuj, is it audible from our side?
Yes, yes, I can hear.
Yes, you please continue. We're having some problem in connecting the other OT.
Okay.
Yes, you please tell, what is your laser setting?
Yeah, this is laser setting right now is 1.5 and 50 hertz. I had started with 35 hertz.
Okay.
Felt I need more frequency. So I just increased the frequency a little bit. So now it is 50 hertz. So I'm operating at 75 watts.
Okay.
You will change the setting or you will continue with the same?
No, I changed the setting. I changed the setting to 75 hertz. Now, this is what I want you to see. This is the capsule here. This is the adenoma. The fibers that stretch up, these are the fibers we are supposed to divide. Like this. Are you getting a good view there?
Yes, sir. Yes.
Very
Can
good
you
view.
appreciate the fibers that I'm dividing? What is
Yes.
important is that you don't have to be very close and you don't have to be very far to this area, to the fibers. That's why I like to keep the pilot light on, and what I ideally like to see is a halo around the pilot light. In this particular screen, I'm getting some lines in between, so I cannot see very clearly, but I don't know if you can appreciate that halo around the beam.
I think this is because of that.
Yeah, they always say earthing issue or some issue, but somehow with the CMOS cameras, I think that is the issue. So now we will be making the.
So this is one marking you have done. Then your plan is to go for digital marking.
Plan is to give the cut in the incision. So I just realized that actually this lateral lobe is on also on left side also it's coming almost till middle. So this groove which was apparent, I was thinking at 5 o'clock, it's actually a little more medially.
Okay.
So let's see. I'll start a little here. Yeah. Now I'm giving the 5 o'clock incision.
Okay. So how do you feel whether the size of prostate has got any difficulty level, or what is the optimum level or very easy size of prostate to be tackled in HOLEP? Your point.
To start with, someone should not start with either very small or very large prostate.
Okay. Ideally 50 to 70 gram is.
Yes.
Okay.
Exactly. So that is the best size to start with. Also, that is good size to demonstrate. Because large prostate, sometimes, someone who is viewing also might feel. I'm not able to reach. I have to drop the. Also looking at the same thing going long time.
Is the other OT connected? I think he is.
Please connect to
OT1,
other OT.
Arvind sir, can you hear us, sir?
Yes, here I'm hearing you. The
camera.
the urethra is friable.
The lines are here.
Sir, we can see that lot of adhesion and
लगातार lines आ रही हैं. नहीं तो इनके पास कार्सलोस मॉनिटर तो है.
So I need to.
कैमरा सोर्स का वोल्फ नहीं.
The vision is not good, sir. Arvind sir, vision is not good. Can the cameraman focus little more on the
Vision is not good. I
physical
also
parts
realize that.
with a zoomed view?
No, कुछ होगा नहीं, वो कैमरा का ही इनहेरेंट इशू है. या तो कैमरा चेंज होगा.
पावर अलग है ना. पावर कहाँ से दिया है?
पानी चालू है. पानी प्लीज.
पावर कहाँ से है?
बड़ा कोशिश करना खत्म ना हो, ठीक है. और एयर भी ना आए, ऐसा भी ट्राई करना, ठीक है.
Someone is blocking the camera. OT1 Arvind sir, someone is blocking the camera.
Give me that one. Deepak, and energy पूरी नहीं आ रही, पूरी नहीं आ रही, ये माइक गिर गया बेटा, इसको ठीक करो।
वो रहा, एक मिनट।
Hold this, hold this.
Dr. Arvind,
Yeah, I'm trying to take the switches. 1 second. After I take the switches, I'll tell you.
what you are doing now?
I'm trying to take the switches in the.
So you are taking switcher from the Apex.
1 second. Do the second one. Cut through. Close, okay. 1 sec. Just 1 sec, hold this. I think I'm going to drop the urethra further. The urethra is very friable, as I expected. 1 second. I'll just take this off a second. And I will just drop the urethra a little bit. Remove this. Gateway assistant. Just put the retractor here. Yeah, hold this. One second. This part.
I think other OT is not connected, no? So which OT is connected now? Dr. Arvind,
Yeah, just a minute. I'm just trying to get the urethra out. Give me 5 minutes.
okay, okay.
Give me 5 minutes. I'll just show it to you. Yeah.
Yes, please shift to the other OT. We are happy that Dr. Anil Varshney is with us. I think you should have suggestion from him only. Dr. Anil, please.
Yeah, good afternoon, sir. Right side का हो ही नहीं सकता. Am I connected? Just one thing, hold it. Give me the forceps.
Please. Hello, Dr. Tanuj. Hello.
Can you hear me?
Yeah, please.
Yes, sir.
We are having Dr. Anil with us, Anil Varshney, sir.
Good afternoon, sir.
Hello, Tanuj, very good afternoon. I'm seeing you doing HOLEP, and the question which was asked by the audience is that the rim of the sheath is being seen. So what do you say? Why it is being seen? At whenever you
A little bit of it will be seen, sir, because I think yeah, that's the instrument issue. Generally, it's not seen.
the other problem which is being observed is these lines.
Yeah, that is the issue. And that is the issue with most of the new CMOS cameras, sir. That's why for HOLEP, we still somehow want to use the old image one, the 3-chip system.
Because this holmium, even the electric supply is different. So one has to see if you do holmium, the OT has to be, the supply has to be changed and the earthing has to be improved. Because recently we have started purchased this thulium fiber laser, which can be fitted to any OT. However, for holmium, the OT has to have a special supply.
Probably that is the issue.
Yeah.
But with the lines coming in between, the vision does become poorer. I can still see, but I think in the auditorium, you might be seeing more of these lines and the disturbance in the vision.
Okay, not very clear. Can I have another right angle like this side? All right, line back, Jana,
Yeah.
So in the 7 o'clock incision that I made, I'm gradually coming back to this area, which I had marked earlier, just proximal to the vero. And I'm going on deepening the incision.
Give me the future sister, give me one more.
So the Tanuj, the basic problem, whenever we want to teach the residents and the juniors is that how to maintain this plane, because you have done so many, so you are finding it easy. But most of the time, the beginner would get lost inside these planes. So could you tell that how are you maintaining it so nicely?
Currently, I'm giving the 7 incision. So it will grow on the right side. This also demonstrate a 3-lobe technique.
Just minute, show it to me.
You have to follow the same line as we come back towards the vero. That is important. If we give multiple incisions, then we can get lost. One more thing that I do is, as I come back towards the vero, I go a little medially also.
Yeah, for the audience, I think we must see that he goes back to the place where the capsule has been exposed, so that he maintains that line. So he comes to bladder neck, he is now maintaining the capsular plane and he goes whatever his point is comfortable with, and then he'll go back to the neck. So that is the trick, that you, once you have found the plane, then you keep on going to the plane. Is that right, Tanuj?
Yes, sir, absolutely right. Also, anytime in doubt, we have to come to the defined area. Like here, there was some tissue which was being cut in between. So I will not go on making multiple planes here. I would rather go back to the area which is better defined and start coming from there and come to this undefined area. As you said, maintaining the same plane and going back to the areas which have been identified earlier where the capsule is identified.
Yes, speculum is okay. Speculum is okay. Speculum is not the issue. Speculum is extremely deep. Speculum is required, but
now we are having to cut through the tissue because there is no natural groove here. We
So
try
how
to
much
reach
is the energy at the moment which you are using?
Sir, I'm using 1.5 joules and 75 hertz. This is a quanta machine.
Okay.
We can also go for, we can also add the vapor tunnel, sorry, the virtual basket mode in this. But I'm thinking I'll do one lobe with the normal energy settings, and the another lobe I will show with the virtual basket mode. Now here we can see, appreciate the difference. Light come हुआ है. Light कुछ कम हुआ है.
Yeah, we are not getting the kind of quality vision which.
Give me this. Give me the knife. Give me the knife. Sorry, give me the scissors.
बढ़ाइए.
Give me the scissors. I'm going to drop the.
थोड़ा better हुआ. Okay. So these are the capsular fibers, sir. The shiny white transverse capsular fibers, and this is all the adenoma, the fluffy part.
Capsular fibers are nicely seen at this point.
So in the distal part of the prostate, there is some tissue which is causing some difficulty. So we come back to the proximal part, and the same plane we try to continue and take it distally. Here we'll have to cut through the tissue because we are making a groove which is not there otherwise. There is no other way to do this. So just complete this. When we cut through the tissue, sometimes we get a jerky movement. So we have to be careful not to come too much distally. कोशिश कीजिए air ना आए. To the bone. No. Other side.
Dr. Tanuj, regarding coagulation part,
Yes.
yes, how do you feel thulium versus holmium?
During the cutting, probably the coagulation with thulium is a little better because it is more of a, I mean, the heat generated is definitely more in thulium. We all know that.
Yes.
But, and focused coagulation, I feel, is better with holmium.
Okay. But ideally, the take point should be the plane of dissection. That's it.
Exactly. So in holmium, we try to maintain the point of the plane correctly, and luckily in holmium we can see the capsule in a better way compared to holmium. So when we maintain the right plane, the bleeding is generally less. If there is some bleeding, that means either we have cut through the adenoma or we have gone deeper in the capsule.
Yes, absolutely.
Flip to me. All this tissue has been giving me a little bit of a tough time. It was not giving me easily. So I'm
Dr.
doing
Tanuj, what is your experience with small prostates? How these procedures?
Small prostate, also we can do it, sir. Our experience comes from those patients who are on antiplatelets and they cannot be stopped. And in smaller prostate, I personally prefer to do an en bloc technique. It's much more faster. And now we also add a bladder neck incision at the end of procedure, because the incidence of bladder neck stenosis was more in smaller prostate. But as a beginner, one should not attempt with very small prostate because they are more sticky. You'll face more difficulty. You'll be either too deep or too superficial.
What will be the chance of bladder neck contraction in those patients?
What will the chance of bladder neck contraction?
Yeah, in doing small prostate.
In small prostate?
Yeah.
No, generally it's very less, sir. If the undermining is not there, if there's not too much of undermining of the bladder neck, the incidence of bladder neck contracture is less with holmium. In my experience, the thulium fiber cases I had done, or the thulium YAG also, somehow they had, but then I'm not the expert for thulium fiber. Maybe it had something to do with my technique rather than the laser process.
Yeah, another point, Tanuj, regarding erythrotomy through laser, usually post laser fibrosis is quite hard. How post erythrotomy through laser? Stricture, killing the stricture in laser. The fibrosis is quite hard. So how do you feel the bladder neck incision and other?
Somehow I have had good results with bladder neck incisions with laser, sir. Even in those post TURP or post other enucleation strictures, I have had good results with laser BNIs. Also, I use the same setting for BNI in that case. I use a higher setting which cuts like a knife. If I use a smaller setting, that would do more coagulation than the incision, and I think that can again cause bladder neck stenosis. With a hot knife versus cold knife.
Okay. Actually, I do use an thulium fiber laser. So I had done around 8 to 10 cases of bladder neck incision, but I had a very bad result. So I have stopped doing bladder neck incision through thulium fiber laser. So now I have moved again to the age old Collins knife. So I don't know any other person can have any opinion.
Holmium laser, I would be comfortable. Sir, thulium fiber, I'm never comfortable at the bladder neck. And today also I have seen that generally everybody likes to leave some tissue near the bladder neck with thulium fiber laser because the chances of bladder neck stenosis are there.
No, Tanuj, I think you would agree that the contractures develop. Basically, there are a lot of reasons why contractures develop.
Yes.
But one of the thing is if there is a scarring at the bladder neck and you have done overzealous resection, or you have got some residual tissue. So when the question arises that you do only incision, then there is definitely a chance that there will be scarring. So what I have observed over a period of years, and our incidence of bladder neck contracture is now definitely less than 1 to 2%. What we do is we don't we leave one strip at anterior 11 to 1 o'clock. That is one way of preserving bladder neck. And the other thing is that at the end of the enucleation, there was a discussion just now about small prostates. So small prostates also can be very nicely enucleated, but at the end of the enucleation, you give a deep 6 o'clock cut. That is a bladder neck incision at the end of enucleation. So that is something which now we do routinely, and we don't observe any contractures. So the question is about thulium. Again, thulium, we have seen contractures, but the incidence of thulium fiber is high. But now we are doing a randomized controlled study in our setup because I have purchased a 60-watt thulium fiber laser also, just because that we had large volume of work of stone disease. So both the things, and now regularly I am doing prostates both with thulium as well as holmium. Maybe after we'll be able to give you the results.
Sir, bladder neck contracture. Regarding bladder neck contracture and planning it through BNI, laser BNI versus hot knife BNI.
It is already a formed contracture, then again we do the incision with holmium only. Yeah. And it is very good. No recurrence.
Holmium results are good, Dr. Sandeep, not as bad as you said with thulium. Of course, if again the patient forms a contracture, then I would cut with a cold knife, which is now not used very frequently.
Sir, one more question. In post-op patients with the HOLEP or thulium or whatever green light, what is the chance of dysuria?
In my experience, after HOLEP, the chance of dysuria is not much. Any laser which would cause more charring would cause more dysuria. But we do tell all the patients that you will have some dysuria. You can have a little bit of bleeding for 2 to 3 weeks. And we also prepare them that they might have some stress incontinence, which recovers.
Is that so that with green light we have more chance of dysuria there? We often
Anything that ablates or coagulates will have more dysuria.
Oh.
Basically, dysuria is a function of residual tissue. The tissue which is necrotic and poorly vascularized tissue. Now, even here, if you see, he is enucleating, but there are areas where you can see this yellowish discoloration. So if you have this kind of a tissue which is avascular and left, it keeps on sloughing for some time. And dysuria may be there maybe for a few weeks before it settles completely. Therefore, I think you people have seen me operating. There is hardly, I just bear the capsule all around. It's only white glistening capsule. And that is what we have to achieve with HOLEP. The beauty of HOLEP is that there should be, as I always say, tangerine technique, that you have only peel remaining and no adenoma remaining.
This is one.
That is the art of
in the right position, please.
you can achieve that art. That is most important. Any surgery for that matter done by any operator, even it is not the question of energy. It's the question of how you do it. So all these conferences, I think the seniors would agree with me that it's the man behind the machine which ultimately translates into the results.
I would like to thank all the chairpersons for this enlightening and excellent discussion. And I would request you, sir, to please proceed for the lunch. We may be closing in another half hour. I would request Anil Varshin, sir, to please stay back. For the next session, I would like to request Professor Uttam Mehte, sir, Professor HOD, PGI MER session. Dr. Professor Apul Goyal from KGMC Lucknow to please join the session. Dr. Rajesh Tiwari, Professor IGIMS Patna. Dr. Pushkal Bagchi, Professor Guwahati Medical College Hospital, Guwahati. Dr. Muruganandan K, Senior Consultant Urologist, Global Hospital, Chennai. Dr. SN Mondal, Senior Consultant Urologist, Kolkata, to please join the session.
Am I still connected? Give me the small needle holder. That's not this one. The smaller one is gonna give. Anyway, give it to me. I will confirm it. Suction to me. Hello.
No, sir, we are continuously watching you, but we'll now move to OT1, where Arvind Panda, sir, is currently doing dorsal only repair.
Sure.
Sir, can you hear us, sir?
Arvind? Dr. Arvind?
Yes, sir. I am just, I have converted that into a more of a dorsal onlay, sir. I am taking the sutures here because extremely friable urethra. So in another 10 minutes, I'll finish the sutures. I'm sorry you can't see very well here.
No,
But
I
the
was.
urethra is quite wide. You can see this God's piece. It is going completely inside.
No, I was listening you carefully. You are telling as expected the urethra is so friable. My concept is in a patient with a stricture,
No.
you are expecting a lot of fibrosis also. But there is hardly any fibrosis.
This is this one.
Friability is there.
Here the mosquito here. Put a clip here, please. Give me one more. Pull towards you. Give one more. No. Pull it towards you. Yeah, give one more.
Arvind, are you okay? Can we ask some questions?
Yes, sir, you can go ahead.
And that's what I was telling. So I was just listening to you carefully. You said that
Give one more.
friable urethra. So in a stricture disease, why do you expect sort of friability? Maybe that is the reason why you are telling that.
The urethra is very friable, sir. The urethra is very friable. It is tearing. So I've decided to take the least traumatic way, drop the urethra. I've dropped it from the bone. I'll show you after I have taken the sutures.
So which suture material you are using? Arvind, suture material?
Arvind, sir, can you hear us, sir?
Yeah, I can hear you. Can you see the urethra here?
No,
It's extremely
just
friable
asking.
urethra. I have got the mucosa from both sides. I have dissected it till almost till the pubic bone. Because I took out the retractor because that was creating a lot of it was pushing the urethra into the depth. So I'll just show it to you again. Now can you see it? Just hold it. Give me one more, sister, for the apex. One more suture for the apex. So I'll just show this to you. 1 minute. This gauze piece is going inside the urethra actually. Now you can see it very clearly. This is the.
He's doing inlay and only post.
Hello. Arvind.
Sir.
Hello. Dr. Asian Mondal from Calcutta.
So I can't hear you.
Dr. Asian Mondal from Calcutta.
Yes, sir. Yes, sir. Tell me, sir.
Do you hear me?
Yes, I can hear you now.
Jai, one question. Why would you need double phase type of urethroplasty in this patient? If the
I don't
urethra is
understand, sir.
viable one, you are doing both inlay and onlay,
Yes, sir.
isn't it?
No, actually, I am doing more of a.
More?
Now you can see the bladder. Can you see it, sir? The exposure.
Huh.
So I am doing more of an onlay than an inlay now because it's a very friable urethra.
Oh,
It's
so you have
extremely friable. I am not able to do a inlay without tearing the urethra further. So I've
okay.
just converted into an onlay now.
Only
Onlay.
dorsally onlay. Okay.
Onlay, sir. Exactly. I have to take one apex suture and then I'll put the graft. I'll show you. Now can you see, sir? I'll just show you. Can you see the inside of the bladder?
Yes.
This is the urethra here. This is the bladder neck, this part. And here I have taken it till here. Can you see that, sir?
Dr. Arvind, can you flash a little bit of saline inside so
Saline,
that
can you show the saline, please?
And one more suggestion is rather than showing the light
So
with
you
the
can see
light
that.
cord.
Now can you see?
Ready. Arvind,
One
rather than
second.
Arvind.
Sir, can you see it now?
So what I am suggesting that rather than showing the light to the light cord, you can attach some laparoscope. And it will be very easier for the assistant to hold the laparoscope and
Okay, we'll get a laparoscope. Do we have a laparoscope here?
then it will be better
Get a
rather than
laparoscope?
it's dangling and then it's very.
Okay. Now I want a sister. Give me a maybe a 30. A 30. Give me that. Whatever you have, give. Let me see. This one is it? Okay. Let me try. No, that's okay. That's okay. Give me the long needle holder.
That is also. That is in the dorsal. Yes, mobile is all around.
Cystoscope also we can use. Actually, yes.
Yet mobile is only the
One
dorsal.
second. Now show it to me.
Not there at the time I was having.
Instruction to me. This is what I will hold it with. No, let that be here.
Incisions also dorsal.
It's
950 when I'm there. Yes.
No, he didn't follow the ventral part.
Okay, it's gonna be tricky for me to take this. Yeah, now I've taken it. Can you hold this, please? Can you hold this speculum? 1 minute. Give me the forceps. I got the forceps here. Wait. Take it away for a minute. Suction to me. Yeah, hold this please. I've taken the apex. I don't know if you could see it. This is in the mucosa. Straight clip. Yeah. Now, can you give me the graft, please? Fresh gauze piece and graft. Put दीजिए. Okay. Give me the fine scissors. No, not pot. This is fine. Give me that fine one. Yeah, this one. Sister, back to you. This one, needle back to you. These two back to you.
Arvind.
Yes, sir. I'll just show you, sir. And then I'll just put the graft. I'm just defatting the graft. I've taken the apical suture, which I think is most important. And rest of the sutures also I've taken. Just a second. I'll just defat little bit, whatever I have, because I haven't done it after the.
Could this case have been done with ventral inlay also, what was demonstrated in the morning by Saranendu? So could have been done with the ventral inlay also with the same result, or how did you choose the dorsal onlay versus ventral inlay in a female urethra?
Put some water here.
Today that we have so many methods of treating surgically the prostate gland. We saw thulium laser, we are seeing holmium laser. we have bipolar, we saw bipolar TURP, and we have monopolar. So are there any guidelines as to, which patient is suitable for thulium, which patient is suitable for holmium, or bipolar or monopolar TURP? Will you like to enlighten?
I think Dr. Basne can tell better, but I think one of the main criteria is the size. But nowadays people say size is not the criteria. For any size they go with the laser or enucleation. So resection versus enucleation versus vaporization, there are three techniques. So size may be one of the criteria as per the EU guidelines. And second is the which way you are comfortable with. If you are doing commonly with a one type of surgery, if you can get the best result, that is the best way to utilize this thing. It is my personal opinion.
Yeah, I think what Uttam is saying is absolutely perfect. It is the art of doing anything. With any modality, you can give good results. So when all these modalities are in your armamentarium, and the difference is that thulium fiber laser which has come, it is much more bloodless.
I've taken 5. I have not taken
Patients
3.
who are on anticoagulants,
I'll just show you.
we are even continuing with anticoagulants, and I find it safer for those patients, even large prostates, and because holmium slightly more this thing. So with holmium, if you do, you can see here that how Tanuj is doing. It's absolutely white, but at times you do get bleeders, and many a times these bleeders you are not able to coagulate just because if you have tissue on both the sides, the vessel retracts, which doesn't happen with thulium fiber laser. In thulium fiber, it is absolutely coagulative laser. But in principle, thulium fiber laser is a diode laser. So if you see the wavelengths which has been modified, the covering of this thulium fiber. So therefore, the hemostatic properties of thulium fiber laser are much better. Coming to monopolar and bipolar, they are the energies where there is bleeding and you coagulate the bleeding. So therefore, all these modalities are slightly different, but in the hands of an expert, they all.
That's what I was just telling. Size is the main criteria. And of course, nowadays, suppose, see, definitely I like to do a robotic surgery. If it's a very huge prostate, 300cc prostate. So if we do a robotic simple prostatectomy, it will be less than what Rohit can do with that stapler. So he has to spend, the patient has to spend 5 lakhs. Only Rohit's patients can afford that. With that 5 lakhs, half of the price, you can go for a robotic simple prostatectomy.
No, I think the time has come that we have to subset, because the question of Apul is very pertinent, that there is a subset of patients, because the spectrum of BPH is also very wide. On the one hand, we have small prostates. The other is the young who wants to preserve sexual function and a medium-sized prostate. The third group is absolute indications of prostate where you have neglected prostates, where you can't afford to leave even a small amount of tissue. So this is a very wide spectrum of BPH. That has to be given a due respect. And coming to the subsetting business, if you have absolute indications, large prostate, vascular prostates, and obstructive uropathy, neglected chronic retentions, where surgery, the enucleative surgery is the best. While the patients, young patients with preservation of sexual function is the goal, you have these urolifts and all. And the patients who have small prostates, in contrast, since morning we have been listening that small prostates, one doesn't have to do lasers. But in my hands, even prostates, you will be surprised. Very small prostates also, if you become an expert in enucleation, you can do good enucleation. And 12 grams, 17 grams, which is reported, because there is a problem with the reporting also. When we go and scope 17 or 20 cc of prostates, we are able to see a lot of adenoma. So question is, adenomectomy is the goal. And with that goal, we should be able to serve our patients.
So one comment you mentioned that when you use laser, so you can do laser prostatectomy even in patients who are on anticoagulants. So after prostatectomy, the bleeding can happen after 1 month also, after 20 days. So my question is, what is the difference in the fossa that you get after 1 week, for example, after surgery between TURP and laser? Is the fossa, is the nature of the fossa, residual fossa, you can say, or whatever, different after each modality? Or is there granulation tissue, whatever modality you use, the granulation tissue remains the same because there's raw area there. So the patient can bleed post-operatively.
No, your point is that what kind of fossa you leave at the end of the surgery.
End of the surgery. Is
So-
there a difference between these different
Yeah,
modalities in as regards the fossa?
No, that is where the skill of the operator comes. A good operator will be able to give absolutely clean fossa with any modality. So that is where I want to tell that even with the thulium or holmium, you can provide a absolutely capsular fossa, which is difficult to get from thulium or monopolar or bipolar. But with holmium, it is easy to get.
Sir,
That is the difference.
As you're talking about the
Uttam,
bleeding,
can I say something?
Situation also, you give me such a.
The,
give me
the
one more
sec- secondary hematuria which you are right now talking, that is irrelevant to the modality which you used.
Please full length,
Only
but
difference-
Absolutely right.
Only difference between the immediate post-operative, per-operative period. When we do laser prostatectomy, even on antiplatelet patients, what we found is, there is no active bleeding, but there is a lot of passive bleeding. So if I do a HoLEP without patient being antiplatelet and I do HoLEP on a patient on antiplatelet continued, my post-operative irrigation period stretches from 8 hours to say about 24, 48 hours. But after 48 hours to 72 hours, the irrigation requirement goes down, patient do well. What hematuria happens after 14 days, that is secondary hematuria. Now that is entirely different subject. But why in HoLEP or TUFLEP the hematuria is less? Because we go right up to the capsule first and the laser has a sealing effect. So when we cut, it seals. While in TURP, you take a chip, there is a bleeding gets retracted, and you do coagulation. There is a sloughing of that coagulated eschar. And that's why when that eschar sloughs off, there is hematuria, which is not the case in the laser enucleation.
I think your explanation is scientific, because when we go for resection with a TURP, definitely nobody can say that all adenomas have been removed.
Correct.
Little bit of tissue will be there, and the depth of thermal injury following TURP is more compared to any sort of laser. So
Very
sloughing of the tissue is more common.
Yes.
Theoretically, it is possible. I don't think anybody has studied this angle. So we do not have any data to support this conjecture.
Yeah.
But most probably it is like so. What I just want to ask Dr. Bhasne, so for a big prostate, normally what we go with alpha blocker plus 5-alpha reductase inhibitor. So one of the idea of 5-alpha reductase inhibitor is most probably there will be less bleeding while you are going TURP or a TURBT. But whether there is any change in the plane between the capsule and this adenoma if you give 5-alpha reductase inhibitor, Dr. Bhasne?
No, the only thing is the fibrosis is slightly more. If you have already given 5-alpha
So
reductase
technically,
inhibitor for
it is not
technically,
difficult to find the plane between the.
no. Technically, if you are in the right plane, you will always find the plane, because I'll show you tomorrow this thing. Patient of even many a times people are scared of doing this enucleative procedures in carcinoma prostate. And we are able to find planes even in this thing, carcinoma prostate. So instead of doing channel TURP nowadays, we do cytoreductive HoLEP in those patients. So planes are possible. That is again the art of doing and finding the plane.
But Uttam, do you really agree to this policy? I have been on the guideline panel for the USI guidelines for BPH, and we came across several meta-analytical studies, and we didn't recommend that in guidelines to keep a patient on alpha blocker plus alpha reductase inhibitor just to achieve less bleeding during a surgery. No.
See, there is a waiting period.
Correct.
So when the way that neoadjuvant chemotherapy had come for MIBC,
Right.
because a long list of patients who are waiting, so they had started giving chemotherapy and they found there's a 5 to 10% benefit.
So
That's how it had come. So it is just like that.
Don't
that
make your
your-
patient wait, send them to me.
So in the waiting period, give something.
I
That's it.
agree.
Dr. Bhasne, one question. Have you operated any post-TRP patient by laser? Say after 3 or 4 years, there is a regrowth of the
No,
prostate.
I had a very large series, and we presented in World Congress Endo Urology more than 100 cases of post-URP residual prostates, it is very common to have patients anytime for post-URP, maybe from 6 months to 20 years, 10 years, more after longer duration, because they don't come to you, they may come to you with retention of urine, but majority of them come to you with recurrent hematuria. So there you are, because if they are voiding, but recurrent hematuria, you have to scope them. And when you scope them, you find them, there are a lot of boscillations, nodularities, irregular prostates. So these are the kind of post-URP prostates. And that tells what Dr. Uttam was saying, that when the resectoscope we use, we are not able to give you as clean a fossa as is possible with this enucleative anatomy. We call it anatomical enucleation of prostate. So all these, the whole terminology has been recoined or rephrased after this 2016. Thomas Herman had published this, that all these and even the people who are doing monopolar TURP, bipolar TURP, they are shifting towards bipolar enucleation and monopolar enucleation. So the goal is that enucleation is going to give you a complete removal of the prostate, vis-a-vis all the modalities like TURP or bipolar TURP, you have a chance of residual prostate. And there are a lot of studies which have found serum PSA levels and post-TURP residual prostate. And one of the publications showed that 46% is the tissue left post-URP. And then there are a lot of this thing studies. But I must tell you that I was asking some of these operators that do they regularly do PSA, serum PSA levels at 1 month, 3 months, 1 year, and yearly thereafter, to see the kind of, because that is the marker which tells you the how good enucleation you have done. So if we say HOLEP, the prostate PSA levels range between 0 to 1.
Give me a lot of water.
Otherwise, if you do PSA after TURP, the range would be somewhere between
Who was asking whether it will crumple? Now it won't crumple.
that tells you the kind of removal or the anatomical enucleation versus TURP.
So completion of the surgery can be assessed by biochemical marker plus imaging. People have done even an ultrasound.
Yes.
So how much you have removed? That's what I think Dr. Ramesh was telling us at the end of the day. You have a Tumi syringe, put it there in the Tumi syringe, how much you have removed. And in the post-op period, I think one can go with the ultrasound. There are studies. The ultrasound and PSA, of course, that will be fallacious. It depends on the glandular tissue.
On my hands.
So how much glandular tissue was there? So, and what, of course, other than PSA, absolute value, what is the PSA decline that might give this thing? So apart from PSA decline, the imaging post-op also, there are studies available. So what was exactly how efficient you were as a surgeon? That can give some idea. And maybe some study can be
Excuse
done.
me, sir. Sir, we have Dr. Arvind, sir, ready from OT1, sir.
That is also fallacies.
Arvind,
But
sir.
at least gross tissue can be seen.
But one thing, sir, regarding PSA. PSA is because the prostate develops from the transition zone. And at the same time, if the patient is having adenocarcinoma, very silent disease also from the peripheral, the PSA will rise.
This is the center one, right?
PSA may not be a good.
No.
That is different.
PSA gives us a volume, estimate of the volume of the BPH also. I did have exploded this here prostate. So that's why PSA is being done for so many patients with BPH, not for the imaging. Suppose sometimes we might see that there is a median lobe and the ultrasonologist might give a huge size of the prostate, which commonly mistake. But if you do a PSA, that will give us actually an idea whether it is a fallaciously given volume of the prostate by the ultrasonologist or it is a real volume. So that is a marker of prostatic volume. That's what we are talking about, the volume. So volume can be used or assessed by PSA also.
Just 2 days before I done cystoscopy in a patient. Post-URP,
So Dr. Arvind Panda is waiting. Uttam.
Sir, I'm just
Sir,
putting this
Arvind.
graft inside.
Yes, sir.
The method to put the graft is actually to slide the sutures inside. Hold this, please. The method to put the graft is actually to slide the sutures inside. So I take 5 sutures so the graft doesn't crumple. So this is an onlay now, not an inlay anymore. Very friable urethra. It was tearing. So I have taken 5 sutures, not 3. Normally we take only 3 sutures, but this is 5 sutures.
Arvind, my question is, when you take a bite through the end of the graft, so do you put exactly at the end or little bit distal to that so that some portion of the graft can be just pushed inside the urethra? Beyond there is a raw area that can be covered.
So yes, sir, if you put a catheter, it is theoretically possible that a graft will survive even if you don't take mucosa to mucosa and put a catheter for some time. That is theoretically possible. But if it is possible to take the sutures, it is better to take the sutures. So that way we can be certain that the graft will not crumple. I'll just show you the sutures once I've taken.
And my
If
question
bleeding
is,
stops, everything stops.
so exactly taking at the margin or little bit few millimeters
That is
prox?
the margin I've taken.
Okay.
I'll just see this to me.
And I was asking you which type of suture you are using. Is it PDS or Vicryl? Arvind, what sort of sutures you are taking?
So these are 40 PDS sutures. Give me some water. These are 40 PDS sutures. The advantage of taking PDS is it slides. For instance, I will show you in the next tie I'm taking. So
Is it a cutting needle or round body?
Sorry, this second. No.
Cutting needle or round body?
If you can see, sir, they are just going to slide inside. And this is free. So I'll just put something here. So this is nice and free. Water on my hands.
Question is the needle.
And then I can just push it inside. I don't have to really see. As long as I've placed my sutures well, I really don't have to see where it is going. I can just push it inside and I can be sure that the knot has slid to where I took the suture. If I take a Vicryl suture, that is not guaranteed because it's not always sure that this knot will slide to where it should slide. So that is done. This second one, I take 5 or 6 sutures because this is a PDS and then I cut this off. Needle back to you. And then this is the next suture. This is the edge here. This is the next suture. So this one I will keep long because it is possible for me to continue this suture. Water on my hands, please. I can actually come continuously on one side with one of these. I usually choose one or the other side. Right. I try not to crumple these sutures. I try to make sure that the graft is stretched when I take these.
Yes, Arvind, we are not seeing the field.
I'll show you, sir. I'll just see you, sir. There's some blood in the field. I'll just take it off now. Yeah. Put a clip. Hold this, please. I'll cut this off. Just a second, sir. I'll just cut this. This one, just cut this off. Yeah, that's cut this. So take off. Give me a fresh gauze piece. So I'm just showing it to you. So I've taken everything. Now you can see, sir, the graft is placed on top. I think it's
We
clear
don't
now.
see anything, Arvind. Your head is coming in the way. Yeah.
Yeah. Now, sir.
Yes, now you see.
Yes, now it's clear. And this one, I'm also going to put it here. Then I'll do a scopy and show you also. No problem. Can I have a mosquito?
Arvind, while you're taking a last few switches, we'll just go to OT2 and have the case presentation.
Sure. No problem.
Next case in OT2 is going to be a vesicovaginal fistula, where Dr. Nikhil Khattar is going to demonstrate a transvaginal repair for the VVF. So can we have the case presentation from OT2?
हेलो कैमरा रेडी है उधर पता नहीं चल रहा है ना चल हेलो 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 Hello, am I audible?
Yes, you
we
are
can see-
audible.
we
Yes,
can
you are
see-
audible.
Yes, we can see your presentation of PPT scene.
ये क्या बंद हो गया है?
We can see it. You can continue. Dr.
Hello.
Vivek, please continue.
Hello.
Yeah, we can hear it.
Yeah.
Yeah, we can hear you and we can see your PPT. Please continue, Dr. Vivek.
This is a 42-year-old lady. She has complaints of continuous urine leak, vaginal hysterectomy, fibroids. 6 months. She also has history of normal work between. She has undergone 3 normal vaginal delivery previous. She is a diabetic and extraurethral matters were normal and urine creatinine is 0.79 and on sonography there was no hydroelectronephrosis. Species defect was seen over lateral wall on the left side in the bladder. Her urine culture revealed no growth. Urography showed no hydroelectronephrosis and a CT cystogram has revealed a small defect over the left. So we ran a weeks back. Supratrigonal 5 catheter could be seen coming out from the left side of fornix vaginal cavity. So plan for this patient would be transferred by Dr. Nikhil Kati.
Hello. OT2, can you hear us?
Hello, sir.
So
Hello.
when was the hysterectomy done?
Sir, this was done 6 months back.
Sorry?
6 months back.
6 months back. Okay. So 6 months old fistula. Okay. fine.
Yes, sir. Yes, sir.
Another
she was on a catheter
question.
for 3 months, following which her leak persisted.
Yeah, she had leakage 2 days after hysterectomy, you are telling?
Yes, sir. 2 days after catheter removal. On post-op day 3, the catheter was removed. Soon after catheter removal, she started leaking.
Okay.
I'm handing over the mic to Dr. Nikhil. Hello.
Nikhil, we can hear you. Nikhil.
Hello.
Nikhil, can you hear us?
Yes, sir.
Nikhil, I'm Uttam Mete from PGI.
Hello, sir.
So with us, we have.
Good afternoon. So we are just beginning with cystoscopy, sir. Dr. Kalandi is there with me and he is doing the cystoscopy right now.
Nikhil,
Yes, sir.
do you do RGPs also at the time of cystoscopy, or you rely on only the CT that has been done to rule out any ureteral injury?
Sir, generally if I prefer to do an RGP as well, sir, because once I have seen a fistula that was there even when CT was normal and CT was normal and efflux was also present.
And efflux was present.
Sir?
And you said that efflux, you could see the efflux, but still the patient had a fistula.
Yes, yes, sir. Yes.
Okay.
What Dr. was trying to
early after her hysterectomy, and she has been worked up well. This is examination under anesthesia has already been done a few days back. I had seen the video as well.
So when we do, whether we do it robotic any sort of obstruction upstream. So what is the need for an RGP? Put another CM and all those things. So it's a supradiagonal fistula, CT is normal, urinary catheter has, and you have seen the efflux from both the sides. Is there any possibility? And is it justified?
It's usually a, abdominal approach that we prefer. Could be open or laparoscopic, but trigonal fistulas, we prefer vaginal approach, and we don't place ureteral catheters.
Maybe I'm a chicken-headed surgeon, so I always try to put a ureteric catheter for the safety. So we don't injure the ureter. So you always put an ureteric catheter both the sides, whether irrespective of the.
We always put ureteric catheter.
Occasional scenario where you find the fistula close to the ureteral orifice and you fear that you might injure the ureter. On that side, you can place a ureteral catheter.
A ureteric catheter.
Fistula is central away from ureteral orifice. There's no point putting in a ureteral catheter when we are doing vaginal repair.
Sir.
The fistula that he'll repair vaginally. So I'm not saying it's not, I'm not conveying that.
What Dr. Mandal was telling is also true. So not only to save yourself during surgery from ureteral injury, sometimes we keep the ureteric catheter just like post and you put it into the bag also. So in the same Euro bag, you can put both the ureteric catheter and then it can be kept for a few days.
Sir, I have a question, sir. Sir, I have a question to you. For how many days you keep this?
Normally, we don't keep it. Suppose it was very close to the social line and you feel. So that is a subjective sort of stuff. So normally, what we see also, we put the ureteric catheter and the end of the procedure, we take it out. During surgery, if you feel the fistula is very close to the ureteric orifice, you have taken bite and you feel there may be a little bit of edema and there will be obstruction of the ureteric catheter. Then I think few days means 2 to 5 days. So just like when we what we do in PCNL, you put the ureteric catheter into the Euro bag also. If you want to keep it,
this is right.
You don't keep it. But if you want to keep it, so you don't have to put another bag or another, so that patient will not be that uncomfortable.
Don't poke.
I don't put ureteral catheters when I'm doing vaginal repair. The reason being that 2 ureteral catheters and a Foley catheter coming out through the urethra is inconvenient for the patient. It causes lots of discomfort. I have seen my colleagues keeping it for 5 days or 7 days. Those 7 days for the patient is miserable. She can't walk and so many issues.
You can take it out at the end of the procedure. That is for the safety. Most of the time, it is for the safety during surgery, not in the post-operative period. What is asking in the post-operative period, that is another sort of a purpose if you really want to keep it. Of course, cost is a factor. Ureteric cost another way.
Maybe वहां से आना पड़ेगा.
I feel there's one surgery that should not fail because the patient has already suffered and the surgery should be such that it should not fail.
That is the reason I'm telling. So you should be all safe.
ये पकड़ना पड़ेगा.
You put an ureteric catheter, you'll be safe.
So that vagina distance. और अच्छे से पकड़ना पड़ेगा.
ये गाइडर मैनिपुलेट करो.
Nursing officer.
Nikhil.
इसको पकड़ना पड़ेगा. Yes, like this. So that the vagina distends.
Nikhil,
Yes.
you are in the vagina, you are doing vaginoscopy.
Yes, yes, sir. Yes, sir.
Okay. So have you done cystoscopy?
Yes, sir.
So can you show us again? We were busy in a discussion, so we
Yes,
missed.
sir. I'll show you again, but I could see only the scarred area, and could not see the fistula there.
Actually, this time the patient is having normal voiding with continuous incontinence. So this is what was presented by the resident. So is it possible that the patient is having a ureterovaginal fistula only and not a VVA that we are looking at?
No, but I think he's going to do the cystos. He already had done the cystoscopy. So normally what we do through the fistulous opening, we pass a guide wire or you take catheter. So it then pull it down through the vagina. So that gives a guide. He cystoscopy also.
Where? Okay, we have to do fornix the है ही नहीं. Which lady have you taken up? पानी तो आ नहीं रहा. पानी तो आ नहीं रहा. ये खत्म हो गया पानी. पानी तो चलो. नहीं मिथिलीन ब्लू रखो रेडी. इसको बंद कर दो. पकड़ के रखो.
Not fully.
गाइडर डालो ब्रदर. वायर बढ़ाओ. बढ़ा दिया. जा रहा है.
थोड़ा अंदर जा सकते हैं सर, मतलब ये
अब जा रहा है. नहीं कॉइलिंग. वापस करो. अब देखो.
लगा हुआ सलाइन में.
उसका चैम्बर बड़ा करो. यहाँ वायर बढ़ाओ. एक मिनट ऐसे धीरे. हाँ अब
Nikhil, you are in the vagina.
yes.
Huh?
And this is a lateral side.
He's inside bladder. Can you see the ureteral orifices first?
I saw, sir. This is the okay. चलो फिर से. हाँ डालो. नहीं. Okay. Wait. Let us come back to bladder. Let us come back to the bladder. रेडी रखो यूरेट्रोस्कोप।
ये
मिथिलीन ब्लू भी रेडी रखो।
मिथिलीन ब्लू रेडी रखो।
पहले मिथिलीन ब्लू टेस्ट किया था। दिखाओ राइट ऑरिफिस दिखाओ। This one is the right orifice. And this is the left orifice. So let us wait for the efflux as well. Can you display the imaging? हाँ है वही एंगल है। नहीं मिथिलीन ब्लू तो यहीं से डलेगा, वो तो उधर से आ जाएगा, बट हाउ I had seen guide wire also coming through. इसी में है अंदर। नीचे से यूरेट्रोस्कोप डालते हैं।
Nikhil, why not fill the bladder with methylene blue and look for the hole from the vagina?
Let me, I think, sir, first try a ureteroscope from the opening that we were seeing on the vault, left side of the vault.
Okay.
Because once I put blue, then everything will become blue and it will become very difficult to locate any. We'll just be able to ascertain that there is a VVF.
Actually, the tracks are usually tortuous. It's not
Yes, it
straight.
appears that it is a tortuous track.
So I don't think even ureteroscopy will help, but we can try.
No, but at least I can park it inside from where maybe can go. So ureteroscope though. Any अभी टाइम है? अच्छा, okay, so methylene blue ready?
If you want to dislodge the clot, you can connect. You can connect some saline to the ureteric catheter so that the clot can be dislodged.
ये इसमें कितना बिट methylene blue मिला है? ये सिरिंज से इंजेक्शन से लिया हुआ? एम्पूल से है ना? इसमें अभी saline मिला है?
Hello. Sir, can you just go to OT3? Dr. Anuj wants to wrap up.
ठीक होगा। Yes, cystoscope से उसमें डाल दोगे.
Tanuj, we are with you, Dr. Tanuj.
Yes, sir. Because you are
So
discussing.
Tanuj, yes, we are back with you.
Yes, sir, because Vashni sir was there and you were discussing with him. I didn't come inside the discussion. And I think most of the points were discussed. So I'm done with the enucleation part. This was a large 132 cc prostate. We can see the fossa all around. That's the left side, entire fossa. That's on the right side. There will be some tissue remaining here, which I always leave because this is where the bulk of sphincter is. This prostate was extending pretty much beyond the veru. This is the veru. It was extending till here. I have enucleated from right behind the sphincter. This is the sphincter area. I hope you can appreciate, sir. And I have enucleated from behind this here. And again, same thing on this side as well. And we are done with the enucleation. The lobes are here inside the bladder, and we'll proceed with morcellation. There was not much bleeding, so I didn't have to do much of a hemostasis, but a good hemostasis is must before starting the enucleation. I mean, before starting the morcellation. So sometimes should be.
So the end result has come very well and good job done. 3 cheers to Tanuj.
Thank you, sir. I'll start with the morcellation now, sir.
Stand by. Which morcellator you are going to use?
I'm going to use the morcellator from BioRed, sir. It's called Tumi. It's a nice morcellator. It's pretty fast. It has an oscillating type of action compared to the to and fro movement of Versacut, which is from Luminous. So, which I feel has a benefit that it holds the tissue nicely. Although some Versacut users feel that holds the tissue nicely, but I feel that curve or that shape of the blade helps us to catch the adenoma, and it does not leave it easily, so we can finish the job fast.
Tanuj, I know you're a rich person. You may have more than one morcellator in your theater. Have you ever faced such a situation that at the end of this, when you started doing morcellation and it has gone out of order and you are helpless? So what did you do in that situation?
I have only one morcellator in my theater, sir.
So if it becomes non-functional, so what you are going to do?
To have a good whole program, it's important to have a very good technician, sir. And my technician is accompanying me here today also. His name is Akhilesh, and they maintain the things very well. So far, I've never faced the issue because of morcellator per se. Sometimes there can be issues that the vision is not good, that adenoma is very hard, and it is not cutting. And that is when we do some maneuvers by which we can still cut. But if we are not able to do it, then we stage the procedure. We put in the catheter, we keep the patient on irrigation, and we come back again after 24 or 48 hours. And that time the morcellation becomes very easy. And if it is a faulty morcellator also, within 24 hours, we can get it repaired. So I think that should work. It's difficult to afford 2 morcellators, sir. Even one is quite costly. 2 बोतल चला दीजिए.
रोहित के ओटी में तो 3 morcellator है.
किन की ओटी? सर के. 2 bottles चला दीजिए. 2 bottles. So we keep 2 bottles on.
That's what happened in our OT1. So what he's telling is true. So we had to stage the procedure. But another option is you just give a small incision, suprapubic incision, and remove it if you really want to complete the job. But the whole purpose of doing endoscopic surgery is lost. So in that case, you definitely have to go for a stage procedure. So you have done it, put the catheter, come back. Once it is okay, then go for it.
No, I
If
had
the
faced.
adenoma is not very large, we can reject it also. But I find it very tedious. I still like to morcellate.
So I had been to Calcutta, one of the hospital, to demonstrate HOLEP. We did HOLEP, and then the moment we finished with enucleation, I asked, where is the morcellator? What is that? So there was no morcellator. So then that moving adenoma, we had to resect there and then, and it took double the time of the enucleation.
It is very difficult to
It's very
resect,
tedious.
na.
It's very tedious.
It is not attached.
Yeah, the best way to morcellate after 48 hours, the morcellation takes even 1/4 of the time, because all it becomes very shrunk. So it becomes very easy. At times more than 150, 200 grams. We stage, we do enucleation, leave the 2 big glands inside. After 48 hours, you go in, your morcellation happens within no time.
So Rohit, the lesson you have learned that you not only take the technician with you, you take your morcellator with you also.
Sir, bigger prostate, they should always be counseled about staged morcellation. I agree with Rohit, sir. So first we suck the adenoma, we bring it to the center of bladder. The technician should always make sure that the bladder is full at all times.
Anyway, Tanush, well done. You want to say something, otherwise we will go to the other theater.
No, please, you can go to the other theater. Thank you so much.
So, audio visual team, can we go to the VVF theater, what they are doing? Could they find the fistula or not?
Bladder देखते रहना चाहिए.
I'll tell you what, इसमें आप डालो so we can show them at the end. So let's cut this short one.
Full eye.
Long one. Let's put that here.
आगे और थोड़ा left side.
Nikhil,
Adenoma होता है ना, पता नहीं.
I don't know, are we connected to OT2?
Give me one more suture system. Give me this.
Nikhil?
Yes, sir.
Can you hear us? Okay, so ultimately you could find the hole there, isn't it?
I am able to find the hole and the urine I can see is dripping from this, but I'm not able to cannulate it. It's a tortuous track. Not yet able to cannulate it. I'll have to have some more patience, maybe give me some more time. Let us see. जा रहा है क्या गाइड में? नहीं.
You are just seeing some pre-operative video which shows the area where there's a blood clot. I think that is the area of fistula. So if my suggestions will be that if you are really having problem with that blood clot, you can dislodge it, some saline through the ureteric catheter and then try to find it.
सर ये देखो नहीं डाई अभी डाला नहीं ना. यूरेट्रोस्कोप डालता हूँ.
So, occasionally we encounter patients who have developed a large VVF, mostly after obstructed labor. So, and they come after many years, and the bladder becomes very small. And because of the large fistula, it is sometimes difficult to distend the bladder and estimate the bladder size. So, because in that scenario, you need to augment the bladder as well. So can anyone share his or her experience with, has someone encountered such a patient where you have to do augmentation in a patient with a VVF?
ऐसे रखोगे तो वो जगह स्प्रेड आउट होगा. होल सामने दिखाई दे रहा है बस उसमें से यूरिन भी आता दिखता है.
Yes, sir. I'm Dr. Arshad, sir. As you pointed out that clinical scenario, it is a scenario which is seen. We have heard few cases obstetric fistulas and post radiotherapy fistulas where the bladder capacity was very small. And that dilemma is there whether to augment or not to augment. But if there are fistulas where only the trigonal part is seen and some part of lateral wall is seen, therein, and it is impossible to close the bladder. We feel that if we close the bladder, we'll not be able to put even one catheter, what to talk of two catheters. So in that scenario, we have done cases where we have augmented the bladder. And some of the cases have done well, one or two cases to be precise, where they developed small fistulas even after the augmentation. Recently, we had one case where there was two fistulas which were there, one in the trigonal part, small fistula, pinhole fistulas, and we are again planning to repair it transvaginally now.
So this thing we have to keep in mind, because if you haven't thought of this before, because the bowel is not prepared then. Because if you haven't seen the bladder capacity, not estimated the bladder capacity, then of course you are not prepared mentally to augment the bladder as well. So in such a sense, so it's always good to estimate the bladder capacity at the time of doing cystoscopy when you are trying to locate the site and the size and all those characteristics of the fistula. Always estimate the bladder capacity as well. Because once you open up and you aren't prepared and you find the bladder to be small, then there's no way. It's very difficult to augment at that time. You have to close the fistula, put a finger from below, try estimating the bladder capacity. Because once it has happened with me, because the resident had done the cystoscopy before, I only knew that there's a VPF. We opened up the bladder and then we realized that the bladder is very small. So, but then you can't augment just like that, because you haven't taken consent and so many things are required. You need to plan it before. So we did the VVF repair only. Augmentation was, I've forgotten what we did after that, but at that time, you just close the bladder, you can't augment.
You are talking about the radiation fistula. I think that is the worst thing to repair, because not in radiation fistula, if it is a trigonal fistula, urethral sphincter is also involved by the radiation. Not only that, the ureter is also involved by the radiation. So many a time we have done just diversion rather than because even if you repair the fistula, patient may have a stress urinary incontinence. It's very difficult to put anything. In that case,
I beg your pardon, sir. Dr. Arvind Panda is waiting for us.
Okay.
He's just finishing.
I just want
Arvind,
to
sir?
show you the final outcome. Can we?
Yes, sir.
So this is the final outcome. This was a little inflamed. So I'll just put a speculum. Can you see this? No,
Yeah, we
this
can
is
see.
on the open view. Can you see this, sir? This one? Can you see my? Yeah. So
Yeah.
this is the speculum, sir. This is a wide speculum. You can see that quite wide. So this speculum I'm going to put inside this, and this is the water coming out. So
Yes, we can see it. Arvind, are you going to do cystoscopy also? Or you
yeah, I
just?
will just like to show you the graft. Can you see the graft here?
Yeah.
So this is the graft inside. And I want to do a scopy also and show you at the same time. So this is the scope. This is the bladder neck. And as we come to the end of this,
Can you give us the end of view, please?
yeah, this is the end of view, sir. This is the okay.
End of view, please. Do you routinely do cystourethropy after
Yeah,
this?
the cystoscopy is needed because there are no landmarks in the female urethra. Otherwise, the speculum should be enough. Actually,
Okay.
if you put the speculum inside, it should be enough to give you an idea about where you are in the urethra. If you really put light inside, you'll be able to see in the speculum also. But the problem is, in the female urethra, there are no landmarks. So now I'll give you the end of view. Can I just go inside? So this is the graft. You can see the graft. I'll go inside the bladder. This is now inside the bladder. This is the bladder neck which I preserve. I did not cut the bladder neck. And as I come here, this is where I've cut it, and this is, you can see the graft here. It starts here. I've cut it here. The graft starts here. There's a quilting sutures. This is the and this is a 30-degree scope actually. So here you are the graft, and I will come out and till here. So you can see a better point from here actually. And then we will, can you see this? Open, normal view, hold it.
Camera person, please zoom it. Surface camera.
Yes, sir. Can you see the graph here, sir?
Yeah. Arvind, well done, Arvind.
This is a little influence. Otherwise, it would have been a much more simpler procedure. This is mucosa and mucosa anastomosis. You can see this graph. Yeah. Yes, sir. This is a mucosa and mucosa. You can see the graft here inside.
Yeah, you can see
So
that.
I'll just put a catheter. This is the normal mucosa. This is the graft on top. I'll just put a catheter and put a vaginal pack. That's all. Thank you so much, sir. Thanks a lot.
Thanks a lot, sir. Very nicely demonstrated.
Another dilemma in a patient of VVFS, if the fistula is located at or very close to the bladder neck.
We'll pull it and keep it
So,
here because otherwise the pull won't be there.
some incontinence surgery at the same time, putting in a sling or something, or you just repair the fistula.
You must say 100% you are sure. सीधे से cut out. इसके साथ दे दो मुझे. उसी सिरिंज में दे दो.
इनवर्स में छोड़ भी सकते हैं इनवर्स में ब्लैडर तो उसको छोड़ सकते हैं ब्लड इज रेस्टिंग ओवर द मार्च चलो भरते रहो लग रहा है ना हार्ट टिश्यू दैट्स व्हाई इट इज नॉट कटिंग इट
नीडल 18 वाला ले लो
ब्रदर 18 गज नीडल
Tanu sir, we are with you, sir.
Yeah, so I am doing the modulation, as you can see, sir. And these are some remaining hard nodules in the end. So I'm doing inverse modulation for them because they were not coming in easily with the routine straight modulation. The advantage of inverse modulation being so that even if it leaves the modulator, it bounces back to it and the modulation becomes easier. But leave it for the last. And if still I have some issue, what I can do is I can bring this into the fossa and modulate there.
Anybody from the audience, if they want to ask anything to the operating faculty or chairpersons, they can please ask.
One more thing, sir, when we are modulating, most of our field of vision is occupied by the adenomas. So if any doubt, we can just rotate and see if the whole thing is rotating means they are not holding the bladder wall.
So, sir, good afternoon, sir. Myself, Dr. Amrit. Sir, if there is a ureterovaginal fistula, sir, which we which we diagnose like post-operative day 5 or 6 of hysterectomy, then should we wait, sir, for the surgery, definitive surgery? And how many days should we wait, sir?
If it is a isolated ureterovaginal fistula, you can go in immediately because you are away from the previous surgical site. Actually, you are not dealing with the vagina. So typically, you need to do ureteral reimplantation. And typically it is done on the anterior bladder wall. So you can go in immediately. There's no point waiting.
है ना वहीं से आ रहा है लेफ्ट साइड वहीं से आ रहा है इधर से भी आ रहा है क्या
Cannulate it with a stent. It recovers, sir. So can we do that also, sir? Like if we put a stent, we can pass a stent. Then the patient recovers. It doesn't require surgery, sir. Can we wait like that?
Yes. So many people, if they can negotiate a guide wire and place a DJ stent, then often these patients recover. But you have to be careful because such patients may later develop a ureteric stricture later on. You need to be careful. So take out the stent. These patients need a little longer follow-up.
Only thing you should not get confused with ureteral injury versus ureteral fistula, ureterovaginal fistula. For a fistula to occur, it takes some time. Immediately in the post-op period, it's an ureteric injury, isn't it? So
Yes.
urine is being leaked from the ureter, getting collected in the pelvis.
है वही
So in an ureteric injury,
तो
definitely
जाके उसी में फंस रहा है सर.
is telling okay, you should try to pass an stent and then follow it up. Some patients may not require any sort of stuff. And when you are talking about the ureteric injury, definitely whether what type of injury was there, whether it was due to the ligature or whether it was due to the, is there any loss of length of the ureter or not, or the thermal injury? So it should take little bit of time so that inflammation sets down and then you go for a repair. So fistula and injury should be discriminated. Injury can be treated immediately with this thing. Fistula needs definitely implantation. And what is telling, what the doctor is telling is absolutely right, because you are implanting in a healthy ureter to the healthy bladder. Whatever in between is there, we don't bother.
In this, if there is a small VVF, sir, if there is a small VVF, it has been demonstrated like it's a 5 mm, 0.5 mm VVF, then can we put a catheter and wait and let it resolve on its own?
It all depends up at what time span you are detecting it. So immediate, maybe people have waited for 1 month to 3 months, small fistula, it might close automatically. It is not a fistula, then it is still injury. Unless it is epithelialized, we don't call it a fistula, isn't it?
Okay.
So small bladder injury, which might cause, even for a small, we have told that you can just fulgurate it and then it can form. So how small is the small? Is what is that? What is the diameter of a guide wire? So something like that. So everything. Suppose you have done a fistula repair and patient is still leaking little bit. What do? You don't go for a repair. You keep the catheter for a longer time. Same principle applies for a small fistula. So it may heal, and that time you should add bladder sedative like anticholinergics.
Okay, sir. Thank you, sir.
People have used glue for small fistulas also. People have used blood clots also, injecting blood clots after freshening the edges. So if it is an acute injury, small injury, you can place a catheter, but then you need to be sure that the patient is not leaking with the catheter in situ. Otherwise, you keep the catheter as well and the patient eventually develops a fistula. So if the patient stops leaking after placement of catheter, then probably she might heal.
Patient is fine, no? इन्वर्स मॉड्यूलेशन नहीं लास्ट में जो नहीं कट रहा था उसके लिए करता हूँ मॉड्यूलेटर बहुत जबरदस्त है.
I would like to thank all the chairpersons for such an excellent and engaging discussion.
So then you don't tell it a BBB, it is a bladder injury. So you are repairing a bladder injury. Bladder injury can be repaired. Okay, bladder injury, bladder and vaginal injury. So it has not been epithelialized. So that can be repaired. So just like a radical positive after biopsy, if you want to do it after within 7 weeks,
हार्ड वाले बच जाते
4
हैं.
to 6 weeks.
हाँ, उसके लिए वो होता है.
Thank you all the chairpersons for such an excellent and amazing, energetic discussion. I would like to invite the next set of chairpersons for the next
Thank you, Dr.
session.
Sambit.
Welcome, sir. Thank you, sir. I would like to invite Dr. Sanjay Sinha, sir, Senior Consultant Urologist, Apollo Hospital, Hyderabad. Dr. Anita Patel, ma'am, Senior Consultant Urologist, Global Hospital, Mumbai. Dr. Manas Pradhan, sir, Senior Consultant Urologist, Amri Hospital, Bhubaneswar. Dr. Sagarika Paul, Consultant Urologist, Sarvodaya Hospital, Faridabad. Dr. GP Singh, sir, HOD Urology Department of Berhampur. Dr. Devanshu Sarkar,
Okay.
IPGMR SSKM Hospital, Dr. Devang Sarkar is here.
एक बैकअप देना लगा लो दोनों को होल्ड करो बैकअप से पूरा अच्छे से वाइट होल्ड
Nikhil sir, can you hear us, sir?
Yes, I can hear.
Hi, Nikhil,
Sir.
can you hear us? Sanjay here.
Hello, sir.
Hi, good to see you. So can you tell us what you have found and what are you
To see
planning?
me at a wrong time.
Okay.
So what is established till now is that we have a VVF.
Okay.
And we have this blue coming out from the vaginal vault
Okay.
from the left side of the vault from here, but haven't been able to cannulate yet because the track appears to be a bit tortuous.
Okay. It's a single fistula at the bladder end.
Guide where?
So you're trying to put it retrograde on the vaginoscopy.
Yes, sir. I think ऊपर वाला है कहाँ है? ये है या ये है?
From the bladder side, you have a single opening?
I have seen, sir. Were you watching at that time?
Not really.
I have seen it is there is a scar approximately 1.5 centimeters above the left orifice. Now that I have injected blue, I'll give a shot from here and see if I can. Otherwise, I'll have to drain all the blue.
It's usually easier from the bladder side rather than the vaginal side. But you said that it's tortuous and it's not going, right?
Yeah, it was not going, sir. But I have seen on a ऊपर है क्या?
Hi, Nikhil. It's Anita here.
Hello, ma'am. यहाँ से डालो.
So have you, what size is your sheath, Nikhil? Maybe a slender scope, maybe a ureteroscope?
No. I tried with ureteroscope, ma'am.
Oh, okay.
Guide where? No. Don't push too much. Just पे project कर दो. Project कर दो. बस project कर दो. अभी मुझे करने दो. आप आगे मत बढ़ाना. पानी पुश करो जरा. खत्म हो गया लग रहा है. खत्म हो गया. नहीं है ऊपर से ऐसे एंगल से ऊपर से। चलो फिर से स्कोप करता हूँ, इसको निकालो।
सिरिंज दो, सिरिंज।
थैंक यू। एक बार देना। इसको हल्का सा बिठवा दो।
So, Nikhil, maybe if now you did a scopy and you will wash out everything except that the track would retain the color perhaps. Do you think that can be tried now? Washing the methylene blue from the bladder and doing a repeat scopy?
Yeah, that's what I am doing, ma'am.
Right.
Let us see what we get. That she was voiding intermittently, spontaneously, and bladder is such a good capacity that was all indicative of that having a small BVF. निकाल दो इसको निकाल दो पूरे अभी डाल दो।
That's the bladder.
लो यू केप लेके आओ।
Yeah, below that yellow thing, it looks a little promising. Yeah. And as you
Can you
rightly
see
said, there is that scar there.
this scar?
Yeah.
And I think it's right there underneath this.
Yes.
But it has a tortuous oblique track going backwards from here.
Hmm.
This is the left orifice. This one. Appreciable?
Yes.
डालो जरा गाइड वायर बढ़ाओ। बस 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 इतना ही रखो, थोड़ा प्रोजेक्टेड रखो, बस 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 लेट मी ट्राई एंड ऐड ऑन। बढ़ाओ जाता है कि नहीं? Don't know what switch up they have used. Maybe that's 6 महीने बाद। हाँ?
I think that little hole above the yellow nodule is where you're trying to put the.
This one?
Yeah.
No.
Does this fistula appear mature to you, Nikhil? It almost looks as if the bladder is all inflamed and unhealthy.
History is of 6 months, but that's what I was wondering. What kind of suture is this, which is visible at 6 months?
There's a stitch there. Yeah, it looks almost unhealthy, inflamed, unhealthy. Doesn't look mature.
When was the cystoscopy done?
3 weeks.
Enough time has passed, that is for sure.
Continuously.
What to do?
Do you think it is reasonable to wait a little time and then go back for this? I mean, this is not looking, to me, it appears as if the margins of, even if you find that fistula there, the bladder around that doesn't look healthy.
No, actually,
We have the previous cystoscopy, how it looked?
this a little bit is because of our attempts to poke
Manipulations.
the guide
Okay.
wire.
Okay, okay. Right.
The cystoscopy that was
Yeah, could we see a
done
recording of the previous scopy? Do we have that?
previously. Can
Yeah.
you play that? Can somebody play that? No, can you play it on the screen
Maybe
for
for
everybody?
today, it may be just time to call it today and review the situation. Maybe 3 weeks later, we are not in a race to somehow do it today, are we?
No, if I'm not able to cannulate, then I won't be able to proceed. That is there. तो देखते रह जाएंगे, इस पे नहीं होगा, नीचे से करना पड़ेगा एक बार फिर से निकल।
Dr. Nikhil.
Yeah.
Dr. Nikhil, this is Dr. Prashant. So actually, we had tried cannulation pre-op and we got it through intravaginally only. So niche
Through
se.
intra.
Yeah.
Okay.
Yeah.
I will again, because I don't think I'll be able to do it.
Yes.
And the other issue is it's a supratrigonal also, isn't it?
Yes.
Little above the ureteric orifice. That makes it even more tricky if you've not been able to cannulate it from below.
I have to cannulate, then only I'll be able to pull it towards introitus.
Yeah. So Nikhil, at least whatever fistula that we have done, we've always actually cannulated, had something in the fistula. So if you're not able to get something into the fistula, what would you do?
Speculum or anterior vaginal wall.
ये ब्रदर ले लीजिए
For a vagina?
ब्रदर ये ले लीजिए
She don't. Huh.
No, अब मुझे गाइड वायर चाहिए और
For the vaginal repair, this is a key step.
एक
Having
feeding
a
tube दो अच्छा
catheter in the fistula, balloon tugged, so that you can then do a dissection around it. You have a clear idea about what's the
I have
location, tract
put
size,
scope
everything
twice,
in
but
direction.
scope is not helping. No.
An abdominal repair might not require that. So repair from above might not be essential, but from below, I think it's an absolute key step. So if you just can't get anything in from below, doing a vaginal repair safely, I
I'm
think
able to see it. I'm not cannulated. I have the scope goes like this and opening is somewhere above that.
यूआरएस में ही होगा ना यूआरएस में हो जाएगा
नहीं हो रहा है, मुझसे नहीं हो रहा एटलीस्ट
किंतु यूआरएस कर रहे हैं हां यूआरएस
So Sambit, is something else happening in one of the other OTs meanwhile while they're trying?
Sir, in both the OTs, the patients are now being
Getting
extubated
prepared.
and wheeled out.
Okay.
लगता तो है अरविंद कुछ गया नहीं गया एक पिट है वहां पर प्रोबेबली लीक होने से पहले एक जगह बनाया हुआ यूआरएस डाल चुका है डाल चुका मैं हाँ हाँ नहीं यूआरएस से नहीं गया फ्लेक्सिबल से नहीं जाएगा फ्लेक्सिबल से नहीं जाएगा ऐसे ही जाएगा यहीं से आ जाओ अरविंद जरा नहीं फिर से गाइड गिव मी ओनली द गाइडलाइन
Sir, can I ask a question, sir?
Yeah,
Satyasena,
of course.
sir,
Yeah,
to
yeah.
all
गिव
the
मी
three persons,
ओनली
sir.
द गाइडलाइन
Modern era of advanced imaging, CT urography, and every armamentarium, cystoscopy. Is there any role of 3-swab test in this present scenario?
Any role of?
3-swab test.
So I don't ordinarily do it, to be honest. I don't. So I rely on imaging. A combination of doing a cystoscopy and contrast enhanced CT scan is what I would ordinarily do to make a diagnosis. I don't really.
दूसरी वो देना फॉरसेप
So to give you a perspective, this test was devised when we didn't have access to all the fancy things that you said. And this 3-swab test can be done in your clinic, in your office. Okay. And you don't need any gadgetry for that. So it would be nice if at your initial visit, you are able to just pinpoint the possible etiology. That doesn't mean you're not going to do a CT. You're not going to rely solely on that, whereas previously they relied solely on that because the imaging didn't exactly differentiate between vesical and ureteric origin of the fistula. 3-swab was primarily for that, isn't it? So if you want to do it clinically, that's fine. A good office examination with a speculum, and you can just check where the leak is from. But as Sanjay said, you would still go ahead with the CT anyway before you plan. Yeah.
Anyone from the audience, if they have any doubt in the meanwhile, we were preparing for another 2 OTs. If they have any doubt, they can ask the chairpersons.
सपोर्टेड डॉक्यूमेंट मुझे दिखना बंद हो गया No.
So maybe we could take a little break for 10 minutes and come back while the patients are ready in the other theaters. What do you think?
No, no issue.
Whatever that. You know.
Any suggestions that, ma'am?
Yeah. Yes, Nikhil, we are listening.
No, I am just asking, is there any suggestion that you can give me?
No, in fact, we did brainstorm a little bit, and we all would have done exactly what you have already tried doing, including putting an infant feeding tube just guided by your finger. And we've realized that nothing is going. Maybe it's time to just call it a day and do it on a different day. Sometimes things are totally different, maybe 10 days later. It's perfectly okay.
Yes, they were totally different 10 days earlier at least.
Yeah, we've seen the cystoscopy that was done earlier, and that does not seem to show so much of inflammation, etc. in that areas. It's possible the manipulations have caused that to happen or whatever, or it's a consequence of the previous cannulation that was done. But essentially, I would have done all the things you are doing. That means I can see that you're trying to put a direct wire, trying to put a direct finger guided feeding tube. You've tried a cystoscopy, a ureteroscope, everything from above, below. That's about it. But the key thing is that we do need to get something across if we have to do a vaginal repair. If nothing goes, then you can't do a vaginal repair safely.
पता नहीं लग रहा है कुछ नहीं बाहर आ रहा है coming back not going. So I think this limitations will not be there for an abdominal or
Yes. So I don't this yes,
We'll
this
go
would
for-
not repair for this would not be a limitation for an abdominal repair. You could still go
Yes.
repair it from. Is it possible that having a speculum from above might help you?
Is it possible that
A speculum from above, upside down from above.
Uh-huh.
Right now you've got the posterior wall on the speculum, putting the anterior wall and one on the posterior wall. Both.
और देना पीछे की
Okay.
तरफ
Put one and then have the patient head down.
head down करें
Head down as far as possible. So have the backs with the posterior speculum fully in, right up to the vault, and have the anterior speculum up to the area of the fistula, and have a head down deep Trendelenburg as much as possible, and then try and see. You might get a better access there.
है वो सामने यस नहीं ये वाला ये वाला है ये
right angle
okay sir you can take a 10-minute break. Let us try give ourselves 10 more minutes.
Yeah, that's fine. That's absolutely fine, and it would be okay in case we're not able to do this. Either this is done abdominally, or I think seeing that it was cannulated a few days back, it's reasonable to go back after a couple of weeks, and it's possible that one might be able to do it from below. Either way is fine.
All cases should be tried. Not happening.
एक मिनट नीचे से बाहर सपोर्टेड रखना अभी खींचना नहीं
आप इसको पकड़ो मैं पकड़ता हूँ
पता नहीं ऐसा 2 बार लग चुका है कि गया मगर गया इसको खींचो ये इसको खींचो
सर ये गाइडर पड़ेगा they have taken a break no
ये
Nothing else is going on.
no 5 minutes to go for it we'll come back
no.
What's the patient's morphology here? Is she obese, or her BMI is normal, or how is it? Any idea?
Normal BMI.
Normal. Okay. So many things can make a difference at this point. So how capacious is the introitus, the vagina, previous deliveries that she's had, body morphology. All these things can make a small differences in each of these can make it difficult or easy to access. So, but seeing that you were able to cannulate it apparently easily last time, it's possible that the previous cannulation has produced some sort of inflammation in the tract. And that's what's making it difficult now, because whatever you showed us, that seems reasonably clean at that time. So perhaps had Nikhil the fortune of doing this cystoscopy as a fresh cystoscopy, he would have been able to do it. But the fact that we've done a trial run for a patient who's got to be operated in a workshop, that has actually produced a problem, is my feeling. Okay, we'll take a quick coffee break and come back. That's a sign that we should take our coffee break.
We'll be having a short break till both the OTs are ready. And tea is coming within few minutes outside. Just please bear with us. After this short break, we're going to have two parallel OTs, both demonstrating SUIs. One will be with the autologous sling and other with TOT or TVT sling, according to preference of the surgeon. So please wait, don't disperse. After the tea break, please come back to the hall.
हेलो इको आ रहा है हेलो
Yeah, hello, we can hear you. Yeah, hello.
हेलो सर
Yeah, hello.
Sir, we are from OT3.
Yeah.
We have next for SUI for TOT repair.
Heeraj, yeah, okay. I think, are you ready with the case?
Yes, sir. Patient has been shifted and being induced.
Okay, we'll just wait for a minute. We are taking a tea break here.
Okay, sir. Okay.
So we'll come back to you maybe in 5 minutes.
Okay, sir.
Right. He's ready. So that he is ready. So I request the audience to. Yeah, it's in that red area that he is available in the exhibition area.
Okay. सर फाइनल लग रहा है हाँ यहाँ पे ललिता में
So do we have the details of the other cases which are going to be done, Sambit? Do we have them?
Sir, we have one case ready. Spinal is being.
Hello? Am I audible, sir?
You're audible.
Yep.
In that OT, we have Dr. Lalita madam with us. She
Okay.
will be doing TOT repair for ACY.
Okay.
The presentation,
Shall-
please.
Yes.
Can I present now, sir?
Yeah, please go ahead.
Yes, sir. We have next case for a
It is not visible.
TOT repair.
Dheeraj,
Yes, sir.
screen is not visible.
Yeah, we can see it now. Yeah, go ahead.
This is a 43-year-old lady presented with mixed urinary incontinence for last 6 months, predominantly a stress incontinence with occasional urgency. Normal voiding present. There is no relief on conservative therapy. There is history of laparotomy for benign ovarian cyst on December 22. Total abdominal hysterectomy 11 years back and tubal ligation 16 years back. Gynecological history P4L3 and all through the normal vaginal delivery. And he sees a known case of diabetes mellitus and the hypertension. On examination, external urethral meatus is normal. Cuff stress test present. There is lower midline scar for abdominally. Bladder diary, coming to the bladder diary, the intake and output is around 3000 ml. The maximum voided volume is 250 ml. Daytime frequency is 8 to 11 times. Nighttime frequency is 2 to 3 times. And the number of pads she used is 5 to 6 pads per day. And there is multiple episodes of ACY, which is unquantified. And there is no urge in urinary incontinence. Creatinine is 0.79. Ultrasound is within normal limit. Culture shows no growth. And on uroflowmetry, maximum flow is 18 ml per second. And UDS shows no IDC. So we are proceeding with the TOT repair, which will be done by the Lalita ma'am.
Okay. A little bit more detail. So she doesn't have any prolapse, I'm assuming, right?
No, sir.
Okay. Okay. And the urodynamics, what else what did it show? You said there were no detrusor contractions.
Yes, sir. There is no detrusor overactivity in the filling phase, sir.
And you could demonstrate, there was demonstrable.
He is only having stress incontinence.
Okay.
There
And
is
what?
no, yes, sir.
Do we have an assessment of a leak point?
Yes, sir. We have. There is leak at 190 ml, sir.
Okay, so the testing was done at 190 ml of bladder fill. So did they test in the standing sitting position? How was it tested? And did she?
Sir, during the sitting position, sir.
In the sitting position, right?
Yes.
And she leaked, I can see, I think with the catheters in place.
Yes, sir.
A lot of women will not leak when until the catheter is, the urethral catheter is removed, but she seems to have leaked with the catheter in place, as I can see here. So do we have a measure of her leak point pressure? Are those flower things markers of leakage? That those
Yes, sir. Yes, sir. This is the leak point, sir.
the markers of leakage, huh? Okay. Okay. So I think the lowest pressure at, I'm not able to exactly see it, but the lowest pressure at which she has leaked might be around 60 or 70, depending on how the scaling of that is. If
Yeah,
it's
P
whatever.
detressor is a -1 and the
No,
P
it's not.
vesicle is 19, sir, and P abdomen 20
At the time, at the point of leakage?
at the point of leakage, sir.
No, so you'll have to, if you're looking at the machine captured information, sometimes there's a lag between the leakage recorded by the flow meter and the actual rise in pressure in the abdomen. So you'll probably need to take a look at the actual trace to see what was the spike, the peak pressure in the spike of the cough. And that would be regarded as the leak point pressure. You understood what I'm saying? So if you make
Yes,
a
sir,
woman
yes.
cough, so the leakage happens because of the cough spike, but the leak might be captured by the flow meter a fraction of a second later. And because the cough spike subsides by then, if you take a look at the machine reading, then you might get a false impression of what the leak point pressure is. So if you're doing a cough leak point pressure, the leak point pressure should be regarded as the peak pressure of the cough which induced the leak. Right. So I think if you're scaling, I can't see the scaling from here. If the scaling is to 100 max on that abdominal pressure channel, then I think then the lowest pressure which she has leaked is about 50 or 60, so which suggests that she has a component of ISD.
And also on clinical exam, did you actually look for hypermobility? Because all the details you've mentioned, I didn't see any description of whether the urethra is moving excessively. Was that noted? Or maybe we can see that clinically right now on table.
Bond state, sir, is negative.
Okay, no, so what Dr. Anita was asking was, did she have hypermobility or not? So, you know, in a woman with stress incontinence, the lack of hypermobility is more important than the presence of ISD. If a woman has no hypermobility, that is a marker for a poor outcome, a substantially poorer outcome. ISD is also a marker, but lack of hypermobility is a completely different ball game. But I'm assuming she hopefully will be having some hypermobility because there's no other reason why she wouldn't. But she does have ISD, as I can see here on this.
I think you did have initially a video showing her coughing, but that got abruptly stopped. I think the urethra was moving, but before we could appreciate that, I think we switched over to the rest of the case description. Can we replay that video? Or maybe if she's already in the lithotomy position, we could just simply make her cough and yeah, that's
Do we
the
have
video.
it? Yeah, in case you can make it run. Yeah, you can take a look. Yeah, so you can
So
see,
there is
you can see hypermobility. So a visual assessment of urethral mobility is enough. And you can see here that when she coughs, you can see a hypermobility associated with the leak.
Hello, good evening, Dr. Sanjay, Dr. Anita.
Hi,
Lalita here.
good evening, Lalita.
There is very good urethral hypermobility.
Right. So what's your plan for her?
So transobturator inside out.
Right. So this is a kit that you are using. What are you going to use?
Yeah, kit only.
A kit.
Inside out TVTO by J&J.
By J&J. Okay. So this is the one which comes with a guide. You have that winged guide, the butterfly.
Yes, winged guide.
Okay.
Winged guide.
Right, good.
They just given spinal, trying to put her in position. It'll take another
Right.
5
So
minutes for me to
anything-
start.
Sure. So anything specific about the position for her?
Yeah, instead of the regular lithotomy, I would keep her hips hyperflexed.
Okay. So it's somewhat exaggerated.
About exaggerated. About 110 degrees hyperflexed. Yeah.
So do you like to make markings on the patient before you do it, or do you do it on table by palpation and just go ahead? I mean, do you like to
Yes,
mark out
just palpate and go ahead, but I can just show where the exit points would be with, yeah. I usually don't mark.
Right. So as compared to a patient in whom we are going outside in, where you just palpate and put your trocar in, you just make a stab incision. When you're going inside out, you have to aim for a point outside.
Yes. I will demonstrate when, which is the point, the ideal exit point should be.
Correct. So for the inside out, at least I actually like to mark. For the outside in, I don't mark, but for the inside out, ordinarily I would.
I mark actually not with a marker, but I give a small nick at the proposed exit point.
Right.
And Lalita, what's your antibiotic policy like?
So actually she is a diabetic. So I would like to cover her for everything, gram positive, negative and anaerobes.
Right.
Since we're going through the vagina. So I give a cephalosporin, aminoglycoside and metrogen.
Right. And what's the protocol? I presume that is on table immediately when you induce, isn't it?
Yes. Yeah.
And post-op, how long will you continue it for? 5 days?
No, the parental just for one more dose.
Yeah, parenteral is fine and oral will be total of 5 days?
Oral 5 days. Yeah.
Right.
Catheter for a day.
Yeah.
Overnight.
And you're going to show all of this, but as a rule, would you cystoscope them?
I usually don't do cystoscopy for inside out, but it's optional. It's not mandatory like in retropubic, but it's always safer to do a cystoscopy, especially for the beginners. But for outside in, I recommend a cystoscopy to be done routinely, not for inside out.
Right. And I think you're probably wanting to look at the urethra more than the bladder, isn't it?
Yeah.
Ma'am, I have a question. And myself, Dr. Sagarika, from consultant urologist Faridabad. I have a question for you. Since the patient is diabetic, isn't it fair to do prior cystoscopy? Maybe she is having a detrusor overactivity on a urodynamic study, so it is mandated to see the bladder capacity or any other pathology.
So this is the urodynamic shows a normal
So,
storage, yeah.
so it is not
pressures-
mandatory, because in our usual protocol we used to do cystoscopy and then followed by.
So the decision to do the cystoscopy is perhaps not dictated by the urodynamic finding of detrusor overactivity, but would be number one, to check whether if you have a suspicion of some other pathology, then obviously you do. And then I would guess recommend that if you're doing a procedure in and around the bladder, neck, or urethra, it makes sense to do a cystoscopy to check whether you've caused some trouble or not. I think it's just part of good clinical practice. As urologist, it just takes a minute to check, but I think it's reasonable to check. So I would say that I would do a cystoscopy, but as a part of the operative procedure at that point.
Again, ultrasound, it is not totally informative for everything.
Right. But I wouldn't use the findings. I mean, I wouldn't look at the cystoscopy to see whether my stress incontinence surgery is adequately tensioned, for instance. So I wouldn't, for instance, look at the bladder, neck, or the proximal urethra or the mid urethra to see whether it's getting occluded. So I wouldn't do things like that. So I think that would overcorrect. But I would take a look just to make sure that I'm not missing some other pathology.
I beg your pardon, sir. We are ready with another case from OT1. We have Dr. Pawan Vasudevan and senior resident Dr. Rohit G with us. Rohit, can you hear me? OT1.
Rohit, can you hear us? OT1, can you hear us? The autologous transobturator sling.
AV team from OT1.
Can we have the audio from OT1? Can we have audio from OT1? So Dr. Pawan is going to be demonstrating to us an autologous transobturator sling. The autologous transobturator sling is a relatively recent route for placing the autologous sling, and Pawan has a way of doing it. I don't know where he's going to harvest it today, but I think typically harvests it from the thigh. So it would be good to see the harvesting of the tensor fascial aorta from the thigh. I think maybe Lalita is ready with her. Not ready yet. Okay. They're getting ready. So there are potential advantages to putting the transobturator autologous sling from the transobturator route, that you're not traversing the retropubic space at all. But it's less validated as compared to the other procedure.
Good evening. Am I audible?
Yes, you are.
Focus.
So you're showing us the transobturator autologous tape case history, right?
Yes, sir. This
Right.
this
Go
is a
ahead.
brief case history. A 32-year-old female who presented with mixed urinary incontinence for 6 months. Predominantly, it was stress incontinence and occasional urgency. Apart from that, she had a normal voiding. There was no relief on conservative therapy, which was taken for 6 months. She tried even with medications and Kegel exercises. Obstetric history is P1, L1, and she's a hypothyroid patient. So on examination, her meatus, external urethral meatus was normal, external genitalia was normal, and a cough stress test was positive. This is demonstrating that she leaks on stress. Her renal function tests were normal, and on ultrasound, her bilateral kidneys was normal, and her PVR was nil. Her urine culture showed no growth. Her uroflowmetry also had a max flow of 15. Her bladder diary, average intake was around 2,500 ml. The output was around 2,700 to 3,000. Maximum void was around 400 ml. And SUI episodes were more than 5 per day. Number of pads used were 1 to 2 pads. And occasional urge incontinence was present. Her cystoscopy was done with a 20 French cystoscope. Her meatus and urethra were normal. Bladder neck also was normal. Bilateral ureteric orifices were normal, while the capacity was around 350 cc. So the patient is planned for an transobturator autologous sling.
So I noticed that she's 32 years old and she has 1 child.
Yes.
So is she planning any more children? Has she completed her family?
See, sir, she's completed, sir.
She's completed her family. Okay, right. So Anita, any comments regarding the age of this woman prior to the stress incontinence surgery? So, I mean, how does the age impact your decision regarding what you do?
So 2 things. First is the very obvious question that you already asked, whether she's completed the family. Second is, younger the patient, I tend to be a little more vigorous with trying the non-surgical modes because their pelvic floor muscles, etc., would be innately a little better. But the third thing is, all these procedures have a life. All the anti-SUI procedures, whichever technique that you use. And if the patient is young and let's say the procedure that you're doing is going to last her for the next 10 years, that's the way I look at it. It's very likely that she's going to, when she approaches menopause, certain new changes will take place. Maybe the tissues will thin out. And it's likely, though I don't have any literature evidence to support that, it's likely that maybe either a new onset event can happen or whatever you've done, the effect might wear off. And I'm always a little very younger the patient. I think I'm very aggressive about trying everything else possible. Fortunately, he's doing an autologous and not doing a synthetic.
Yeah, that's the other thing I was about to ask you about. So at least my inclination for patients who are this young is that I would really push for an autologous procedure. So I'd be very hesitant to do a mesh procedure in somebody who's in their 30s, because we really have no idea what happens to a mesh in 50 years or 60 years. And we do know, but what we do know is that with time, the complication rates keep going up. So it keeps inching up as you follow a cohort in the long term. So I would be hesitant. So I'm glad that, as you said, that this is an autologous procedure.
So we are seeing in the OT, and maybe we could have some comments from Pawan on the patient position, because not many people are used to harvesting from the thigh. Most of us are used to harvesting from the lower part of the anterior abdominal wall using the rectus sheath.
So do we have Pawan online? Pawan, are you there? So there are two essential, I mean, there are two ways in which you can harvest this. So you can harvest it either by a conventional incision, or you can use a stripper actually to be able to harvest the tensor fascial aorta. And that gives the opportunity perhaps for giving small incisions and getting the sling material out. Ultimately, if you can retrieve from a relatively small incision, then you can make it almost a minimally invasive autologous procedure when you do it transobturator, which is not the case when you're doing it retro. Are you there, Pavan?
Can somebody connect with? Hello? Hello?
Yeah.
Sir, Nikhil.
Nikhil, हाँ बोलो. Yeah, Nikhil, we can hear you.
So, we have now given up, abandoned because in spite of all the attempts that we made from all angles and whatever instruments we had, we were not able to cannulate it.
I think it's reasonable, Nikhil. Nikhil, my feeling is that the fact that this patient had a trial run catheterization probably induced an inflammation in the tract, and that's why you've had difficulty today. Had you been the first person to cannulate, you would have been able to do it today and you would have proceeded. So I think that also tells us that if we wait for a few days, very likely you'll be able to do it from below. And since the morbidity is so much lesser in doing it from below, it makes sense, if the patient is okay with it, to just wait for a couple of weeks and then try. And I think it should be possible. That's fine. We have two other cases waiting for us. Nikhil, thank you so much for having.
Yeah, my apologies.
No, not at all.
No, Nikhil,
Not at
I
all.
think you were very brave because you tried
It's
each
the right
and
decision.
every possible thing, and you in fact demonstrated a lot of things which can be tried in such a situation in real life. So I think you did very brilliantly.
Many of our best learnings actually come from difficulties that we face. So you can hear some claps
Yes,
in the
there
audience.
are claps in the auditorium. So
right.
Thank you. Thank you so much.
OT1. Anyone from OT1? Pavan sir, can you hear us, sir?
Pavan, are you there?
You want to be connected? No?
So if you look at the autologous procedures over the last few years, some individuals have suggested doing a kind of a postage stamp
Am I audible, sir?
retrovaginal sling, where they've put a
it's not.
relatively
Yes, sir, you are
small
audible, sir.
piece postage stamp size of an autologous material and then actually hitched it up.
Am
to
I
sling,
audible,
which
sir?
have never been very comfortable.
Yeah.
Yeah, you're audible. Yeah.
Okay.
Go ahead, Pavan. So tell us what you're going to do. We can see you have the patient in the lateral position, I think, in preparation for harvesting from the thigh. Go ahead.
Sir, I can't hear you clearly, but the plan is that the patient is currently in lateral position, left side up, and thigh is flexed slightly, the knee is flexed to 90 degrees. The plan is to harvest a tensor fascial aorta strip of about 7 centimeters by 1.5, and for that we need 3 landmarks. Once this is painted and draped, then we'll discuss the landmarks.
So typically, at what depth do you expect to encounter the tensor fascial aorta?
Sir, I can't.
At what depth can we get that? At what depth?
So you just go down the skin and you have the fat, and below that is the tensor fascial aorta.
So are you planning a single long incision, multiple small incisions, or
No.
or using of a stripper?
So we would usually make a 4 centimeter S-shaped incision,
Okay.
and so that gives a good scar also, because at the end you can do that Z-plasty and close it. So a 4 centimeter S-shaped incision, which is about 11 to 12 centimeters above the level of the tubercle of the fibula.
Pavan, any particular reason why you're not using the rectus sheath here? Any reason why you are preferring to use the tensor fascial aorta here?
So results wise, both are equal, and so this is also for demonstration purpose, but usually in obese or those who've had recurrent surgeries in the abdomen, we would prefer a tensor fascial aorta.
Yeah, I thought that would be the thing. The scarred abdomen does make it difficult and it doesn't give us the kind of fascia that we want.
Yes. Plus somebody who's very obese, it's much easier to harvest this.
Yeah, and if you harvest from the rectus fascia, you might as well put it pubovaginal at that point. I guess there's no point then now harvesting from the rectus and then putting it transobturator. So
Yes.
this really enables us to do a procedure without having traversed the suprapubic region,
I'm
retropubic
glad
region at
you're
all.
doing it by this technique, Pavan, and I think each and every step, please go on speaking and we're not going to interrupt you. Start with, if you have a marking pen, I
Yes,
think it
I
will
will.
help.
A marking pen there.
And could the camera angle be a little better? There is a light glare on the thigh. Maybe the camera could come from behind Pavan so that the glare will get shifted.
Confirm all team members.
So Pavan, can you speak as you're marking?
Yeah, so what we're doing is, we're marking 3 points. This is the anterior superior iliac spine. Can you see this?
Yeah, we can.
Yes, yes, of course. Yes.
This is the fibular tubercle.
Yes, the camera needs to move down.
Can you
Can
move
you
the
show
camera
this?
down, please?
So, so this is the tubercle of the fibula. So this patient is left up, head is this side. This is the leg. The hip is flexed to about 15-20 degree. This is the leg. So this
Right,
is
right.
flexed to 90 degrees.
Yes. Right.
This is the fibular tubercle. So this point is the anterior margin of the greater trochanter.
Yes.
Right.
And this is the anterior superior iliac spine.
Okay.
Yes.
So the first line gets drawn between the anterior margin of the greater trochanter and this tubercle. The
Right.
idea is that the iliotibial tract is at this level. So you
Yes.
don't want to go you want to stay anterior to this. You don't
Yes.
want to damage the iliotibial tract, which is running along this direction.
Yes.
Then the other line is from the anterior superior iliac spine again to the tubercle. Okay, so we have this triangle now. Scale. So now we go 10 centimeters.
So, Pavan, the bottom part of the second line is still the same fibula tubercle, but what was the top end of the second line?
So top end of this
The anterior line, the anterior one.
Anterior superior iliac spine.
Yeah,
This
and
is
the
going to be
anterior one.
anterior margin of the greater trochanter.
Oh, that was greater trochanter.
Achha,
Okay.
okay,
Yeah,
got
yeah,
it,
sure.
got it. Right,
Okay.
right.
So now from here, about 11 centimeters you go up. You want to leave this much because this fascia is going to be supporting the knee. And then you make a 4 centimeter mark. Yeah, 11. So this is the 4 centimeter mark that you made. And here is where your S-shaped incision going to come.
Okay.
Is this much clear?
Yeah, absolutely.
So that's all about the marking. Now we'll go down and get the fascia. Now, S-shape, because once it opens, it gives you more space to. If it's vertical, you want a 2 centimeter wide एक मॉप, दो मॉप, दो फोर्सेप, दो मॉप, कॉटरी है ना? Yeah.
So the purpose of the S is primarily to get the width along the whole length, right?
Yeah, and it leaves a better, the scar also is a little.
Scar is better. Okay, right.
Thank you. Kotri.
Two Langen back.
Langen back.
Langen backs. Already RTP. We have already.
The target length for your strip is about 8 centimeters, you said, right?
Harvest about 7 centimeter.
7
but
centimeters.
what you need is about 6 centimeter.
Okay.
Cover.
So if we were to do the retropubic, we normally harvest a 10 centimeter long sling, isn't
Yes,
it?
ma'am.
Pawan sir, we are watching you, but Lalita ma'am is ready in the other OT and she will be joining us. So we are watching you. We'll be back to us soon. Lalita ma'am, can you hear us?
Dr. Lalita, can you hear us?
Me?
Yeah, we can hear you. Go ahead.
Yeah. See, this is the hypomobile urethra we are talking about, urethral hypomobility, very clearly seen. So we will give an incision which corresponds to the mid-urethra.
Right.
From the proximal to the meatus. The incision would be about 1.5 centimeter long. And you can feel the bladder neck balloon here. So about 1.5 centimeter proximal to the incision. And this is what I was talking about, how make a exit point. This is the adductor tendon. Just beneath the tendon,
We're not able to see.
lateral to
Can we
the
lift the camera up a little up? Can we
Camera
get the
person,
camera a
please
little
zoom
higher?
out. Please zoom out.
Zoom out or move up,
That's
either of the
that's
two.
what can you see?
Not
I
so far,
don't know
not so
what
far, not
all
so
can
far,
you
not so
see.
far. Just a few millimeters. Yeah,
Yes,
that's
yes,
fine.
ma'am.
Not so
Not-
far, not so far, please. Go back in,
Thoda all right.
go back in, go back in. Yeah,
Yes.
that should be fine. Yeah, thank you.
So this is the adductor tendon. This is how I feel it.
Right.
Just beneath the adductor tendon,
Okay,
1.5 centimeter lateral to the groin crease.
right,
So
right,
because I don't want to go 2 centimeter beyond 2 centimeter. So I make it a point at a 1.5 centimeter. I try to make a medial exit.
right.
So
So I find that when we are
called
going,
actually medial exit zone,
Right.
which is much more safer than the 2 centimeter mark.
right,
So I don't want to go beyond that.
right. So do you find that when you do the inside out, you tend to have a slightly more lateral point of exit from the groin compared to when you do an outside in? Anita?
Yes, outside in entry point is just
So
Just at the
I
crease.
agree with Sanjay.
at the
Outside in the
crease.
entry point is way inside. I mean, the exit point or whatever you want to call it. Yeah.
stay in the outside in. The entry point of the needle is in the groin crease, almost abutting the ramus. But here in about 1/3 of the woman, there is an accessory operator artery running along the lateral part of the pubic ramus. So there is one steady case. Inside out is much more safer than outside in, but there's not much data beyond that steady.
Right, right. So Lalita, we will observe as you are making your incision and doing that initial dissection, and we'll just go back to OT1 to try and understand how to identify the tensofacial letter. So can we go back to Pawan in OT1? Pawan, can you hear us?
Yes. So,
Right.
so
So-
after you make this, so this is the fascia you can see.
So can we have the camera zoom into the wound, please? Can you zoom into the wound so that we can see exactly what the operators are looking at? Yeah, yeah. Okay, go ahead. We can see
You
that
can
now.
see this fascia.
Yeah,
So now the next step is that along this line, if you
Right.
rub your hand like this,
Hmm.
and then you go here, so
Right.
this side it's tougher or harder.
Right.
So sometimes you can see it, and the other times you can feel it. So
Right.
what you feel as the harder portion is the iliotibial tract.
You don't want to go there.
So you have to stay so I can feel
Anterior
it
to that.
somewhere here.
Right.
So I must stay anterior to this portion.
Right. Right.
I must stay anterior to this line.
Right.
Right. So now we just make the markings. Ek,
So this is just under the subcutaneous fat.
so we're just marking a
So from muscle orientation point of view, you will be underneath that will be vastus lateralis, is it?
scale. So we mark this point, and this is yeah. ये दिखा पा रहे हैं? So we marked the point with the scale. आप इधर से आ जाओ, उधर से कैसे दिखाओगे? इधर से आ सकता है. Anyway, so we marked horizontally 2 centimeter, which is going to be the width. This has
Right.
been
Yes.
done with a cautery, and there's muscle below. Now we're taking a scissor and then going up to get the length.
Okay.
Scissor.
So as compared to the feel of the rectus fascia, how does this feel?
Sir, it's thinner,
Okay.
but but tensile strength wise, it's the same.
Right. But you can invariably get adequate material, right?
Yes. No.
And the location at which you are, it's unlikely that you will injure any prominent nerve, isn't it? All the
Yes.
lateral cutaneous nerves and everything is way behind here.
Yes.
Yeah.
एक और लाइन में
उसको yeah. So we have to go. बहुत नहीं. इससे आराम से 8 तक हम इजीली निकाल सकते हैं. ये हो चुका है. वो ना. So we've gone vertically, and we're now just measuring how much you.
Yep. So we can actually see the edge of the fascia that you have cut, and it seems to be a nice clean edge. I can see.
So is this 7 centimeter or 7.5 centimeter, is that enough irrespective of patient's body habitus? Or do you sometimes have to trim it down? I mean, trimming it more is impossible once you've already got a cut piece, but is it ever longer than what you need?
నాకు టేప్ తీసుకో. సరే గైడ్ పెట్టినాక చూపిద్దాంలే వాళ్ళకి మళ్ళీ.
So in all these harvestings, it's always good to leave the ends intact and first make your long incisions on either side.
టేప్ తీసుకో.
That just helps you to get it correctly, the dimensions correct.
చూపిద్దాం తీసుకో లోపల. ఓ ఇక్కడే ఉందా? వీళ్ళని చూపి. So when the auditorium is ready, let me know. I
Yeah,
will show how-
we are with you.
we are
We are with
watching.
you, Lalita.
Yeah, can I start?
Yeah, go ahead.
Yes, please.
Yeah. So I've just dissected the parietal tunnel on either side. So I will
Right.
now insert the wings guide. You will know where exactly it is, and So I'll just show. I give the scissors once, I'll show them with the scissors and then put the wing guide. See, I'll feel the ramus here and then go underneath the ramus, perforate the obturator fascia with the scissors and then insert the wing guide. I'll just show you what it is and
So in the inside out procedure, actually, we are doing we are perforating it 3 times. We are actually first doing it with the classical technique, first perforating with the scissors, then putting the wing guide, and finally actually putting the trocar in. And there's really no good data to show whether all the 3 go into the same point. But,
no,
but
no. I'll just tell you the reason behind that. See the wing guide, can you people see
We
that?
need to shift the camera. Yeah.
The
Or
wing
shift
guide,
your hands. Yeah.
can
Yeah,
you
we
see
can
that?
see. Yeah, yeah.
So the tip is blunt.
Right.
Unless we've already perforated the fascia with the scissors, it
Right.
doesn't go into the obturator foramen.
Right, right.
And the advantage of this, again, I'll tell you later as I'm proceeding. The another advantage this is, as this enters the obturator foramen, we put the needle trocar on this groove. There is a groove here which guides the needle into the obturator foramen. That's the reason it's called guide, winged guide. This has a dual purpose. It guides the needle into the obturator foramen and also shields the urethra
Right.
from the needle.
Right. So when you're putting it inside out, you can't put your finger to actually protect the urinary tracts. You need to have a wing guide. When you're putting it
See,
outside,
the
you can use your
another
finger to
advantage why I like the inside out thing is, see, the incision here, we don't do any blunt dissection. It's only sharp dissection. And the pararethral tunnel is not wide.
Right. So the amount of dissection that you do in the
The mesh
out is lesser.
and only,
compared to
you
the
know,
outside.
it's only as big as the needle.
Right.
There is no finger dissection, no blunt dissection, so it doesn't damage the periurethral fascia. That's the advantage I feel. Tape, 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 tape.
So the wing guide also has a certain degree of malleability. So you can actually bend it a little if you need to get it into an orientation, if it's
You
required.
can lengthen it. The flap has a
Yeah.
You have to hold this just without rotating. You hold in the same direction. You'll take this. Wait. It's gone in too deep inside. Put it here. Like this one. So you might have observed, I've taken it out a bit. We shouldn't shove it in too laterally into the obturator foramen. That we take care.
So the trade-off with the inside-out procedure is that you have lesser dissection at the vaginal end, but you get a more lateral exit point. And when you do your outside in, you have a slightly more dissection at the vaginal end, but you get a more medial entry point into the skin.
See, once you're in the obturator foramen, you rotate it under the pubic ramus. You rotate the needle. And once it comes out, you take out the needle in the reverse direction. Hold it at the tip. Move the needle in the reverse direction.
Yeah, you need to hold right at the tip. If you hold slightly more proximal, then you end up holding the trocar and it doesn't come out.
No, you have to withdraw it slightly, at least 2 centimeters before you hold this.
Right.
Otherwise, the trocar is still the tip.
Yeah.
More. I've actually observed when I club this with the hysterectomy, occasionally I've done in few patients where a patient there was an indication for hysterectomy and
Okay, Lalita, we'll just go, while you're doing the other side, we'll just go back to Pawan's
See,
theater. He'll just tell us what
when I
he's done.
club this with hysterectomy, I've observed there is a little bit more bleeding than when we do only this. I
Right.
don't know the reason.
Sure. We'll just go to Pawan's theater for a moment. Can we go to OT1? OT1, please. Pawan, can you hear us?
Yeah. So we
Yeah,
have,
just tell us what we just saw that
we
you
just show you
harvested
the what we extracted. But now all you
Right.
need to do is you bring this here, you bring this here,
Right.
and close it.
Right.
Lagan it?
So this is just a single layer skin closure?
Yeah, nothing is required.
Right. So you've done a fair number of these. Did you ever have any donor site issues, collections and things like that? No.
Right, sir. So
Nothing.
far,
Nothing.
I mean, literature talks about knee instability and all of that. But
Right.
what we tend to do is we increase the margin of safety here.
Right.
Whatever is happening is going to happen because while you're pulling, you tend to your retractor tends to go down and you keep harvesting below. So
Right.
what we do is we put our initial incision here on the
Right.
lower edge and then go up.
Okay.
So it's so just to make sure you don't go closer to the knee.
Right.
This just needs a simple dressing and there's no need to give any pressure bandage or anything. So that's how it looks at the end. We will just show you the graph. Graph plan. This is 20 protein निकालेंगे.
Sir, this side Dr. Sagarika from Faridabad. Sir, I have a question. Will you use some antibiotic solution to dip the graft for some time?
Pawan, can you hear? So Dr. Sagarika had a question whether you would place that harvested piece of graft in an antibiotic solution or just leave it in saline or something.
No, so we just put some saline over it.
Okay, just keep it wet.
See, this is
What length did you manage?
this here. So we have 7 centimeter.
That looks like an excellent rectangular piece, Pawan. Congratulations. Well harvested.
And now the next step is to take on each corner, we will take a 20 proline, which is 15 centimeters in length.
Right.
I mean, one strand will be left 15 centimeters in length. 20 proline.
What size of proline would you use?
20.
Single
20.
But the one proline is enough to take all the 4 edges.
Right.
And Pawan, do you sort of defatten it if at all there is any fat, or it really doesn't matter?
So sometimes some fat below this in very obese women, but usually so usually if you see there is so maybe this.
It looks actually quite thin.
Usually there's nothing.
Yeah, it looks quite thin. But you said that there is enough strength in it, right?
So sir, isme na, so the fibers
right.
are running like this.
Correct,
Yeah,
correct.
yeah,
Okay?
yeah.
Now, if you hold these 2 edges,
right?
If you hold this edge and you hold this edge and you pull them apart, this
It'll
is going
tear.
to rip through the
Split.
middle because
Right.
the tensile strength is longitudinal.
Right.
But if you hold these 2 edges and then pull them apart, then
Right.
it's very strong.
Right. So you will be giving what kind of a suture do you put at the end?
Sir, right now what we're doing is we're
Around knee.
round knee. So right now what
We need 6 centimeters, 1 centimeter we have to. We
You
don't
just
need
said some proline, isn't it?
Yeah, so we're taking 20 proline,
Okay.
1 on each edge.
Right.
Ideally, a round body needle should be used to go
And
through this.
the glistening, shiny surface is going to be facing, abutting against the urethra, right?
Yeah, so usually what I do is what was inside stays inside, what is outside comes outside.
Oh, okay. So the glistening, shiny fellow will remain outside then, probably.
So, yes, yes. So this will go inside. So now we leave this about 15 centimeters because you need that much for the trocar to bring it out.
Right.
हाँ लिथॉट में करा दो बिल्कुल करा दो
हाँ तब तक वो लिखा के
एक सेकंड
इसको देखो
so we are going to trim this to 6 centimeters.
Okay.
So am I audible?
Yeah, you are.
Yeah. So sir, इसमें if this graft is too long,
yeah,
the graft is not going to go to the other side of the obturator membrane.
Right. It can't get inside the membrane,
Right.
so it can't. You can't be too long.
With a mesh it does, but with this it doesn't. So if your length is too big, I mean if it's too long, and you keep pulling, this stay suture gets torn off, cut jayega.
Right.
And if you don't pull enough, then it becomes baggy and it doesn't sit on the urethra. So a centimeter short is all right, but
It shouldn't be too long.
will not do.
Right. Right.
So I beg your pardon, sir. Lalita ma'am is waiting for us in OT3.
Okay. Pawan, we'll just leave you for a moment and go to OT3.
And Pawan, just don't do anything more till we come back to you. Sorry.
Yeah, Lalita, we're with you.
No, just 1 minute. I won't take much of your time.
Yeah,
Just
go
wanted
ahead.
to show how we adjust the tension for the sake of the juniors here. So always leave an instrument when you are tightening the mesh. Between the mesh and urethra, there has to be some scissors or dilator, 7-number dilator, and then tighten the mesh.
And you have your catheter in the urethra, right?
And yes, there is a catheter in the urethra, but between the urethra and mesh, there has to be some gap.
Right.
See, and we won't remove the outer sheath till we adjust the final tension. Because once we remove the outer sheath, the mesh, there is a sheath which covers the mesh here. Unless we remove, if we remove this, we can't adjust the tension anymore. So it doesn't, the mesh doesn't move, it clings onto the tissues.
Go ahead.
That's all I wanted to show. You know, we have to put some instruments so that the urethra doesn't get compressed. It not only results in voiding dysfunction, it can also result in ischemia, urethral ischemia and erosion in the long run.
Right. Right.
So this is the exit point as I have shown. It's about 1.5 centimeter lateral to the groin crease. And we have lot more, margin for the obturator canal, obturator vessels, another 2 centimeters from here.
Right. Okay. Thank you, Lalita. That's a good job. We'll continue
Thank
seeing
you.
I will
Thank
go
you.
back
Well
to the next
done,
later.
Lalita.
And you can hear the claps from the audience.
Thank you. Yeah, I'm missing Pawan's show too.
Right. Thanks. We'll just go back to OT1 now. Can we go back to OT1. Pawan, we're with you.
Yes, sir. Sir, so now what we've done is on this side.
This one is small.
On this side, we have shortened it to 6 centimeter. I mean, now the graft is 6 centimeters.
So would it be okay to do this shortening after you have actually introduced it on one side in the patient?
Sir,
Or not necessary?
I mean, but over the last, it's always between that figure only. But now we.
Yeah, so there might not be too much of variation in that length, I guess.
Yes, I mean,
And
that's
also,
the length between the
I mean,
two
once
obturator
you've taken the stitches on the edges, how will you shorten it?
Side, I meant
Yeah.
Yeah, so that's what I'm saying. So initially we used to do this after measuring.
Right, right.
But now we feel that, I mean, now it's
not necessary,
never more than this. So, so we've maybe taken it 0.5 centimeters shorter.
Right.
Yeah, and more importantly, I think it doesn't matter if it is a little shorter, but it matters a lot if it's longer. Yeah.
So with abutting, the obturator membrane or clinging, I mean, crumpling there, if it's half a centimeter shorter, it won't matter.
Right.
It doesn't. So now pretty much standard that when we go through each side, we will bring, so we go through each side outside in, each time we bring one of this out. So on the right side, we'll go in twice. Once take the upper edge, once take the lower edge. And the
Okay.
plan is to go from outside to in at about a centimeter difference at the level of the obturator membrane.
Okay. So I remember, Pawan, in the beginning, you used to, I think, make a single pass and
I used
retrieve
to.
and still
I
tie
used
them
to.
over the tissue, right?
I used to. I
So you're
was
not doing it.
as comfortable with that, but so over time we've now started taking outside in twice.
Okay. So outside in twice from two different skin punctures?
No, same skin puncture,
Same
but
skin
at
puncture,
the
but
level
from
of the
two different
obturator
tracks.
membrane, a 1 centimeter difference.
Yeah. So two different tracks, essentially. It really doesn't matter whether it's a centimeter apart or 5 millimeters. Really, it wouldn't
Yeah,
matter.
so the idea is the knot that you're tying, there is a
Correct.
wedge of obturator membrane in between it.
Correct. There's tissue in between to engage that
Yes.
suture. Right.
Yes. Sir, we will get back after this is their painted races.
Right.
Sometimes minimum. Maximum if the patient is
Excellent. So the only thing that you need to see is that they're at the same level. That's the only thing you want. हाँ बस ये देख लो same level है.
OT3, Lalita ma'am, we are back to you, ma'am.
Describe the hyperextension.
हाँ कर दो.
So,
मतलब अब वो आदत तो ये कर लो.
Definite almost, but you can still see the end result. This is the exit point. We don't close it. We don't suture it. Just 2 sutures here with trio vicryl. That's all.
Ma'am, any tips for youngsters who want to venture upon this surgery, ma'am? Any safety tips, ma'am?
Yeah. Always know the anatomy well. So we need to feel the obturator ischiopubic ramus here, and then take your scissors underneath the ramus and perforate the obturator fascia with the scissors, and then pass as I've shown the winged guide. So one very important precaution is, as soon as you enter the obturator foramen, rotate the needle fast. Like, you have to, it has to be a swift movement. You should not go in too laterally beyond this point. That's one thing. And always at the end of the procedure, cornices. Can you give me the Langenbeck? End of the procedure, because we have to make sure that we haven't injured the lateral fornix. Can you people see the lateral fornix here? Is it being shown?
Yeah, we can see it. Yeah.
I'll show you this side. See, always make sure there is no
minimum staff.
through the lateral fornix. We are going either with the scissors or with the needle. There can be inadvertent injury. If there is any such thing, we have to repair the fornix at this step. Otherwise, the patient can have vaginal extrusion in the fornix at a later date.
Right.
And cystoscopy is a good idea for any midurethral sling, but in inside out, it is less likely that the urethra gets injured. In outside in, there is a possibility of injury to the urethra as well as bladder if there is a cystocele which is uncorrected.
Right.
And if we are doing a cystocele repair, we should not club this incision with the cystocele incision. We have to just stop it short of, like, at like just like this, and give another incision for the cystocele. Otherwise, there is a very high chance of the tape getting migrated in the post-op period.
Basically, यहाँ पर है ना वो pubic tubercle ये adductor हो जा रहा है. तो ये इस यहाँ पर
If you shoot questions, I will be happy.
Below at the level of clitoris यहाँ से हमने अंदर
Questions from the audience?
But if you want to feel,
I was actually saying earlier,
yeah, will you be
this
able to
patient, there was little bit more bleeding on the right side, which I usually don't have, but I've seen this in patients where this midurethral sling.
So you get the adductor longus like this, you get the pubic tubercle.
But this patient underwent hysterectomy long ago. If I'm doing it in the same sitting, in a couple of occasions, not just once. The bleeding is slightly more. I really don't know the reason.
Are not at the same level.
Could be because of the venous congestion, because we have ligated the vessels at a higher level. That's just my imagination. I don't know. There are again no studies for that. Repair with the mid-uterus sling, the results are not as good as in isolated incontinence surgery.
Thank you, ma'am.
Any more questions from the juniors? I would be happy to answer.
I think that's it now, Lalita. Thanks.
Yeah.
Thank you for a job well done.
We
There are
are
claps here in the
also
hall.
We are, hello, auditorium, am I audible?
Which auditorium are you taking us to?
Sir, we are currently in OT2.
Okay,
This is
what's
same
happening there?
case where we could not cannulate the vagina and we could not do it transvaginally. So we have put in a lap ports and
Okay.
we are doing a laparoscopic repair because patient was already under anesthesia.
Right, that's fair enough. Yeah.
So you will get one transmission from the lap VVF repair, sir. The
Okay.
other would be from Dr. Pavan Vasudeva, sir. So two OTs
Right.
would
Right.
go on.
Okay.
Thank
I would like to thank our chairpersons for this engaging and enlightening session.
Thanks.
And I would like to invite our next chairpersons, Dr. KP Mishra, sir, Senior Consultant Urologist at Utkal Institute of Medical Sciences, Bhubaneswar. Dr. Shivaji Vasu, sir, Senior Consultant is Institute, Kolkata. Dr. Subodh Das, sir, Senior Consultant Urologist at Amari Hospital. Sir. Dr. Sabyasachi Panda, sir, Associate Professor at SCU Medical College, Cuttack. Dr. Devashish Kaushal, sir, HOD Department of Urology at AIIMS Bhopal. Dr. Sarika Pandya, ma'am, Consultant Urologist at INU Hospital.
हाइट तो ठीक है, तुमने जो कपड़े दिए ना वो फट रहे। ये मेरे नीचे से कुछ आ रहा है, ये क्या है? यार मैं उसमें तो नहीं हूँ ना। हाँ, ये थोड़ा सा आगे कर दे। या
जब आपका ऑडियो वहाँ ट्रांसमिट करना होगा तो बता दीजिएगा स्टार्टिंग समझो।
हाँ, अभी है बात तो।
Manoj, sir, can you hear us, sir? OT2, can we have the audio from OT2?
Yeah. Hello.
Manoj, sir, hello.
Hello. Yeah, I'm able to hear you well.
Yeah, hello, Manoj, we are with you. So we just wanted to know how far are you there? What difficulties are you facing? And chairpersons are also there. So start interacting with you. Manoj, are you with us?
Yeah. You see now? See,
Yeah.
this bulge you need to see.
Yes.
Okay.
Yeah.
Yes.
To change the glass now.
Yes, sir. We are seeing the bulb, sir.
Yeah, just now I have put a vaginal pad. The earlier which was put, it was very soft, it was not giving any bulb inside. So I have to change it to another one. Can you show?
Can I ask a question to Sanjay? Sanjay, do you think we should congratulate him or convert it into a lab? Because hardly there should be any difference in 2 weeks' time. Or you feel strongly that it would have changed?
No, it's perfectly fine. So all I said was that if the woman is keen for a vaginal repair, then waiting a couple of weeks might just enable it, because the way it was a couple of weeks ago, I guess if you wait a little, probably it'll go back to how it was in 2-3 weeks. But having said that, she's under anesthesia. There's a promise for correcting repair, and it's devastating to keep waiting with the VVF. So it's perfectly fine to repair it from above. So I think the key is that you can't repair it effectively from below if you don't have a catheter through the fistula. It becomes difficult to do that because you can't identify the track, the direction, everything properly. So at least I wouldn't repair from below if I can't get a balloon catheter in.
Unless you have a combined approach through transvesically as well.
From above, that is not essential. So I mean, once you're repairing from above, then really that is not essential, because you don't really need to have something through the fistula from above. I mean, clearly it helps if you're doing especially a minimally invasive repair from above. Having something through the fistula does help, but it's not mandatory.
So, sir, hello.
This patient is actually roaming around for quite a long time in our hospital. So it is
Yeah, it's
very
absolutely.
difficult
No,
to
it's
refer
fair enough.
this. Yeah.
Absolutely fair enough.
She just wanted a repair.
Yes, absolutely.
Hello, Manoj. This is Dr. Devashish from Bhopal.
Hello.
Hello.
Yeah,
Am I-
Devashish, yes, please.
So there is dense adhesion. I think there is adhesions between the vagina and the uterus. Oh, vagina and the bladder.
Vaginal vault and the bladder.
Vaginal vault and the bladder. So if you have such big difficulties, what is the criteria to convert it open? O'Connell.
See, when you are able to do it, if you are progressing, if you are not taking much time, and there is not much bleeding and your field is not blood, I think you can continue lab. So if something is possible with lab, that is also possible with open.
Okay. And we used to put a guide wire usually, and it will help us. But
Yeah,
today
definitely. Once the guide wire is there or electric catheter is there through the fistula, it becomes more easy. You directly bang on the fistula site and make only two openings. Once you bang on the fistula tract only, what will happen? You will have only two openings which are very small in size. You need only 2 to 3 stitches. That's it. Whereas if you are doing mini opener in lab, we usually do mini opener. Why we need more switches as compared to the extra vesicle repair?
Yes, today's the scenario is something different, and adhesion is also so far. Do you put there is some second layer or omentum or something usually?
See, it has been seen that people, we as a surgeon, we are very used to with the peritoneum as the policeman of abdomen cavity. But it has been seen, once you go back while doing the recurrent VVF repair, you usually do not find any momentum lying there. Why it happens? Because if you are putting any stitch over there, that area becomes lysed, that fat becomes lysed. You don't need any, or you don't find any tissue there.
Sir, I want to ask you one question, sir.
It is not mandatory. It is not mandatory. What I feel, once you're putting some reinforcement by using momentum, it just gives you a sound sleep. That's it.
Sir, are you going to give transverse cystostomy or like routinely we are doing Because in INU technique, we have published.
No, INU techniques, ma'am, actually what we have seen, INU technique is a transverse incision, and there also you need to be very near to the fistula. If you are very near to the fistula and you are putting ANU technique, what happens? You will not have a T-shape incision. If you are very away from the fistula tract and putting a transverse incision, it becomes a T-shape. The bladder opens in T-shape. That gives difficulty in suturing. That is one thing. Second thing, once you are putting this transverse incision, you may go lateral where there is every chance of injuring the ureter. So that's why I used to avoid doing this ANU technique. But couple of cases we have done it here. But still, since in this case we don't have any ureteric catheter or guide wire, I'm not trying to do that. If at all I'm going to do, I'll just put a mini O'Connor incision and go into the bladder.
So when you encounter this kind of an adhesion, you have two choices: either to dissect right now between the bladder and the vaginal vault and try and get that space come as close to the fistula as possible, or to do hysterectomy at this stage in a vertical shape and visualize it from inside and then do your dissection.
Yes.
How do you decide which to choose?
Yeah, the addition is more. I'll do that, sir. Just give a try to reach as low as possible.
Right.
So if I'm not proceeding, then definitely I'm going to do that.
So I mean, if you are a little far away, as you said, from the fistula, then a vertical incision is a safe bet. A horizontal incision you can get stuck if you're far away. So a vertical incision you can just extend like a classical O'Connor incision and reach there without problem. But with the horizontal, you'd get stuck there.
I think just we have reached in this is a vaginal vault, and this is the bladder area. So we can put a nick over here and look for the fistula tract.
I beg your pardon, sir. Sir, we have Manoj, sir. We're continuously watching you, sir. But we have Vasudevan, sir, with us from OT1. He is ready. Pawan, sir, over to you, sir.
So we've just given some installation which helps a little bit in hydrodissection, and now we're making an incision over the mid urethra. Do Elise, ya do knife.
Dr. Pawan, hello, OT1.
Pawan, sir, can you hear us, sir?
Yeah, I can. So we've just gave some. So we just gave some. So we just gave some fluid for installation, so that which helps in hydrodistension, and then knife dosto.
Give knife. Knife.
फट जाएगा थोड़ा सा बड़ा फट जाएगा.
So, Pawan, do you ordinarily give your incision without holding the vaginal wall with between Ellis clamps, or?
Yes. So I just give an incision and then
hold,
you.
It's slightly different from what many of us do, I guess.
So once the incision is given, at this time I would hold one on both sides.
Right.
And then I don't know, somebody had to. I just pull them apart.
Right. And you don't infiltrate.
Sorry, I did infiltrate.
You did infiltrate. Okay.
So if you go too deep, you can go to the urethra. So I make a superficial incision only as much to hold these two with alleys, and then spread it with the alley.
Okay.
So
do you find it tearing sometimes?
Sir?
I mean, do you find it tearing sometimes if you pull it apart like that?
So yes. So you see these fibers. I mean, you go to a deeper level when you pull these apart. So it helps. So then the standard that I would just nick a little in this area.
Okay.
Not very hesitantly. And then once you find the space, then you just take your
It's
You
when
don't
take
put
your
any adrenaline
finger
saline solution?
towards the ipsilateral shoulder.
Dr.
And
Pawan? Hello? Dr. Pawan,
yes, sir,
can you hear me?
I can.
You don't put any saline with adrenaline mixed into the space for good dissection?
So we used saline. I don't use adrenaline.
You don't use adrenaline. You don't find any difference in bleeding?
Not really.
Okay. Second question is, why you
It
prefer
brings it whatever you do,
Yes.
and fortunately, by the time you are finishing, everything settles down.
Another question, sir.
So you have to make space enough that your finger can reach the bone, because when your instrument will come, you have to be able to palpate the trocar on the other side of the obturator membrane and then bring it under vision. So this is one side done. Right. And now we just do the other side.
Pawan sir,
Yeah.
as you know, the tensor facial aorta will shrink by 70% as per the
Sorry?
literature. As we have taken the tensor facial aorta, and this shrinks by 70% by the time. The shrinkage strength of the rectus sheath is less. Does it affects in our results?
No, honestly, I didn't hear your question. Just give me a second.
Sir, basically the
Just 1 minute.
shrinking capacity of different fascias are different. So the tensor facial aorta shrinks by 70%. Will this affect our results?
Yeah, why? Yeah.
Interfacial aorta ki strength compared to.
No, so tensor facial aorta strength is not less than that of rectus. The
No, sir.
thickness is lesser than rectus.
Not the strength, sir. Shrinking capacity.
Sorry?
Shrinkage.
Shrinkage.
Yes, sir.
So, so you're saying that the shrinkage of
Yes, this fascia will affect our results.
yeah. So now you can feel the bone on the other side, and now it's time to take the trocar. So I can get back to you on this. I don't think that there is evidence that anyway we take a strip which is wider than what we will take for a I mean anything more than 1 centimeter is enough. If you're taking close to 1.5 to 2, even if the width shrinks, I doubt that it should make a difference.
So this part of your dissection, Pawan, is same as for the transobturator tapes. You've gone just behind the ischiopubic ramus so that you can receive the tip of the trocar on your finger, right?
Yeah.
The
So
same.
this finger.
Yeah.
It's
the same principle as the TOT,
finger.
right?
Yes, yes. So this finger is now reaching to below the bone, so that I can guide the trocar from the other side of the obturator membrane under my finger.
Sure.
Sir, is it like outer ring transobturator tape?
No, yeah, no. Chalo. Wait a second. Yeah, we have this also. Marking the next.
He's asking it is outer in or in out?
So we're going to be doing an outside in. So for outside in, this is the tendon of the adductor longus. That's the pubic tubercle.
Cameraman, please.
Can the
shift
camera shift a bit?
We're not getting a clear view, sir.
Zoom out a bit.
Anyway,
Camera, zoom out a bit, please.
Also, the operating field needs to be in the center of our image. The operating field is at the extreme top.
yeah.
Brightness.
So basically, so the adductor longus tendon, the cubic tubercle. So I go 2 centimeters below and lateral to that. It's usually in this crease at the level of the clitoris. Tap. Knife dीजिए. यहाँ करना टैप करना. बहुत अंदर पूरा कर दो.
Do you put your finger to touch the pubic tubercle and obturator foramen, or it is just like attaining?
So now basically what you're supposed to do is, this is how it's held. I mean, it's the standard way to it. You go vertically down first, and this thumb is what gives the pressure to go down. And once that is done, then you rotate. When you're rotating, now I can feel it, and I can also, so it's on the other side of the obturator membrane, and I can feel it with my finger. So now I bring it under the guidance of my finger, right? So this is where it's come out. At this time, it's important to see that it's not coming out through this. So sometimes it comes out through this fornix and then goes back in again. So you have to make sure that that is not happening. So now we feed one. So now you feed one thread forceps. नहीं निकल नहीं कुछ नहीं बोल नहीं करना है आ जाएगी तो कहीं हाँ कुछ नहीं हो रहा ठीक. So now you just come back, and when you do, this thread would have come out. एक वो लगा लो.
Sir, in post-menopausal woman with atrophic vaginitis, will you advise for estrogen prior to going for the SUI surgery, and how long?
Yeah, so again you go down vertically, then again you now try to feel where it came, the first one came, and then again this will come under vision, I mean under your finger guidance, and now it's coming out under my finger, right? So now you feed the other. हो गया आ जाएगा हाँ आ जाएगा मैं इधर देख रहा हूँ इसमें. So you're supposed to feel this, you can feel it. You see that space? So sometimes you may come out and then go in again. You understand what I'm saying? You may come out of this, then go back into this. So if while your trocar is there, you should ideally feel that you've not gone in and come out again. Okay?
Pawan sir, can you hear us, sir?
Yes, I can.
Sir, there was a question from Dr. Sarika Pandya.
Yes.
Do you recommend intravaginal estrogen cream for a postmenopausal female? And if yes, then for how many for the duration?
So the best answer is that if on my local examination, I think the vagina is very unhealthy, I send them to the gynecologist and let her do what she has to, and then she comes back once, they've given her the creams and whatever. Pass it twice. I pass it twice. Now I pass it twice. बताता हूँ वो देना marker. इसको पीछे करना. So again, this is the adductor longus. You can feel this, right? So, no? Yeah. So that's the adductor longus.
insertion, you come 2 centimeters, about, it will be somewhere here, right? And this should be at the level of the clitoris and corresponding to the other side, right? थोड़ा सा नीचे इधर, थोड़ा सा इधर, एक मिनट वो डाल देगा। I just put my finger to set clarity.
Sir, entry point is in the crease only, groin crease only, not laterally. Pawan sir?
Anji?
The entry point is in the groin crease only, not in a lateral to the groin crease.
No, I can't hear you.
So we want to know the entry point, sir. Is it over the groin crease or just lateral to it?
It's 2 centimeters, so it's usually in the crease, but sometimes it can be a little lateral or medial. But I tend to as long as 2 centimeters below and lateral is corresponding to the level of the clitoris, then that is what I use. My finger will not. Yeah.
That's the same point that any outside in trocar always tends to come more medial, and at least I feel more comfortable personally in coming more medial, because the more lateral it is, I think the more odds of getting thigh pain, hematomas and things like that. So staying as close as possible to the ischiopubic ramus probably reduces some of those complications, and that's what happens when he's going outside in.
So again, you feel it over
you could tie one of the ends straight away, right?
So you again feed them out under your finger, and again feel that it's not come out through that angle.
Anybody experienced like rectus fascia sheath instead of tensor fascia lata?
Yeah, we're doing it all the time.
You do all the time.
Yeah.
Which cases are indicated for synthetic and which cases for autologous?
So I think that's a whole range of discussion, separate discussion. But I think patients who have this, there's some situations you would mandatorily not use mesh. So let's say you have inadvertently opened the urethra, you've done a urethral diverticulum surgery simultaneously. Those kind of situations, anyway, you would never use mesh. Ideally, you would use a synthetic, an autologous material. But other than that, poor quality tissues, a fixed urethra, these are again relatively stronger indications. So a fixed urethra, you'd put a more snug autologous sling, and then counsel the woman that she might have to self-catheterize. But with the regular index patient, I would tend to use it for the younger women, for instance, like the woman for whom the previous procedure was done, was 32 years old. So that kind of a woman, I would think about doing an autologous procedure. I mean, this woman itself, I think of doing an autologous. And these days, I would actually counsel women for autologous first, and then we also have a mesh procedure if you want to get it done.
वो आपको एक proper feel होता है। अगर आप इसको ऐसे डालोगे ना, if you put it like this,
yeah,
so the
retropubic,
trajectory becomes the bone is thick like this, so you will start hitting the bone when you're trying to turn. So unless you heard this pop, unless you use this pop, you will not be able to turn. Okay?
In autologous,
And then if you want to feel, I can
just
help,
like a mesh.
put your finger.
Suppose you look this
Just put your wait. Just put your finger in. There's no hurry. Go there.
like a mesh.
Can you feel the
No,
mesh?
I not four corners. It's
Can you
it's
feel
like a mesh. It's
Only
like a
four
mesh.
corners?
Yeah.
Can you feel this?
Fashioned like a mesh. Yeah.
You can feel? हटा दे. पार्टी देनी पड़ेगी. इसको पकड़ना है एक बार. हाँ, yes. So after
I'll tie. The autologous will be tied, of course.
So after you feel
Autologous will be tied over the.
Then I felt this is at the other side of the operative memory. Right. So now.
Yeah, so there will be sutures on the end. It will be tied over the
The tape you are taking,
So now this.
whether it is a four-corner stitch or
now what
just
you-
like a mesh.
No, not a four corner. Just tie both ends. That's it. Keep ties on both ends and tie it over the rectus.
Is you're bringing it to this side, and this is coming under my finger, right? So there's no chance of bladder bleeding.
थोड़ा सा और बाहर थोड़ा बाहर ले
एक मिनट, थोड़ा सा.
थोड़ा रोटेट कर लीजिए बाहर
So this is the second outside in through the left side.
Right.
Then you feed the let's see. Then you feed the thread again.
Right.
And then you just pull it back.
So is
So
your
now-
introducer
so now
helical?
we
It
have-
looks helical. I think it's a helical introducer, right? Yeah.
Yes, sir. So now we have 2 threads out on each side. Before
Right.
we pull, we would just hold the center of the graft.
Okay.
It forces
Times,
Yeah.
can't you make a loop of the thread and would just pass?
Ma'am,
it
I
once?
used to do it once. Yeah,
Huh.
he has been forcing me to pass twice, but so the rationale is that the tape
should be
uh,
spread out.
no, the rationale is that the knot should not slip to this side. Tell me. Yeah, yeah. Are we? Just hold this. So now we've bedded down equally.
Right.
And
Okay.
we are going to tie one side,
Okay.
taking the knot down to this side of the obturator membrane.
Right. And I can see, Pavan, that just like with the mini sling, for this procedure, you don't have anything between the sling and the urethra. You have to put it snug, right?
Yes, we will put it snug. We will not have anything in between.
You'll have nothing in between the sling and the urethra.
So for obese women or some people in whom it's bordering ISD, I even tighten this a little bit.
Right. Right. So this is actually
Because tightening this is different from tightening at the bladder neck level.
Right. So this
Sometimes
is tension just like a mini sling. So
Yes.
for those of you who've done the mini sling or the mini arc,
Yes.
this is tension exactly the same way.
Suction. दिख रहा है आपको ये? So after we do this, we would take one suture from the superior edge of the graft to the urethra.
Just to make sure it doesn't roll up.
So it doesn't get crumpled.
Right.
Sir, any stitches you are going to take on the urethra with fascia?
Yeah, that's what he just
Zero
said.
proteins.
So Pavan, did it ever happen that you did this step and you found that the graft is too long?
Sir, शुरू में हुआ था. I mean, so it's too long means when you've gone outside in,
yeah,
and you're pulling on the threads, the
Yeah.
proline that you're bringing out, that cuts through.
Yeah, or your sling doesn't tighten.
No, so if the sling doesn't tighten, you can't leave the procedure like that.
Correct.
Ultimately, what happens is you're trying to tighten and the threads will give way. Then you have to repeat repeat means repeat the
Correct. You'll have to
outside in again.
Yeah, yeah. Okay. Would it be okay to use, let's say, a delayed absorbable suture instead of using proline in this?
Sir, possibly.
We have not. Okay, so even with the rectus we do, but rectus knots, of course, are very deep compared to this.
But अभी दिखेगा सक्शन करना पानी ले लेना थोड़ा
42. Hello.
So if I can show you, can you see the graphs bedded nicely? I don't know if you.
Yeah, we can see it well. It's gone flat in.
You can see it?
Yeah, it's gone flat in. We saw it going.
ये दोनों तरफ होगा ये कौन पकड़े थोड़ा सा हेड डाउन करेंगे
इधर भी टूट दीजिए सिस्टर नहीं होल्ड पे.
This suture is vicryl, I guess, right?
Yes, sir. 40.
लोअर एज है ना, ये लोअर एज है, ऊपर एज
Can we go to the OT2?
एक साइड से नदी है ऊपर वाले ऊपर वाले इसको नीचे कर देंगे इसको
Manoj sir, we are with you, sir. Manoj sir, can you hear me, sir? We need the audio from OT2.
कर रहे हैं तो हाँ जी तो टाइट तो नहीं होनी थी वो ये जस्ट रोल नहीं हो जाए इसके लिए
छोड़ क्यों दिया यार?
इसने सिंपली ये कि
Manoj sir, we are hearing you, sir.
See,
Guide-
I'll show you. I have already dissected the fistulous tract. See, no, actually.
Very different
Yeah, can you see it?
Yes, sir.
This is the can you just section it? Yeah, so this is the vaginal ring, come out, just you should do you. And completed. I have to clear the lateral side, that side only. After that, we'll have a very clear vaginal rent, which will need only one stitch. And this bladder rent, what we have created, that will become 5 to 6 stitches. So here the trick is, when you are dissecting this vaginal rent, you can hold the vaginal wall and pull it and separate the bladder wall. Vaginal wall is very tough structure. It should not cut through unless it is a very fresh fistula, very recently done surgery. That may create this tissue injury or tissue cut. But once it is a old fistula, this will not happen. Sir. Now you can see. You can see this. Am I audible?
Yeah, we can hear
Yes,
you.
sir. Yes, sir.
See, so now bladder wall I have separated. Bladder wall is separated now.
Yes, sir.
Yeah, I will show the
Let's see the final picture about
So I have to use the bladder up so that you can see it clearly. Show the ये दिखा थोड़ा bladder दिखा Okay. So this is the bladder rent. Bladder wall is like this. We can close the bladder wall separately. Now we can. This is the bladder rent what is created, and this was separate. This is separate. Vaginal rent.
So this is how we bed it.
Manoj, can you show us the bladder rent more clearly?
Bladder rent. Okay, just I need to just say here got cut through so that my left hand is not free. So can you take a grasper? Just take a grasper, leave the bladder and show that area.
Yeah.
Vaginal rent is very nicely visible.
Yeah, actually we have taken a suture bite from bladder to hitch it up, but that suture got cut. So that's it. Okay, now you can see clearly. Yeah. Give me the grasper, I'll show that area. Grasper, please. Yeah. So this is the bladder rent.
Yes, this
Actually, when I opened the bladder, knowingly I went little bit to left side. because I was suspecting the fistula is on left side. And when Nikhil sir was cannulating it, it was appearing it in posterior fornix, that too on left side. So I just took this incision towards left side, and here bladder is already separated. Can you show me this area?
Yes, there's a margin is visible.
And this is the rent, vaginal rent.
Okay. So do you freshen the margin of the vagina?
No, not needed. See, once you're freshening, then what will happen? This suture will not hold properly. That
Okay.
usually happens. Can you
Manoj
see
sir,
the-
we will be watching you, sir. Pawan sir is waiting in OT1 for his closing remarks.
Okay, okay.
Back to you, sir.
Yeah, please, you can move.
Pawan sir, can you hear us, sir?
Yes, sir. Sir, we're just closing it now. Standard, we will give a vaginal bag, which is removed next morning. Catheter also removed next morning. And we would check the post-void residue. I mean, check in the sense that she voids adequately, we just send her. So we routinely have not been doing scopies now. I am not advocating it, but for trans-obturator, we have not been doing. Unless we feel that there was a problem. If the trocar has come right under the finger, and we know that it was under the finger from that side of the operator membrane to the then we don't.
Sir, what is your follow-up protocol for this patient, sir?
So we call them in about, I mean, if they void, then we call them in about 3 weeks. I mean, most of them, almost all will void. So they come back to us in 3 weeks.
Pawan, hello. Pawan, can you hear us?
Yes, sir.
Yeah, can I ask you one thing? I mean, would you do a cystoscopy at this stage to make sure there are no damage to the bladder or urethra?
Sir, I could hear you.
As it is out in process, would you do a cystoscopy to exclude any injury to the bladder or urethra?
So, earlier we used to, but now in trans-operator one, the risk is anyway very less.
Yes, we are back now, Pawan. You are saying something. We missed it.
Sir, if it's an uncomplicated, uneventful procedure, we would not do a cystoscope.
Sir, any follow-up imaging, follow-up ultrasonography? Is it needed, sir?
Follow-up ultrasonography? No, for what?
Sir, you said that to check for PVR or something, but I didn't get it, sir.
Do we recommend Sanjay for the surgery cough test? Any cough test to see that SU is controlled?
We don't actually, because we find that if you try and tension your incontinence procedure based on a cough test, then you actually might overcorrect. Because when the woman stands up, the weight of the pelvic contents also fall over the repair. And so it tends to become tighter than it was in the lithotomy position under anesthesia. So I don't do it, but I do know some people do, but I don't.
You don't do.
Sir, I think more than the test, it's more important to just standardize your procedure will give you results, and then tension it only till that, because somewhere it's subjective as to how much you're tensing. देना.
निकाल.
Another question, tensor fascia lata and rectus abdominis sheath, is there any difference?
So Dr. Neeraj was with me. Yeah. देना pack दे देना.
थोड़ा दूर करो. रुको, शो दे, कैमरा नहीं दिखा रहे यार. कैमरा दिखाओ. कैमरा नीचे दिखाओ प्लीज.
ना इतने से नीचे देना. अच्छा फोड़ देना.
Even once you grab and pull it, na, coming out. पकड़ो.
So we put a pack now and let's see. Thank you.
पकड़ो.
Pavan, can you hear us?
Yes, sir.
Can I ask you one thing? Suppose inadvertently the shiny side of the tensor fasciata faces inside rather than facing outside. Does it seriously impact the outcome?
No, sir. I mean, I don't think which side goes in, which side goes out really shouldn't matter, because ultimately it's the strength that is the rationale behind why the procedure is working.
Take it out, take it in. ऐसे में jerk क्यों दे रहे हो? क्या switcher दे रहे हो? It's like breaking.
Pavan.
Yes, sir.
Very nice presentation. So hear the clap from the audience.
Thank you, sir.
Very impressed.
इसको थोड़ा लूज करो.
तो इसको निकालना क्या?
हाँ ये भी बच गया वैसे.
कुछ और कुछ है? एथिलॉन दे दो. फटाफट दे. क्या ही चलोगे यार, बस ही चलाओ. टूट रहे तो और कुछ लो ना जिसमें यानी ये मिडिल होल्डर आधे शूटर दो. अरे
So we are back from female to male urology. From the morning, it was all male.
दे दो फटाफट क्लोज करना है मेल.
Last sessions were brilliant.
दो. ये दो मुझे सेक्शन करो. हेलो हेलो.
Yes, sir.
स्टार्ट करो ना प्लीज. बोलो. हेलो.
Yes, sir. We are
Hello.
here. Hello. Hello.
We will be now going to OT3, where
Hello.
R.K. Gopalakrishnan sir is ready with another HOLEP, and we'll have the case presentation now by Dr. Dheeraj.
Hello, hello.
Dr. Dheeraj, can you hear me?
Yes, sir.
Start with the case presentation, please.
Yes, sir. The next case in OT3 is BP for OLEP. The case summary is, he is a 56-year-old gentleman presented with lutes for since last 2 years, having obstructive uropathy on evaluation and on PUC since May 2023. There is no comorbidity. On DRE, there is grade 2 prostate, BCR present, normal anal tone. Serum PSA is 0.6, creatinine is 0.9, and ultrasound now shows HUN is resolved, and there is a 127 cc prostate. So we are proceeding with the HOLEP, which will be done by the R.K. Gopalakrishnan sir.
OT3, can we have the endo view, please? We are seeing slides only. Endo view, please. OT3.
हाँ ये ready है. ये mute किया हुआ है अभी, ready है. Hello. हाँ ready है.
Dr. Manoj, hello.
On table, I think it's good to inform. Nahi kya?
No, it is not life-saving procedure for you. It is not required.
Manoj sir, we are hearing you, sir.
Yeah. So now I've closed the vaginal vent. So I've used 3O Vicryl, but for bladder, I'm going to use 3O barb suture.
What will be the interposing tissue?
So interposing tissue, I will see if momentum is available, I'll put, otherwise not required.
We are taking momentum or peritoneum.
Can you give me barb suture? Good. Will.
So Manoj, you are using BART suture. 30 bar.
3O barb I'm using.
30, yeah.
Yeah. One more thing, when we are putting ports, I just wanted to mention this thing. Sometimes I've seen people use one 10 mm or 12 mm working port.
Okay.
But here I have not put any 10 mm or 12 mm port for working purpose. But what I see, can you leave that here? Can you leave? Can you leave? Can you leave that here? Just you have to leave the bladder, just not the margin.
Okay.
Yeah.
So total,
See-
how many ports are you are using now?
Yes, please.
How many ports you are using?
I am using one assistant port, two assistant port, one working port. One is for suction.
Okay.
The total 3 ports I am putting apart from camera port.
Okay. So you will repair in a single layer with a Bart suture 30.
Yeah, I'm single layer.
Yeah. And when will you remove the catheter? Or you put SPC or any other?
SPC will not put. Definitely, I'm going to put a drain. But SPC I'm not going to put, and we'll put a large bore catheter, which usually we remove after 3 weeks. But nowadays we are trying to remove after 2 weeks. Oh, sorry, 3 weeks earlier. Now we are removing around 2 weeks.
Sir, are you doing a cystogram before take out of the catheter?
No, ideal traditionally it is mentioned. Initially, few cases we are doing that, but nowadays as a protocol, we are not doing it. Unless it is a redo surgery or complex fistula like post radiation, then only we should consider. Otherwise, I don't think it is really necessary.
Yeah. Do you apply any vaginal pack or anything like?
Yeah, vaginal pack I'm keeping, but tomorrow morning we are going to remove it.
Okay.
Not keep it.
So usually how many months you wait after hysterectomy, post-hysterectomy fistula? 3 months, 6 months? As the literature
Can you please repeat your question, please?
Post-hysterectomy VVF repair.
Yeah.
The timings, 3 weeks, or some say 3 weeks, some say it's 3 months. And
We prefer to go it after 3 months so that fibrosis will be more matured. You will not have much inflammation out there. So your life becomes easy when you are repairing it.
so what is your experience with the fistula with stones?
Fistula stones, actually in my career, I've seen 2 cases. A very big stone, that around 10 centimeter stone, that I had to clear transvaginally because it was not possible to enter through urethra. So I have to go transvaginally and cleared it. And after around 1 month, I just did open. At that time, I was not doing laparoscopy. Just immediately after my MCH.
These are the worst PVF in which if there
Yeah,
is
because it's the same setting if I'm doing, it is very difficult to do because the tissue is very friable. Tissue is very friable.
Yeah.
Also, more applicable in this the failed repair cases to get a CT scan done before the repair to make sure there is no pelvic collections or pelvic inflammations. That can sometimes cause a failure.
Yeah, yes, very true, sir. Very true. Even that may harbor infective material also. So definitely, that's a good suggestion. We have already come across such cases where we found very putacious material out of that collection. Ram, can you just release the bladder and go little bit lateral? Just hitch it bit lateral. Yes, this side. Yeah, like this you can take.
Manoj, can I ask you one thing?
Yeah, sure, sure.
Do you believe that?
Hello, please keep silent.
I'm asking you, do you believe that putting two uretary catheter and bringing it out actually
Please
causes
inside OT, please.
diversion?
Sir, please repeat.
I said putting uretary catheters and putting it out, does it actually cause total diversion? Do you believe that?
No, actually, if you see the urinary drainage, it is mostly catheter or peristent. It is just only for mobilizing at that time, just it helps to avoid the ureteric openings. That is the only thing what I feel. But post-operatively keeping for more time, it only increases the discomfort to the patient.
Right.
But not any diversion.
So at the most operative catheter.
Yeah.
Take it out at the end of the procedure. Okay, that makes sense.
Manoj sir will be watching you, but we are now
Sure. Yeah.
where Dr. R.K. Gopalakrishnan sir is ready.
I just lift it up. Yeah. Like this.
One of our resident is now performing cystoscopy. OT3. Gopalakrishnan sir, can you hear us, sir? Anyone from OT3?
Okay. Good. Now.
Gopalakrishnan sir, can you hear us, sir?
Yes, can you hear me?
Yes, sir.
So this is the prostate. As you can see, you have got the history already. The estimated size is, I think, 127 grams. So he has got a trilobar prostatic enlargement, fairly large middle lobe, lateral lobes. That's the verumontanum. There is tissue protruding beyond the veru as well. So this is the cystoscopic view. There doesn't seem to be much of a middle lobe. I think it's mostly lateral lobar enlargement. Can you appreciate it? The ureteric orifices are here. Here, and here. So as I told you, he does not have a middle lobe. That is why the orifices can be seen easily. He has mainly lateral lobar enlargement, and they are protruding beyond the veru. So we are getting on with the urethral dilation, and then we will get on with the enucleation. Do you have an Otis urethral dilator? He has been on a catheter for quite a long period of time. So the prostate looks a little bit inflamed. So this is the reason that when I start using the laser enucleation, I will be using a different setting to what I normally use for enucleation. Normal setting is 2 joules and anything between 30 to 35 hertz. In this case, because the prostate is inflamed, so we want a little bit of a hemostatic setting. So we will do it at 1.8 joules, and we will use a long pulse because that is a hemostatic setting. 1.8 and start with 30. Yeah, use long pulse. Because he has had a catheter for some time, the urethra is reasonably well calibrated, but the meatus is a little bit tight. As you know, urethra, and that is the part that is liable to stricture, resectoscope. Yeah, jelly. The most important thing during HOLEP is a lot of lubrication. So I use a lot of lubrication, and every 20 minutes, I will be removing the resectoscope to push in jelly. So we're just setting up the equipment. Laser fiber. I'm using a resectoscope made by Endoscope, which is similar to a storage setting. The working element is slightly different. Can I have a 5-French ureteric catheter? And the laser fiber.
Sir, which energy?
French ureteric
you are
catheter.
using? Sir, which energy source you are using?
Pardon?
Energy source?
Energy source is holmium laser made by
Quanta, sir.
What laser?
And sir,
The
your
setting-
and Olympus resectoscopes.
Olympus, no, the resectoscope is made
For the-
by Endoscope. This is a
Stores.
stores compatible. उतना नहीं चाहिए.
So your position is the same as the TURP. Is any difference in
This
this?
position is same as the TURP. Yes. नहीं जाएगा, नहीं जाएगा, तो वही देगा, डायरेक्ट देगा.
Sir, are you going to do any OTs?
If you
or
use a
urethral
stores
dilation?
working element
Yes.
or a tooth working element, then normally we introduce the fiber through a 5-French ureteric catheter. That is to prevent the fiber from. Water on. Pedal, please. So this is a dual pedal system. As you can see, there is some oozing from the beginning itself. This is typical of these prostates and these prostates which have a catheter for a long period of time. So that's the reason why we use a slightly lower setting, which is hemostatic as well. That is about 1.6 to 1.8.
There's a question from Sagarika that would you do a Otis ureterotomy routinely here?
And notice
For the
urethral dilators and dilated up to 26 French. As I said, the patient has had a catheter for some time. So the urethra is already well calibrated.
The next question, when you saw there is a extension beyond the Veru, does it change in your planning in any way?
No, it doesn't change the plan. We will have to, once we make the mucosal incision, I'll show you how the enucleation will proceed. The tissue, the cutting will actually be at the level of the Veru. Can I have a little bladder wash just to remove these clots? Although there may be tissue protruding beyond, that will not be of any consequence. Can you clean regularly? Turn on water, please. Put airway. Put airway, please. There is no water flow. Put water on both sides and give airways on both sides. We need good irrigation. So the first step is to make a little mustache. We will make the mustache incision with a little lower energy, with a coagulative energy. So this is the groove, as you can see here. This is the verumontanum. On, please. Laser on. Laser on. It's not working. So you just blanch the mucosa first in order to reduce the bleeding. And after that, you can start. So the mustache incision is being made first on the left and then on the other side. इसका क्या एनर्जी रखा है? नहीं, ब्लू पेडल में क्या लिखा है? हाँ, ये 180 रखो. So we make this blanching incision using a coagulation mode. This is just to blanch the mucosa. As I said, this prostate will be slightly the patient. So once I do this, I'm now going to start the enucleation process. I don't getting a good view because I am seeing a hazy view here. I'm not really getting a very good view here. The reason and to identify the plane of dissection. You don't need to go very so here you see we have moved about a centimeter away from the verumontanum forwards to identify the capsule. After this, we are going to make our commissurotomy. So it can be here or here. It seems deeper. So we are making the try to follow the same contour of same groove. You see the groove gradually to follow the same groove. Then it will be easiest to make a commissurotomy. Probe about from you. So we gradually proceed from the bladder neck all the way down.
Yeah, while you're
The
doing
bladder
it,
neck.
you go to OT2. OT2, Manoj is probably finishing. Yeah.
Just हो गया ठीक है
पानी देख
can you just push the vaginal wall ठीक है
Are you going for a single lobe or a two lobe technique here?
I think I will do a 2-lobe technique here. I don't want to do a 1-lobe HOLEP. I don't want to do a single en bloc HOLEP because this is a teaching session and it is important to do a procedure which will give confidence to the audience.
Right.
Or wizardry that you want to demonstrate. You want to demonstrate something that others can translate into. So I would rather do a copybook technique or everybody to follow.
Absolutely.
Because already it's 6:30 in the evening, the audience is much less. It's best to do a surgery which
देखो ठीक है
once you have achieved mastery over these procedures, you can omit 1 or 2 commissurotomies and make an en bloc HOLEP depending upon the situation. But otherwise, the typical surgery is to do a
section.
Here, as you can see, I'm gradually erasing. A little bit upwards so that I maintain the full contour of the bladder neck. It is important to maintain the bladder neck so that you have enough length of trigone.
Momentum should be between both these here now.
Important things about contour.
चलो
Trigone.
थोड़ा ये करो लूज करो
Yeah. TURPs where the trigone has been erased, those patients have a lot of urgency. The trigone is very important in preventing urgency. So that's the reason why we try to at the level of the trigone, keeping the scope. So I'm moving gradually from bladder neck towards the verumontanum. Out. Hazy लग रहा है ना?
What is that? Anatomical fimbria, I will say. This is the fimbria. And these are the ovary. Okay.
Yeah. So this commissurotomy that we have made, we are gradually deepening it to separate the 2 lobes away. We are separating the middle lobe from the left lateral lobe. And in the process, we are also widening the bladder neck. I prefer making the midline
Sure.
So that I know that the ureteric orifices have been well visualized and have been protected. So that's why I would recommend that you should do this commissurotomy first, because it gives you the confidence. The 2 important structures are ureteric orifices. Just everything can be discarded. So here we are coming to the end of the mustache, towards the mustache incision. Now I'm working towards the middle lobe and gradually separating the middle lobe. Let me remove these clots. It will improve the vision.
No. You-
Now I'm working.
Bus. Can you hear me?
Yes, we are with you now.
Yeah, I've already closed the bladder and the vagina. And the bladder gets saline. So there is no leak.
The video is not good, actually. Looks like more a 3D like thing.
3D is going up perhaps. Okay, can you just do end of view? Can you put the end of view in auditorium?
Hold these, na?
As per view, 3D is being
खोल दीजिए ना, क्यों ऐसे कर रहे हो? वाटर चलने दो। Here, just stay superficial.
Yeah, I've filled a little bit saline now. So no
We'll
leak.
be back with you. We're just going to the other OT for the concluding the laparoscopic repair.
Hello.
Sir, we are with you, sir. Manoj, sir.
Yeah. So now
We're with you now.
end and the vaginal end both have filled the bladder with saline. There is no leak at all right now. So I'm just planning to put a drain and come out. I'm not planning to put any momental reinforcement. I'm not going to do.
Fine.
Hello?
Couldn't find a good momentum, maybe. Actually, if the vagina and bladder are well separated, see the anterior wall of the vagina to a distance, then probably you don't need an interpreter. Probably it's not necessary. If you find one good enough, but the separation is important.
Yes.
Good anterior vaginal wall portion. Where is OT2 gone now? Where-
नहीं मत बढ़ाओ, ये ऑलरेडी ये बहुत वाइब्रेट हो रहा है यहाँ।
Yeah, sure. So I'm concluding here. The repair has been done.
OT2 audio is
drain.
video. Yeah. Audio visual, can you please look into it?
Can you give me instructions? So your voice is not clear.
किसी को समझ में
Give
नहीं
us
आई।
OT2, please.
हाँ, वो तो ठीक है।
Manoj, sir, we are not getting any feed from OT2. We are able to hear you, but we are not getting any feed.
Can somebody ask for end of view?
देखो इतने लाइंस आ रहे हैं ना।
प्रकार दीजिए फाइल में।
OT2, please come in. We haven't got the video. Not yet.
The diabetic, the old obese patient.
वही से
Yeah, Manoj, we are with you now.
Yeah.
It
Sir,
looks
I have repaired a vaginal. No.
Yeah, we coagulated, but I'm not
There is no leak. I'm planning to just to put a drain
and the important thing is you
so
just
only
don't
one thing I believe.
blunt
No,
dissection, just
uh,
elevate and cut.
repair is good.
Elevate and cut. So then it will
I
come on.
don't think
I'm elevating and this I'm cutting so that there is automatic hemostasis. See, I'm working at the level of the bladder neck.
Manoj, you'll be concluding now just putting a drain. Is that right?
We have a good vision. So you'll be able to
Manoj?
see nicely.
Manoj, can you hear us?
Yeah, I'm just putting a drain only. That's it. That's it. Sir.
Thank you. Well done. Excellent demonstration.
There's the Veru. Okay.
Cheers from the audience. Thank you very much. Now we go to OT1.
Which is OT1?
Well, we are with you now. OT1. Magnify the OT1, please.
So OT3. Gopal Krishnan sir, we are with you, sir.
Oh, I see. Okay, this is OT1. Okay.
Yeah, make a good.
Well, I'm working. I'm sorry, there is a bit of, you can see the lines on the screen.
Yes, a lot of
That
interest.
happens. I believe that whenever you use a laser with a camera system which has CMOS technology, this will happen. So Olympus is CMOS technology. Stores is not CMOS technology. So that's why when I do this, using the stores camera system, there is no line formation like this. So what I'm doing here, I apologize for this disturbance. So each time I elevate the lobe and I'm enucleating, I'm always coming back to the bladder neck. The bladder neck is the end point where you see the bladder. So always in holmium laser, it is possible to get lost. So always you define an end point. So you come back to it after every move. So here I've gradually enucleated this, what is this called? Middle lobe and right lateral lobe. And this is the verumontanum. You can see there is tissue beyond it, which we have also enucleated. This is the veru. There is tissue beyond it. We have come behind it to enucleate the entire prostate. Actually, my laser beam I'm firing in front of the veru. Enucleate the prostate in its entirety, you will be able to scoop it out. And you will not have to fire the laser beyond the veru.
As the quantum
So if there is tissue beyond the veru, it really does not matter. The whole
has Quanta got a different pedal for coagulation as well?
Yes, yeah, left and right, yes. I'm using the setting on a little bit of a higher pulse for hemostasis, because as I told you, this is a vascular prostate. So now you can see this has been enucleated, it is hanging from the roof.
Yeah.
This is hanging from the roof. So I will be able to make this incision. You can see the groove very nicely.
The plane is coming out nicely.
You can see the groove very nicely. So you leave a little bit of tissue in the roof and you just incise the mucosa. You can see the prostate hanging down. So I'm making this incision to drop it down further. Let me clean the lens. I'll give you a better view. And so you just stay in this plane and you cut in with a low power so that you have good control. Incise the mucosa. I have not yet made the midline commissuratomy here. So I just want to enucleate this some more. I'm going from below upwards as much as possible, staying in the same plane. Because I just want to drop the prostate down. This is a favorable plane, so I'm just continuing to be in this plane.
Capsule is coming out nicely.
If I have problem in this plane, then make a separate incision somewhere else. But since I'm progressing nicely, so I'm just continuing in this plane. I'm going below upwards.
Do you intend to keep a small strip in the anterior?
Yes, that's right. There will be a small mucosal strip anteriorly to preserve the veru, to preserve the sphincter. So that is called low apical release. So here, as you can see, I'm going from below upwards and I'm progressively enucleating the prostate. So it is important to try and drop down the prostate as much as possible before you make your anterior incision. So that is what I'm doing. I'm progressing in this plane as much as it allows me.
Dr. Gopalakrishna, hello.
Normally, if you use a different optical source like
Hello. Can you hear me? Hello. Hello. Can you hear me? OT, Dr. Gopalakrishna?
Yes, I can hear you.
Suppose there is a question, some institution wants to purchase one machine. Which energy you want? Which energy you will advise? HOLEP or THULEP? Hello. Hello.
There is too much vibration.
Hello.
So see, I'm gradually dropping the prostate up, hanging down. This is the anterior part, which I'm now going to incise. Let me clean the lens once again.
There's a question. Can you hear me?
Yes.
There's a question that if an institution wants to buy a laser, which energy would you advise, HOLEP or THULEP? The holmium or thulium?
Well, you see, this appears the capsule that you see here, this white.
Yes, we can see that.
You will never see in any other energy source.
Right.
Moves like a ball. This you will never see with any other energy source. In any other energy source, you are cutting through tissue. Here you are not cutting through tissue. You are just elevating the prostate and you are cutting the fibers that attach it to the capsule. So this whitish appearance you will never see with any other energy source.
Even thulium gives a yellow.
Yellow appearance. So I would always say is an art which you need to learn. I think enucleation is easier to learn by holmium because you can see the capsule so much better and you can appreciate the capsule better. In case of other energy sources, you tend to shortcut and you tend to cheat yourself. True. But in case of holmium, you can't do that. This will be in front of you. If you leave behind tissue, you will see it. So see, this lobe is gradually getting enucleated away. You can anteriorly. Here leaving behind a little bit of tissue. This tissue I'm leaving behind and I'm cutting here.
Yeah, we can see that.
Patient is bucking.
Most of the laser resectionists feel that holmium is certainly the better energy for prostates, whereas the thulium laser fiber is for the stone. It's brilliant.
So see here you can see the fibers so nicely, and you know where exactly you have to cut in order to drop down the prostate. I'm really sorry about this screen, but then
we are comfortable actually. There are few
you will be able to see this layer very nicely, and you will be able to see the tissue, the prostate falling down.
Yeah, and the capsules are coming out nicely.
Yes.
That's important.
So I was working on a slow frequency just for the near the Veru, but now that I've moved beyond the Veru, now I'm going to go fast again. So I'm still moving from below upwards. And I'm dropping the prostate further down. So if this incision is favorable, just keep going. Keep going in the same plane as long as it doesn't stop you. So since I'm not being stopped, I'm continuing to go in this plane. Until I can go no further, then I will start opening another plane. And that is why I said yourself whether you're going to do 1 lobe, 2 lobe, or 3 lobe. The way the prostate plays out in front of you, you play accordingly. And whenever you are in a problem, make extra incisions. That is either from 2 lobe, you come down to 3 lobe, whatever. If your prostate is very big, then do a 3 lobe technique. Just divide the prostate into segments because each segment is easier for you to handle. So there is no need for you to do a 1 lobe polyp from the beginning.
This capsule is coming out nicely, but this is the place where you find difficulty if there's a chronic prostatitis.
Yes. So you can see that I'm slowly dropping prostate from below upwards and until the prostate is just hanging from the roof. See, the prostate is just hanging from the roof. So it's very easy to now cut this and drop down the right lobe. And I'm well away from the sphincter.
Apart from the heat energy, there is sometimes a traction injury in the sphincter area, which can cause incontinence.
Yes. So you see this lobe is basically falling away from the sphincter. So I'm cutting only on the lobe. So the sphincter is far away.
Right.
So here it is. At the anterior part, which people say is the most difficult part. See, the prostate is just falling down and showing you the plane. So I'm just cutting through the natural plane that is already being visualized. That is the midline. So as I said, I'm doing a 2-lobe HOLEP. So I'm now going to divide this tissue.
So this is the junction of the anterior commissure lateral lobe.
Yes. So you may have seen sometimes that incision made at the midline superiorly, this incision, but this incision I'm making from Veru towards the bladder neck. And in the process, the prostate is gradually dropping down. So therefore, everything is under vision. There is minimal chance of you overshooting the Veru. See, this is how nicely it dropped down, and it is showing you the through. This is a lobe. See, this lobe is already moved the roof. So I'm just going to cut along this line. So I'm separating the right lobe from its superior attachments progressively forwards towards the bladder neck. And regarding the hertz that you use, I am using 30 hertz. That is supposed to be a slow speed, but actually we are not slow. It's like driving a car. If you are in a crowded street, then there is no point driving your car at 60 kilometers per hour. You will still find that you reach the destination at the right time. It is important not to cause any accident. Is fast. So the joules decides how you want to cut the prostate, and the hertz decides with what speed is comfortable for you. So since I wanted good control, that's why I've chosen a slower speed, but still I'm moving reasonably okay. So just because your car shows the maximum speed of 2 kilometers per hour, you don't drive your car at 240. You drive it at the speed that you feel is safe. You see this. At this point, you must detach it just where it touches the bladder in the fixed part. Don't cut it here. Cut it here, just where it touches the bladder. It is easy to detach it from here. So we are in the final stages of detachment of this lobe. So this lobe has been detached into the bladder. Now we will do a little bit of hemostasis before we move to the other side. So we spend few minutes on hemostasis and also to remove small tissue islands that may be have been left behind. So here you see, this is the Veru. We have come beyond the Veru. but we have not used energy beyond the Veru. We have enucleated the prostate completely. So you see, it has come out in one go. That is the ring. There is no tissue superiorly to protect the Veru. Actually is not causing any obstruction. So I don't cut it. I am now going to remove the scope and use some jelly before I go in again. Jelly. Once again, to recap, we have finished the right lobe. That is the capsule seen very nicely. There are no capsular perforations. There's no tissue behind. Just a little bleeder, which we are now going to coagulate before we go to the other side. So if you perforations of the end. So having done this, we also have a look at the ureteric orifice. There is the orifice. See what I told you, it is important to preserve this length of trigone. As you can see here, we have preserved almost good 1 to 1.5 centimeters of trigone, and that is very important for continence. So now we are now in the process of enucleating the opposite lobe. We are
Dr. Gopal Krishnan.
and you can appreciate very nicely the capsular fibers, and how easy it is to just lift it up and cut. So the motto is elevate and cut. Do not do blunt dissection.
So no role of the resectoscope here, of pushing it or using the resectoscope, which initially everybody thought it will hasten up the enucleation. That concept is gone. So you don't push or pull anything.
So if you do blunt dissection, what happens is that it peels off maybe quite easily, but then certain bleeders will open up.
Yeah.
So therefore, it is better to go slowly, just elevate and cut. The beak of the resectoscope is used to elevate the lobe, and you can see the fibers very nicely, and you can cut. And as you progressively move towards the bladder neck, that is the end point. If you're in the middle of the prostate, you sometimes get lost. So always move towards an end point. So this is where the prostate is beginning to turn. So this turn, I prefer to do it from below upwards rather than from above below. See, the beak of the resectoscope just allows you to elevate the prostate along the turn of the prostate as the prostate just ends. So try not to cut through prostate. Sometimes it is our thought, especially at the Veru, that in order to preserve continence, that we cut through prostate at the apex. At this apex, we sometimes cut through prostate just to preserve the Veru, but don't do that. That actually makes things worse. try to go right to the end of the prostate and just elevate it, and it will automatically see how it just enucleates in its own plane, as if you are using your finger. And you are actually firing your laser in front of the Vero, not behind the Vero. So you will never have any incontinence. And if you can enucleate the prostate in one go, then you don't have to again go back and remove prostate near the Vero. So see, it just enucleates on its own. You can see the end of, see how the lobe is turning. And see, and just heals itself. So I'm still going from below upwards. If I had problem here, then I would go from above below. Let's see, I'm going from below upwards.
So Gopalda, you never give the commisurative incision. Gopalda?
See how it is peeling off so nicely. You can see the place where the prostate ends, and then you can just cut the fibers.
Yes, sir, we can see it clearly, sir.
And this cutting is actually in front of the Vero, so will not cause any incontinence. See, you can see how the prostate turns. And this is the entire lobe, so there is nothing left behind beyond this. See, the round of the prostate is just turning in your beak and is just falling away. And always make these semicircular incisions. Don't go on enucleating in one place. Go from one, sort of go make a big arc. The bigger the arc you make, the safer you are, because then you can never go deep at one point. So see, I'm trying to make as big an arc as possible. Starting from here, going all the way up, all the way up, all the way up, still, all the way up till here. Again, I will come down. So try to make these long arcs. And all the time staying close to the prostate. See, I saw a bleeder here. I will not go here. I will go here. Staying close to the prostate, between the yellow and the white. And as I said, it's not necessary to enucleate at 50 speed if you're not comfortable with it. You can jolly well use 30 speed or 35 speed. And as you become more and more confident, you can increase your speed. So it's just like driving a car. When you become confident with driving the car, then you drive at a higher speed. Or if you're on the highway, then you drive at 80. Here, the highway is a place which is away from, when you're away from the Veru, then you are in a safe zone, you can use a higher frequency. But when you are near the Veru, you want to be careful. So use a lower frequency. So see, I'm just making these long arcs. And each time my end point is the bladder. I want to see, oh yeah, I can see the bladder. That means I'm safe. So as I did on the other side, I'm going from below upwards. I have not yet made any midline incision at the roof. The time to know where you stand. So now the situation you can see here is that this lobe is falling from the top again, and this is what is holding it back here. You can see this groove very nicely. So I can actually cut in this groove. I can see the groove very nicely where the prostate is ending. So I'm not leaving behind any prostate lobe at all. I am not cutting through prostate. See, by the weight of the prostate, it is automatically falling down, and it's very easy, and it is opening up the tissue plane. So you see the prostate, how it is falling down, and this is the line. So I need to cut in this line. The line is automatically displayed. So I will just go through this line. The prostate is falling down by its own weight.
Yes, sir, we can see you. Apart from some disturbances on the screen, it is actually very well visible. We can see the plane nicely, sir.
As I said, there's a bit of a vascular prostate. So the mucosa is vascular. It's not the prostate that is vascular, it's the mucosa that is vascular. That is why when you make the mucosal incisions, use a little lower energy, use coagulative settings. Sometimes if a bleeder refuses to stop, don't worry. Carry on in the other places and detach the prostate so that that bleeder can retract. When you're applying traction on the prostate, that bleeder remains open. It is like the DVC. Similar to the DVC, as soon as you detach the prostate, DVC bleeding stops. So here also, if you have a bleeder that refuses to stop, just carry on, detach the prostate from that area, then the bleeder will retract. So I'm gradually dropping it from the roof. I'm working on other areas and then I'll go to the bleeder area. So I've left that bleeder area for a while and I'm working on a different area. Then I'll go back to it. I'm again going progressively from below upwards, detaching the prostate from below upwards. It is shivering. Unfortunately, HOLEP is a surgery that you need to observe standing beside the surgeon. Unlike laparoscopic surgery, where you can see in a workshop in the hall, HOLEP is a surgery where you need to stand beside the surgeon and see his hand movements and everything. Only then you will appreciate better. So I want to stop that bleeding. So I'm going to empty the bladder first. Often emptying the bladder helps you to achieve hemostasis. In a full bladder, the vessels open up more. So this is just the attachment at the level of the veru, just the mucosal attachment. The lobe has almost moved away. So here is the lobe falling from the roof. And this is the plane in which we need to go. So this is a retrograde method of enucleation, where we go from the veru towards the bladder neck. I'm constantly moving from the veru towards the bladder neck. So there is no chance of overshooting and cutting beyond the veru. And in the process, the prostate is gradually dropping down from the roof. In fact, the prostate is just dropping by its own weight. Is moving. Not pulse. All along, I was using a longer pulse. Short pulse, so that I can cut faster. So this is the prostate again. Again, we have detached it from below. It is just hanging from the roof. I think you can appreciate that better. It's hanging from the roof. अरे इतना लाइन होने से is shivering. Shivering के कारण और भी कैमरा क्लीन करो.
सर्दी लग रहा है ठंडा लग रहा है गर्म हवा दे रहा हूँ ठीक है हाँ अभी नहीं लगेगा ठीक है
Which year are you resident? Okay. Okay, okay. So you should be able to do left. हाँ तो करो. You should be able to do it. करते करते ही सीख जाओगे. And do all small prostate, big prostate, everything. Don't reserve only for big prostate. You must do all sizes. Start with small prostate. Then only you will get the confidence. हाँ अभी डालते हैं. And when you do 20-30 gram prostates, then you will understand the capsule, how it looks. Then you will be able to do bigger prostates. इतना ये लॉन्ग पल्स फिर से कर दो यार, ये तो बहुत हिल रहा है। ये तो बहुत वाइब्रेशन हो रहा है। हाँ ठीक है, नहीं अभी भी लॉन्ग पल्स, शॉर्ट पल्स में ठहरो, करो। नहीं अभी भी शॉर्ट पल्स में। उसको बुलाओ, वो कर देगा। लॉन्ग पल्स का तो बहुत वाइब्रेशन हो रहा है यहाँ स्क्रीन पे। पानी, पानी एक बंद क्यों रखा है रे? हाँ लगाओ चलिए। एक ग्लाइसिन लगा दो और एक रोलर बॉल लगा दो। हाँ सर, जस्ट पुट अ रोलर बॉल फॉर अ मिनट। रोलर बॉल, लेट्स सी। इसका नहीं है ना, इसका।
सर इनर से जो क्या हुआ था ना सर,
हाँ
सर बोल रहे थे तो इसकी वजह से वो
समझ गए, समझ गए, समझ गए। Modulator ready? Modulator. भी थोड़ा हेमोस्टेसिस कर लेते हैं फिर।
Sir, what size criteria do you follow for HOLEP, sir? Sir, can you hear me, sir?
Yes, I can hear you.
Sir, what size criteria do you follow for HOLEP? Prostate
There
glands
is no size criteria
for smaller glands also, sir?
that you feel comfortable with, that you can tackle. If the size is bigger, then you break it up into 3 lobes to make it comfortable for you. Don't do a single lobe HOLEP, because then after some time you lose sense of where you are. So if it's a big prostate, then make it into 3 lobes. Remove the middle lobe. The moment you remove the middle lobe, what will happen is water flow will become better. If you remember in TURP, the reason why we say to do the middle lobe first is basically to allow water inflow and out much better. So similarly, if you do the middle lobe first, then number one, you gain confidence, water inflow, outflow becomes better, and then you just have then 2 lateral lobes to tackle. So there is no size criteria. And I think if you want to learn HOLEP, you must start doing everything by HOLEP, whether it's 20 gram, 30 gram, 50, 60. It's important to understand the contours of the prostate and to know how the prostate turns and how the prostate plays around in your hand before you start doing bigger HOLEPs. So if you want to learn HOLEP, then don't reserve your for every case.
So would you advise to start with such a small glands at 20-30 gram, or should we start with ideally with?
Yeah, you start with small grams. If suppose you are not getting a small prostate, you are getting only then what you do is you do one lobe by HOLEP. And if you find that you are taking time, then you do the other lobe by TURP.
Yes, sir.
So therefore, gradually you increase your confidence. But you must do everything by HOLEP. And very important, which I've always said, keep enough time. When you are learning something, don't be in a rush. Don't keep 5 cases on the list. Keep at least 2.5 hours for a HOLEP so that you are not in a rush. Then only you will be able to learn better. You can't expect to complete a HOLEP within 40 minutes and then go on to do the next case. So if you want to learn something, then you must give time for it. Just as in laparoscopy. So see, once the prostate has been removed, now the hemostasis is slightly easier. We are focusing on hemostasis.
Dada, Manoj here.
Situations, if it's not a bad idea to take a roller ball and just run it over the surface of the prostate to get a good hemostasis. So don't think that it is a defeat of your procedure. I do not shy away from sometimes using a roller ball just to achieve a good hemostasis before I do the morcellation. You see, all this bleeding will stop if you put in a catheter, but you need a good vision mainly for your morcellation. So if it becomes necessary, you can use a bit of ball coagulation before you go on to morcellation. So you see, this was the little tissue that I left behind in the roof, but it is very little. It's not even protruding into the fossa. Many times we...
Hello. Hello.
Clear part and make sure that start the morcellation.
Gopal da, Manoj here. Am I audible?
Yes, Manoj.
Hello. Hello. Can somebody unmute Gopal da?
Yes, Manoj, hear me.
Yeah. Actually, Gopal da, you told regarding that preserving the trigon area. Do we feel that
Not
just
able to hear you.
you told about the preserving the trigon area, some portion of the trigon area. Do we feel that preserving the trigon area will reduce some irritative symptoms as it is?
Pardon, tell me again, please.
You told regarding the preserving of trigon area while resection.
क्या बोल रहे हैं? See, this is the capsule. There's no tissue anywhere. If you remove the prostate completely at the level of the veru, then you will find that the whole fossa, there'll be nothing left there. Can let me get a better vision for you. Yeah, wash, please. Manoj, I could not hear your question at all. I'm sorry.
Yeah, now are you, is it audible?
Yes.
Yeah, actually you told regarding the preserving the trigon area.
Yes.
Yeah. Do you feel that by preserving that particular area, it is reducing the irritative symptoms? What was expected in particularly when laser, when you are using laser surgery, that increases?
I think you were asking something about preserving the trigone area.
Yeah.
Yes.
Do you feel that the irritative symptoms are less by preserving that area?
Yes, that's right. The trigone is responsible for irritative symptoms. So you can have urge incontinence if you remove the trigone or if you erase the trigone. That's why it is very important to preserve the trigonal area. As you can see here, this is the bladder neck, and then we have this is the. I'll show you the ureteric orifices. This is the interuretary ridge. This is the orifice. So we have preserved almost 2 centimeter of trigone, and that is very important for continence.
Yes, it's clearly visible. So what is your experience in regard to bladder neck contracture after doing OLIP?
Bladder neck contracture with HOLEP.
Yeah.
But it is very minimal.
As I can see that you have removed all around the bladder neck.
Yes.
But traditional
Actually, bladder neck contracture happens more when you leave behind some tissue at the bladder neck.
Is it? So it is the traditional teaching is that when you are doing TRP, you need to leave some area in the 12 o'clock area so that it will prevent bladder neck contracture.
Yes.
In contrary to that, you have told it is not required.
So just little bits of tissue anterior. They are actually very small. You may choose to leave them, or you may choose to just remove these little islands of tissue.
You are just smoothening it. It's already.
That's right. It's not really necessary. This is not going to alter his voiding parameters. It is only for the surgeon's satisfaction.
Correct.
This is the roof. There is just little bit tissue here. Really doesn't matter. Now we're going to start enucleation. Start morcellation. Yeah. Jelly. What's the time?
7.
Okay, morcelloscope. Morcelloscope. Yeah. Inner sheath. ये पकड़ लो। तो क्लीन करो।
अजीब वजह से तो सीवी आया है देखो ना ग्रुप पे अजीब वजह
ठीक है होगा वैसे हो ऐसे इस रिंग को
वो जो ब्लैक होल में डॉट है वो नीचे जाना चाहिए।
अच्छा अच्छा ठीक है पानी चलाओ दो पानी दोनों दो पानी चलाओ दो 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 एक और दो पानी चलाओ यस पेडल प्लीज पेडल Yeah. Can you see this morcelloscope? If anybody can see this morcelloscope, let me know. शायद ऑडियंस में कोई नहीं है।
Sir, yes, sir.
Hello. This side is the cutting side. That is why this morcelloscope is associated with less chance of bladder injury. Whereas with the luminous versa cut, that is a guillotine type, that's an open blade. That is why bladder injury is more common with that. In this case, you see this side is blunt, closed. So, see, this is upward cutting. If you want, you can also do downward cutting. You can turn it around and you can also do downward cutting like this.
It's like side firing.
Yeah. Some people say this inverse cutting is safer because this tissue is always touching the scope. Water, please. Secondly, you see, this morcelloscope has got teeth. This see, whereas the luminous type that does not have teeth. That is why this cuts faster than that. The morcellation efficiency of this piranha type is better than the other type. This teeth help to cut better. That's why more tissue comes out per minute. And you must always see the tissue dancing in front of you. If the tissue is dancing in front of you, then you know it's mobile. If you touch bladder mucosa, then bladder mucosa will not move. And in the background, you should be able to see black. Black means the bladder, means the bladder is far away. क्या एंटीबायोटिक मिला है? क्या एंटीबायोटिक मिला है? This pre-op culture was normal. Because he was on catheter, isn't it? That's why. slow speed, so that the tissue doesn't fly away. टिश्यू आ रहा है वहां पे? हाँ सर, क्या हुआ? When you finish, always come into the fossa once, just to make sure there's no tissue there. Suck out the blood clots from the fossa. Okay, ठीक है. इसमें tissue भी नहीं. Hold it, please. Catheter 18 3 way. हाँ 24. इससे पता नहीं 23 ले रहे 23 वे 2 वे तो नहीं है 3 वे चाहिए 3 वे का क्या है
22 कितना छोटा चाहिए 24 আছে আর ছোট আছে কিছু ডিফারেন্ট
पानी चला 20, then give 20. 20. हाँ 23 हाँ Do you have a forceps? Do you have a PCNL forceps to remove this tissue? Airway चला airway देना है airway देना है airway दोनों दोनों airway देना है वॉश टिश्यू को पकड़ेंगे. Seasonal forceps है क्या? बाइप्रॉन ही चाहिए. What did you mean that it is good? Yeah, because I could see this white tissue floating around. More so at the when you empty the bladder. Look at this very slowly so that it doesn't fly away.
सर इसमें disease है 100 है कि
नहीं यहाँ से foot pedal से.
सर वहाँ ऐसा 5 में सेट किया हुआ है.
हाँ. That is the maximum speed. See, these are all balls that have formed. हाँ देखो, वो seasonal forceps से वो निकल जाएगा. निकला है कि नहीं निकला? These small balls. फोर्सेप्स होने से उसको निकल. ठीक है, ऐसे ही वॉश तक हो जाएगा. ऐसे वॉश तक हो जाएगा. वॉश देना, कोई बात नहीं, ऐसे भर लूंगा. I get it. Okay. Yeah, catheter. Jelly. Thank you.
Subtractions में
हल्का. और 15 दे दो.
कलर दिख रहे हैं ना, कैसे दिख रहे हैं सर? सर देखिए पोली का कलर देखिए,
वही
वहाँ
तो।
वहाँ पे कलर देखिए। पूरा
हाँ
glaze was coming from the laser fiber and from the other space.
दादा स्पेस कलर ठीक है ना?
हाँ बढ़िया सर। ये actually लाइट का है वहाँ से पूरा पुलिस रेड दिख रहा है।
ठीक
रेड पूरा
चलो बैग दे दो। ठीक है हो गया मनोज, थैंक यू। सॉरी
you,
फॉर द
sir.
लेट नाइट शो।
No issues, sir. Thank you for excellent demonstration, sir.
ठीक है
सर्जन बिना करे जाए ना और मरीज के लिए अच्छा एक्सपर्ट के हाथ में हुआ, हम लोग का पाइप लग।
हाँ तो वो भी इसमें क्या कमी है? ये स्कोप बहुत अच्छा है। Very nice. Thank you.
सर कर लेंगे सर ये थोड़ा सा देंगे ऐसा करते हैं फोन ले
बस ठीक है सैली लगा दो।
सर इधर से कंफर्म
Sir, anyone from OT3? OT3? না ঠিক আছে অপেলা তো হ্যাঁ ঠিক আছে ঠিক আছে